Morning, one and all. For the first session today, the wrist case presentations, we would like to call upon Dr. Anil Bhatt and Dr. Mallikarjuna Swamy to chair the session.
Yeah, please start.
Good morning, sir. I am Monish, second year PG from St. John's Medical College. Today I am presenting the case of Shibu, who is a 24-year-old male who came with complaints of tenderness over his wrist since the past 9 months. The pain started suddenly when he tried to lift a heavy can of water about 9 months ago, which was a sharp pain located over the inner aspect of his wrist. Since then, the pain is continuous, which is present on and off. And the pain, he says, aggravates whenever he uses his right hand to do any activity. And also, it aggravates when he does rotatory movement of his right forearms. The pain is also associated with what he says as a weakness of his right hand, wherein he is unable to grip objects as good as his left hands. Then on examination of his right wrist, sir, there is a
no, is the pain is the only complaint?
Pain and slight weakness on of gripping the object.
What is weakness?
So whenever, like, the hand, whenever he tries to grip objects, yes.
What does he do?
He's a office laborer where he works in an office where he does labor work wherever.
Like what?
He tells he works in a company office where he transports stuff from place A to place B in the office, like a ward boy kind of jobs.
क्या करते हैं वहाँ पे? क्या? पैंट्री में वजन उठाना पड़ता है? हाँ? कितना वजन? ज़्यादा नहीं? हाँ. Yeah. So what exactly? See, in a wrist, because again, see, like hip, we all say hip is a weight-bearing joint, knee is a weight-bearing joint. In upper limb, wrist is the most weight-bearing joint. Okay, the entire weight transfers through the wrist first. So it is a weight-bearing joint in that sense. So when somebody comes with pain, you should be asking a little more details on that, so that you get an idea of. So you say, again, you use tenderness, rotatory movements, all those are very technical terms during history.
In the history.
Okay. What is rotatory movement? What is his expression in that?
So he told the pain aggravates when he does this. When he's unable to do this movement because it pains.
So in his day-to-day work, what does he, like does he turn a tap? You know, does he tighten something? He could be in the pantry tightening a cylinder cap. You know, those are the ones which classically they say is very painful. So those are the things you need to be asking. What exactly does he do in terms of work? सिर्फ वजन उठाते या पुश करते या हाँ वो छोड़ दिया पहले इसके पहले क्या किया ये हाँ ओके पुश करना पड़ता है ट्रॉली कुछ नहीं हाउस कीपिंग का जॉब ओके one of the other things would be people coming with classic history of lifting weights, gym and things like that. So they, again, when they do that, they get pain. So exact activity, please try to get it. Is which hand dominant?
He's right hand dominant.
Okay. And if you get a wrist case, you first at least try to identify by the history where is the pain, which side of the. So there are straight away if I have to come to the diagnosis, I have in mind, is it radial sided pain, ulnar sided pain, central pain, or a diffuse pain. Okay, this is how you have to start thinking. So you can ask questions, leading questions to the patient, which side of this. So you don't have to tell in the history, he's got an ulnar sided pain. But you can say it is on this side of the wrist or something. So where is the pain?
On the inner side of his wrist.
So that straight away narrows your diagnosis so much. And ulnar sided pain means we know some classic or very common diagnosis. Radial sided pain, we know straight away what are those things. So at least try to get that area of pain first. Okay.
किधर दर्द होता है आपके लिए?
So he shows very clearly, he shows on the hand ಎಲ್ಲ ಬರಲ್ಲ ಸರ್ ಅವರು ಹ್ಯಾಂಡ್ ಓವರ್ ಮಾಡಿಬಿಡ್ತಾರೆ. So that is an important aspect. Which area of the pain straight away gives you a lot of diagnosis. So that is how you should be presenting. Okay, but again, don't use technical terms or like the medical terms. Just tell it's on the inner side, on this side. Okay, go ahead. Right?
Middle, dorsum, arvola, whatever it may.
Okay.
Inner side, outer side, middle.
Yeah.
Don't use your anatomical terminology.
Yes.
So what's the duration now?
Since 9 months, sir.
9 months.
Yes.
So what is the disability of the patient now?
He's unable to do work which involves heavy weightlifting, sir.
Then?
And as he said, the rotatory movements which are...
He stopped working? No.
He's continuing the work, but whichever work...
He's modified his work. Exactly, he told that I've stopped that, but he's modified his work.
To avoid heavy weightlifting.
Okay. So get the disability, whether it's hip case or anything, end the history always with the present disability of the patient. How do you assess disability in terms of when you present?
So initially we'll have to see whether his recreational activities are affected. Those are the ones which are affected first, and then his work-related activities, and then his activities
So
of daily living.
it's a 3 zones, like the outermost zone is what we do apart from what we routinely do, in the sense that it could be sports, it could be instruments, it could be so many other things. The next zone is always your daily work. And the inner most important zone is the activities of daily living. So disability, when patient has problems, it will go on reducing from the outer to the inner one. And that is what you need to tell where exactly it has stopped now. So it is a second zone of, right where he has modified the work, but still altered. It's not affecting his activities of daily living at all?
No, sir, it's not.
Okay. कम किया है आपने, कुछ चेंज किया है और कम भी किया है. So he shifted this work. आप इससे ज़्यादा काम नहीं करते. हाँ. So he's a right-hand dominant person. He shifted most of his work, which they do very subconsciously initially, but later on, very consciously, they will avoid the other hand and then do it the opposite, non-dominant hand. That's what happens. A lot of times when patients come to us like a tennis elbow patient, they start developing pain on the other side now, which was asymptomatic because they start overusing the other hand. These are the things you can very nicely present. Okay.
Yes,
so anybody in the audience, ulnar-sided pain, what are the differentials now you can think of based on the history? One by one. One is, then ECU tendinitis, then ulnar, no, there's no trauma, major trauma, anything. So common things, when the OPD, when patient walks and they say pain on this side, the classic, of course, you should be ruling out 2 things, which is the TFCC and ECU tendinitis, common ones. There could be rarer, there's episotriquetral arthritis, so many things are there. But at least these 2 you should keep in mind and try to look for the problem. Plus there could be even a tumor sitting in the ulnar head. Okay, there could be a GCT of ulnar, we don't know. There could be swelling, rheumatoid, so many things. But then these are the common things. Central pain, especially they say central pain here. There could be a ganglion. Anything? Which is the most important bone there in the center? The Keen box, the lunate. Of course, it's a radiological diagnosis, but then you should be keeping that in mind. Radial sided pain, common when patient comes to you in the OPD. Huh? You should rule out everything about scaphoid. It could be old scaphoid non-union, right? Decoherent stenosynovitis. Then elderly patient, if they come. Sir also is only hip, no wrist. Good morning, sir. So elderly patient, CMC arthritis. So go like this, CMC, MCP, CMC, then come down to the wrist, scaphoid and decoherence, 4 things in line. Rarely in CMC patients come with history of trauma and then chronic pain, which could be collateral ligament injuries, ulnar collateral ligament injuries, very commonly missed. These are the commonly missed injuries. That's why they come later. Okay, right?
Yes, sir. Coming to the local examination of his wrist, sir. On inspection, his ulnar styloid is more prominent as compared to the other side. There is no other swelling or deformity that is.
You can't really see an ulnar styloid. So what do you see there?
Distal end of the ulnar. The ulnar head.
Ulnar head.
Ulnar head.
Okay, use the correct. Ulnar styloid, you can't really see it. It's quite deep. So ulnar head is prominent.
Head is more prominent as compared to the others.
Okay.
No other swelling or visible deformity that is seen, sir, and no scars or any discharging sinuses that is seen. On palpation, he's got tenderness present just distal to the ulnar head, which correlates with the tenderness over the TSCC ligaments.
Where is that tenderness?
So just distal to the ulnar head, between the ulnar head and the capitate is there.
Ulnar head and capitate.
Yes, sir.
Where is capitate? Can you show me where is it?
He's got pain here.
So what is the tenderness called? In the entire case, this is the only finding which will clinch your diagnosis. There's nothing else in this case. So you went just distal to the
Head of the ulnar and
so you felt is it a soft spot?
it's a soft spot.
Okay. So what is that called? Anybody? Fovea, the foveal sign. Okay, that's what it's called, the foveal sign. So the boundary is basically there. You have your FCU, you go there, you got the pisiform here, then you have the ulnar styloid, basically the distal end of the ulna. We can't really call that. Okay, and just distal to that, and dorsally you have the ECU. So just in that area is your soft spot. Okay, some people call it ulnar-sided snuff box. Okay, like scaphoid, you have this snuff box here between the tendons, right? Between the first and this one third compartment. So here also you have FCU and ECU, and then pisiform, and then just distal to that is your soft spot. So some people call it ulnar-sided snuff box tenderness or foveal sign. Okay, so you need to be palpating in the deep area, and then when it's tender, it's indicative of probably a TFCC injury. Then carpal bone. If you really talk, then pisiform is not a true carpal bone. It's a sesamoid.
Medially, hamate.
Capitate is in the center. So you have the triquetrum. If you really move the wrist, you will get the triquetrum out. If you do radial deviation, the triquetrum moves out. Then you can, if you push your hand deep inside, you get the triquetrum, and then transmit it to the hamate there. Okay. Then
No local rise of temperature, sir. No other swellings that was palpable around the wrist. Movements of the wrist, only ulnar deviation terminally was painful, sir. All other movements were within normal numbers.
Okay.
Coming to the
Range of motion is full.
he's able to.
No, you need to quantify the range of motion. You can't say everything is normal. Hip case, this case, everything is same. What is the range of motion? Dorsiflexion, palmar flexion, ulnar deviation, radial deviation. Because you're dealing somewhere near the distal radial ulnar joint, you should also add
Pronation and supination.
So tell that.
He's got a dorsiflexion of 0 to 80 degrees, even palmar flexion of 0 to 80 degrees, and radial and ulnar deviation of 0 to 40 degrees. But
that you are bluffing.
0 to 40.
You can't have radial deviation of 40 degrees. Do you have? Ulnar deviation. Is that 40?
20, about 20 degrees.
That is normal. Normal itself is up to 20 max. Which is more, ulnar or radial deviation normally?
Normally ulnar deviation is.
How much is that? Even that won't reach 40 unless you have ligament laxity. Check.
Yes, sir, correct.
Comparable to the opposite side? Or is there any restriction?
It's comparable to the opposite side.
It is comparable to the opposite.
Yes, sir, correct.
There is no restriction.
Yes, sir. Yes. Yes, sir, correct. Yes, sir. It's comparable to the opposite side.
So is it painful?
Yes, sir.
If it's not restricted, is it painful or you said it's painful?
Only terminally it's painful.
Wait. Pronation supination. In this case again most important would be pronation supination.
Yes, sir. His
Can you
pronation
demonstrate the pronation supination?
is heart is
That's a normal. Demonstrate the normal side. Show him what to do.
ऐसे पकड़ के ऐसे करना ऐसे और ऐसे नीचे करो लेफ्ट हैंड ऐसे
Is that correct way to do pronation
has to be-
supination?
ऐसे पकड़ो ऐसे और ऐसे करना ऐसे पूरा
Still not ideal way to show a pronation supination. Why can't you lock the elbow there? Okay. Now you want only the forearm movements. What would you do? Undergraduates are taught how to check pronation supination. You would give them.
put a pen in the
So do all those things. Only one side you will give the pin.
भी दोनों ऐसे रखो दोनों ऐसा करना ऊपर नहीं उठाना ऐसे
When you passively do, how will you do? Can you show me on the normal side? If you want to check. Where will you hold if you really want to get the correct pronation supination?
So we lock his elbow over here and then we hold the wrist.
That might give a lot of false movements if you are going so distally.
At the distal.
Be close to the joint,
Yes.
okay, and only the forearm has to move, nothing else, right?
So ask him to hold the pin little pointing firmly, because if otherwise you twist the hand.
See, this is your dial. This is for you to see.
Right? Dial should be correct.
In any patient who has got a pronation, supination, restriction of any amount, they compensate from two joints, the shoulder and the wrist. So the way you tuck in the arm by the side of the trunk and bend the elbow to 90, less than 90, they might still use some trick movements. So you should tuck it in and elbow 90 strictly and ask him to clench. So if you see the worker's movements, it is this. When you make a fist, there is a natural tendency to lock the wrist position of function for that particular patient. So when you plan for wrist arthrodesis, you ask the patient, normal side, tell him to make a fist firmly. So when you ask him to hold, it's not a limp hold, it's a firm hold, so that the synergistic muscles of the dorsal and the volar side of the wrist, they stabilize the wrist and prevent any false movements of pronation and supination being, they always have a compensation. A congenital pronatous synostosis patient will always have hypermobility of the wrist. So he will move the wrist more. He will manage well because he is used to it from childhood. So you have to lock it in like that. Okay. So both joints you have to prevent any false apparent pronation of sorry, but I
No, exactly.
You
So
please-
that's first thing is, when we see people doing this, I think we get a little bit worked up because first thing is lock it
Lock,
nicely.
yeah.
Keep that straight so that you see the exact movements which is happening, right? And then he's giving you the answer. The moment you ask him to supinate, he's getting pain.
Pain.
That itself is another part of the exam, another test actually which you're supposed to do, which is a resistant supination. The moment you do that, they get pain because the TFCC is now stretched out. Okay, so that also is one part of the test. Okay, so अभी दर्द है? Now he gets the pain. Okay, that is one thing. The other thing is, so you have the fovea here, you have the ulnar head, you have the FCU, this is the ECU, this is the pisiform here, just here. If you really push this out, you'll get a triquid form. So this is a soft spot for you for your fovea. The moment I press that, he will get the pain there. Okay, so that is one side. Next is resisted supination. You got that. Third is what is called, it's got a lot of crepitus. You didn't tell that there's a click, there's a crepitus here.
One more
Then
test.
what we do is called the grinding test. Okay, we do the radial side grinding test and we do the ulnar side grinding test, and it is not specific for anything. It just says there's a problem on the ulnar side. Okay, if the grinding test is positive. Okay, but then you add the foveal side, you add the resistant supination, then you come to the ballotment. Okay, so ballotment, piano key sign people show like this, but sometimes it's not possible unless there's a lot of laxity here. The ulnar head is prominent here. The ideal way is stabilize the radial column like this, then you palpate this. Already there's crepitus, he has
Crepitus.
abhidharma. So you see this in neutral position, supination and pronation. So if you can see, I don't know whether you can appreciate, this is neutral. The moment it goes to supination, he has pain, but it gets, the ulnar side head down is not prominent. Okay, it's almost in line. When I do the pronation,
It becomes
it is becoming much more prominent. So which tells you, see, in the pronation, it's becoming very prominent. It tells you that it is unstable. So this is the actual ballotment which you're supposed to do. Okay, piano key sign, people show this when it is very unstable. Remember wrist, in the knee, when we say instability, you talk of giving way, the patient feel buckles and all. Wrist instability or carpal instability is actually it becomes stiff. Okay, it's the contradiction of that. When you say instability, actually the wrist is actually stiff. So you have to get out that instability by these tests. So these are at least the four tests you have to do for a DFCC. Foveal sign, resisted supination, ulnar grind, ballotment.
ballotment.
Okay.
Yes.
ECU, tendinitis, how do you? Any specific test for ECU tendinitis? Those are the common differentials you have in this patient. Any tendinitis, what will you do?
Stretch.
Huh?
Any
Any tendinitis anywhere in the body, what is the basic principle of eliciting the sign?
stretching of the ligament would cause.
Not ligament, tendon.
Stretching of the tendon will cause. Tendon.
So, if there's a flexor tenosynovitis, what will you do? The movement of the tendon, you should do something. The opposite of it, you should do something. direct tenderness, second is stretching, third is ask the tendon, make the tendon to contract and then find out.
So if you give resistance to the tendon in the direction of its movement, it becomes painful. If you stretch the tendon to the opposite side, it becomes painful. Right? Like if you have a flexor tenosynovitis, if you ask the patient to flex and you give resistance, and it's acting against resistance, obviously it becomes painful because it's inflamed. If you stretch it out, as in extend the finger, then also it becomes painful. And there's local tenderness. So in a suppurative kind of tenosynovitis, for that example, there are classic signs called cannibal signs. Okay, so that is a different way, but then the principle is the same. So here also same thing. If you have a ECU tendinitis, what will you do?
Ask to extend against resistance. And
You will ask the patient to extend and ulnar deviate against resistance. If you do a radial deviation, patient gets pain. That's called as a synergy test. You just radially deviate like this, patient will get severe pain on the entire muscle. And locally you will feel the tenderness all along the tendon. There might be swelling also. You should add up those things. So you might just have ECU tendinitis for all you know. So you should rule out that. Can you rule out that?
अभी ऐसे करो, इस तरफ कुछ दर्द है? नहीं, अभी ऐसे करना है और इसको ऊपर करना है.
See, you are blocking the tendon. You are holding there where the tendon has to glide and move. Right? All you need to do is ask him to do this. You don't touch and you are holding the forearm tight there. The tendon has to move. You just give resistance just distal to the insertion of the ECU. ECU is inserted where? Here. Okay. Base of the fifth metacarpal. Okay. So give insertion around the shaft of the metacarpal. Ask him to hold like this.
ऐसे करो, गट से पकड़ो ऐसे.
Turn, deviate to the ulnar side.
Yes, yes, ठीक.
Yeah. Dorsiflex.
ऊपर करना है अभी.
Ah.
अभी ऐसे करके ऊपर करना है. ऊपर करो.
You can see the tendon, feel the tendon very nicely. ECU.
इधर किधर भी दर्द है. ऊपर करना है जोर से.
Demonstrate the movement. We are asked to do these tests. It is always better keep the wrists and identical position on a support or a table. You ask, tell the examiner. Then the examiner might say, just demonstrate it like that. So first tell that and then start doing all your tests.
And in the case when you get, the exam when you get a hand case or a wrist case and all, ask for a pillow. Keep both the hands there and then demonstrate all, so that you don't keep the patient's limb in the air like this all the time when you're doing this. It becomes painful for the patient, right? Take a help of a pillow, support it nicely and then do all your tests. Okay? No signs.
He doesn't have any time loss.
Okay. Right. Movements done. Measurements, no difference. Neurovascular.
Distal pulses are felt and there's no sensory deficits that is present on them.
At least you should make sure you tested the autonomous zones of all the three nerves in the hand. Any case in the hand and wrist, all three nerves you have to document. Okay. Special test would have been these things. Okay. The ulnar grind test, the ballotment, right? Foveal signs. Okay. Right. So what will you do? It's a 9-month-old ulnar sided wrist pain with probably a TFCC injury. What will you do?
Plain radiograph of the wrist
Why do you want the radiograph?
to see if at all there's any trauma positive.
He didn't have any major history of trauma, right?
No, sir.
Okay. Most of them won't have. Few people come classically with trauma, fall and everything, but majority don't have a specific history of trauma. It will sometimes be something in the gym once or lifting any heavy weight once. A lot of times when they're traveling, suddenly there's a jerk, some break happens and then the wrist completely goes into a kind of an axial kind of force. So that is the time they develop these TFCC injuries. These are the common histories you anticipate when patient comes to the OPD. Okay.
And to look for any distal radioulnar joint.
Okay. X-rays there? What else you'll see on the X-ray? Oh, straight away MRI. Okay, X-ray. Okay. Can you show the carpal bones once? Because you said capitate. That's why we are a little. Said ulnar most is capitate. So.
So this is scaphoid, sir. Lunate, triquetrum.
Lunate.
This one.
Okay.
This is the triquetrum and the pisiform which is overlapping on that.
Okay.
This is the trapezium, trapezoid. Sir, I'm not able to.
It is like the forest, doctor. Aditi is trying to tell you, don't go inside the forest. You will not see the entire picture.
This is the trapezium, sir. Trapezoid here. And this is the capitate.
Where is the overlap of the trapezium and trapezoid?
This and this. This is the overlap.
Okay. It's actually not just that corner, ulnar corner, which you showed earlier. It's much bigger. Yeah, that is the border. Okay.
Yes,
Then?
this is the capitate.
Okay.
And this is the hamate.
So when you put your finger here, right? So you will feel, if you move the wrist onto the radial side, you will feel the triquetrum touching there, okay, sometimes, if the patient has a laxity. But otherwise, the TFCC is basically starting from there and ending here, okay? So that is the portion of the TFCC. It has the deep portion, the superficial portion. So your foveal sign is where you would put your finger here when there is an injury in this, most common injuries are the peripheral injuries here, okay? And when you push that, what we showed that time, okay? So the pisiform here, the FCU, the ECU, and then this is a soft spot. So it's sometimes called as the ulnar sided scaphoid, ulnar sided snuff box, like you have that side. So between FCU and ECU, and you have this boundary here, and then this boundary here. Push your finger into that, you will get this tenderness there.
You also make a mention about the variance.
This.
So what are you seeing now? In the X-ray, what did you want to see? So wrist X-ray standard is PA view, not AP view, right? How do you make out? Anybody can tell? What is it, PA or AP? What's the first thing you would see, or the only thing at least? No, all of you nodded your head, PA view. So how did you make out it's PA view? Even if you ask for AP view, the radiology guy will take, technician will take AP view, if you ask, he will take a PA view. So even if you make a mistake, those guys are trained very well that they will take a PA view. So the only thing you would see is the ulnar styloid. That's the first thing. So in a PA view, the ulnar styloid arises from the ulnarmost corner. Like that is the picture you see. Go and check on AP view, open up your mobiles and check. In the AP view, the ulnar styloid will be somewhere in the middle. So if you keep like this, right, there will be some amount of rotation and then you will see this. But in a PA view, this is the class. At least this is the only thing at least you should see in the X-rays in OPD, is it taken correctly or not. And only in the PA view, the corpus is arranged anatomically, it looks correctly. If you look at an AP view, the scaphoid is completely twisted. So you might think there is a problem with the scaphoid. So compare PA and AP and see the X-rays, then you will understand this. Okay, but in this case, what are you trying to see? You will want to see any problem here?
Avulsion of the ulnar styloid.
Then you also see this. What is the normal gap, DRUJ?
2 to 3.
Less than 2 millimeters. Okay. So anything above that, you should start thinking, is it okay? If it's properly taken PA view. Okay. Lateral view.
Lateral view, there is a dorsal subluxation of the radial.
So before commenting on that there's a dorsal subluxation of the ulnar, you should make sure that again it is a true lateral. How do you take a true lateral? I mean, what do you see if it's a true lateral?
The alignment of the
Alignment, what alignment?
metacarpals, if there
So third metacarpal, capitate and radius, they have to be in line or collinear. Okay. And this is called as the SPC lateral. The scaphoid should be projecting front, then the pisiform and capitate, right? So this is this capitate, the pisiform shadow. This is the capitate shadow here. Pisiform is, I think it's somewhere seen here, this border here, but it's called SPC lateral. Scaphoid, pisiform and capitate, they should be in line. So that is the true lateral. Then only you say this is moved. Otherwise you should not be saying this. Okay. So this obviously doesn't give you any clue about this injury. So what would you like to have?
MRI.
An MRI. Okay. I'm not, because this is not a true lateral, so that tilt of the lunate, but otherwise probably yes. Okay. So you have the sagittal and you have the axial cuts and the coronal ones.
The lateral view, can we take it in 10 degrees of flexion like this?
That's only to see the articular surface. That's all. The tilt views we take only to see the articular surface. Otherwise, it is taken in this adducted position. For a PA view, the radiologist would take it like this. Shoulder should be in abduction, 90 degrees. So the moment it comes down also, as sir was talking about, the variance changes. The ulnar variance changes. So they will do it correctly. The technicians will do it correctly. They'll make the patient sit, and on the table they will keep it like this. So shoulder should be 90, elbow should be 90. Then only the PA is the correct view. The lateral view is taken in adduction, like this. Then only you get a true lateral. So this, at least two basic things you should know how to take the PA and lateral views. Okay.
So there
You
is
see anything?
hyperintensity.
Yeah.
Hyperintensity in the T1 weighted image.
Okay. Can you trace the TFCC there? There. I showed you on the X-ray how it is. You are going distally.
It extends from the medial part of the distal radius to the ulnar.
Okay.
And then ulnar to the tricep.
So you have different portions of TSA. What I told you was one coming here. You see the small signal there, the empty signal here. So you have any other cuts? No. Yeah. So this is the deep portion of the TFCC here. This is the fovea. Actually, this is the fovea. And you have the superficial portion. You also have the sheath. The ECU comes here. And the ECU sheath is also a part of the TFCC complex. TFC is triangular fibrocartilage, but TFCC is triangular fibrocartilage complex. The complex part also includes the sheath of the ECU. Okay? And see here. So this is your deep portion here. Okay? And this is the superficial portion. So there are two laminas of the ligaments. Okay, so the deeper portion, and if you see here, this is where there is a defect here. The superficial portion is probably the injured one. But again, you'll have to be careful. There's a small defect here, the signal change here. So the deep portion that's a foveal tear. The deep portion tear, which can be there. And if you see any fluid signals along this, okay, that means the ECU sheath could be injured apart from the TFCC itself. That's a massive injury for the patient. Okay. So along with the superficial and deep portion, the sheath is also injured, then the joint subluxates. So that is what happens with the subluxation. Then of course there's a central portion which is called as the articular disc. And articular disc is generally not involved. It's more of degenerative tears as the patients, as we grow older, you get these degenerative changes. So the central portion is the articular disc. The deep portion, the superficial portion, the ECU subsheath, and there's some loose areolar ligament here where the vessels come in. So these are the 5 parts of the TFCC. Okay. And so all these could be injured in a very bad injury when there's a huge trauma. But this kind of injuries, generally it will be only one of those superficial or a deep portion which could be injured. And if the peripheral tear is the commonest one, which also has blood supply like your meniscus, and if you repair them, they would heal nicely. Okay. Great. So what will you do?
Is there any role for CT scan? This massive injury, the radial ulnar joint, there is a subluxation, there is a ballotment positive. Role for any CT? you can't find any role. It is only a soft tissue injury. So the ulna, the stability is not only by that, there is also an anterior and posterior, the sigmoid notch is there, where the ulnar head articulates, which rotates. So that margin, there can be a fracture. And dorsally, if the margin is gone and this is going, even if you do a soft tissue repair, if that bony restraint is not there, then it is likely to fail. So you have to be careful about it.
So if you start seeing your distal radius fractures, axial cuts, what sir is telling, you will see them, right? You should be actually looking at, you ask for a CT scan, but nobody really looks into that axial cuts where you see the sigmoid notch, okay? And majority of, there is almost 30 to 60, almost in literature talks about almost 65% of patients might have associated TFCC injuries. But all we do is we fix the radius and we are happy about it. And patients do come, most of them would come later with ulnar-sided pain. All your distal radius malunions come with ulnar-sided pain. They'll never come and tell there's pain on the radial side. So most of us, when we operate and we put a good plate and then fix the radius, the sigmoid notch generally reforms. And they always heal. So majority of them heal by themselves. So we don't really worry about it. So ideally you would have to check the instability on table and do something. Immobilize maybe for 3 weeks in supination for the TFCC to heal. Okay, if there's no instability, you can mobilize early if you've done a plating. It's not just the TFCC, you also have the intraosseous membrane. So that is also a part of, so these are all the ones which can get, these are all secondary stabilizers, intraosseous membrane, pronator quadratus, all these things. So when we do a plating, we take off the pronator quadratus, we strip it out. There's a TFCC injury also. Then they take, so some patients, when you know distal radius, they don't heal nicely. They always come back with pain and stiffness. That is because of these soft tissue injuries. Just because I do a plating, I should not be mobilizing next day, right? Unless you know that there are no major soft tissue injuries. That is where the results change between people, okay? So you think my plating is so beautiful, I've done such a good reduction. Why is the patient complaining of pain repeatedly, you know? So these are the reasons you should think of. Okay, so axial cuts showing sigmoid notch morphology is very, very important, especially in a distal radius fracture situations. But otherwise, if it's just a pure soft tissue injury, an MRI would be fine. So 9 months now, he's come, he's got pain, what will you do?
Initially, we'll try with analgesics and immobilization of the wrist joint.
Immobilization?
Yes, sir, with the cast.
Okay, how will you immobilize?
With the cast.
At 9 months, you want to put a cast. When the cast would be the most beneficial one. Acute injuries, even up to 6 weeks if they're present, please put them in a plaster for about 3 weeks, above elbow cast, like I showed you, it reduces nicely in supination. The ulnar head becomes less prominent. So you check in all the 3 positions and see. So most of the time we try to put it in as much supination. If you put in complete supination, they develop a lot of stiffness. So we just put in with 30-degree supination, but it has to be above elbow cast for 3 weeks. They all do very nicely. But a lot of times what happens, they are given some splint, which is even a small splint like this. I see patients with one very narrow wrist brace they will be using. It's absolutely useless. Okay? So if at all you want to splint, the elbow has to be locked. Okay, so there are splints for TFCC called Munster splints and all, where like the good old Munster cast, where the elbow will be locked. So pronation supination has to lock. As long as it's moving like this, there's no way the ligament will heal. So if you have a patient like that, please convince them for a plaster because it does a world of difference for them. 3 weeks is good enough, they'll heal nicely, you can start mobilizing. If they're not ready, at least give a splint which locks the elbow. Or give a long splint, forearm splint. Don't give some short, very flimsy ones for TFCC. Okay? And then we have a standard protocol of strengthening the muscles later. So you have all the stabilizers which I showed you, ECU, FCU, ECRB, pronator quadratus. So these are the 4 muscles you have to strengthen. Okay? These are all crossing the joint. And pronator quadratus is a secondary stabilizer for the DRUG. So your protocol for after 3 weeks or 6 weeks after the cast or whatever should be to strengthen these 4 muscles. ECU, FCU, ECRB is also a part of that because it's running centrally, and on this side pronator quadratus. Okay. So put them on the strengthening exercises, they'll do well, right? If they come back again with pain, they're not able to lift anything, they can't twist or turn, and there is disability persisting, then
Surgical intervention.
what are the options?
Either arthroscopic repair of the TFCC or we debride the TFCC.
Okay, so there could be an arthroscopic or an open TFCC repair based on your skill set. So ideally would be obviously an arthroscopic repair. Peripheral tears heal nicely, so you can repair them nicely, but there's a classification system also, so you know where the tears are. So it could be radial side, it could be olar, dorsal, it could be central, and it could be peripheral. So peripheral tears heal nicely. You can debride that area nicely, and the bleeding is there. There's vascular supply, they heal. A radial tear is very difficult, which is just at the DRUJ junction. Central tear is degenerative tears. We usually just debride that area. Okay, that's generally seen in older patients, not younger patients. Okay, so most of them do very nicely if you can do that. Okay, if you don't have that skill set, then you can open and still do the TFCC repair. A little more stiffness, but then it's still worth it. If they come with very badly damaged TFCC, there is nothing to repair, you have to reconstruct. Do you know any way to reconstruct? Anybody? So that's the end point of this whole treatment. So if TFCC is so badly damaged, we use a palmaris longus graft, any of the tendon graft basically, and reconstruct this TFCC ligament. Like your ACL and PCL, same thing, we talk of this same way of doing things. Okay, so a reconstruction with a tendon graft. Okay. Any questions? So present the case, a wrist case with which sided pain, ulnar side, radial side, central, diffuse. Diffuse pain generally are in inflammatory and infective kind of pathologies, tuberculosis, rheumatoid and all those things. But otherwise, if you have one-sided pain, there are specific differential diagnoses we can straight away diagnose. It's not just for exam, I'm talking of when you see patients in OPD also. So keep those in mind and then rule out. Take proper x-rays, PA view, lateral view, interpret that, okay, do the tests. And most wrist patients like this, ligament injuries and all, and this decoherence, anything, first line is always conservative treatment and then the operative management. Things like scaphoid non-union, CMC, arthritis and all, which might require surgical intervention, it's a different thing. But otherwise, most soft tissue pathologies, tendinitis, ligament injuries, good trial of conservative management, and then sometimes like decoherence and all, we might give a steroid. So very few indications, but then this is how the management has to be told. Okay?
Save upon the arthrodesis. Is it also an reconstructive?
So that's a salvage.
Salvage.
So if you see an arthritis, a DRUJ arthritis, you do a Kapanji's kind of a thing or a Darax. So they're all salvage procedures which come later. Okay. Primarily, you try to restore the anatomy as much as possible. Second is by repairs. Then is reconstruct the anatomy. If both are not there, it's the same principle as in the hip also. Then you try to. Here we don't really have good processes and this one, so we don't replace it. So we will do something like Sir is telling. So we might do a salvage kind of procedure where we might have to do a limited fusions or sometimes. So the distal end of the ulna is okay to be taken off, but you have to, if you look at the original Darax procedure, they don't take off the entire thing. That ulnar styloid with the TFCC attachment is still kept, if you look at the original article of Darax. So that support has to be still there. Okay, people have changed that, they've just chop off the distal end of the ulnar head. That leads to complications. That leads to radioulnar impingement, instability, pain, and so Darax procedure has got a bad name because of that. If it is correctly done, it's still a good procedure. But that needs to be kept for only certain cases, not for all the patients. Ekapanji works very well, but there has to be arthritis. Again, a lot of people, just because there's ligament TFCC injury or something, they'll do a Kapanji's, which is not a correct procedure. Okay. Any questions?
Thank you, sir.
Thank you.
Thank you, sir, for the valuable session. Well, that was a good start to the day. I request the chairpersons to be seated on the dais only. In this session, we have Two more cases, sir. One ankle and one knee, and shortly we'll be beginning. And I would also like to request all the postgraduates to call their co-PGs and friends to not miss this session. Thank you.
ಇಲ್ಲಿ ಮಾಡಿ ಈ ಸೈಡ್ ಕಳ್ಕೊಳ್ಳಿ ಮಾಡಿ ಹಾಂ ಓಕೆ ಸರ್. Patient name Nagaraju, age 47 years old. Complaints of pain and swelling over the right ankle for the past 3 to 4 months. No. Complaints of pain. Complaints of pain and swelling over the patient name Nagaraju, age 47 years old. Complaints of pain and swelling over the right ankle for the past 4 months. The patient was apparently well 4 months back, 5 years back, when he met with an accident for which he sustained a closed injury to the right ankle, following which he was treated conservatively with analgesics. Post injury, after 1 month, he started developing swelling, which was on and off in duration, which was really on taking rest and medications. It was going for the past 3 years. For the last 3 months, the swelling started to increase in size. It was continuous in nature. It was progressively increasing in size, and it was relieved. Swelling size was reduced in the last 1 week after applying some ice compressions and local country Ayurvedic treatment, putting a plaster for more than 1 week. After which patient develops pain. In order to relieve the pain, he removed the plaster, and he was having a difficulty in walking. There's no history of any recent trauma.
Because we are totally confused here.
Yes, sir.
So there was a trauma 4 years ago.
Yes, sir.
Right. Was it a significant trauma or not? Do you want to attribute the present condition to the trauma, or it is just it happened?
It's a significant.
It's a significant trauma.
You
Then
also
you'll have to tell what is the mode of injury and how do you know it is a significant trauma or not?
you made a statement that it was a fracture and treated with analgesics.
Treated conservatively, he told. There's
No,
no
the
fracture.
conservative management for a lower limb is not with analgesics, is it not? Upper limb probably the patient will be able to manage. Other than the metatarsal or phalangeal fracture, people have to be put in a plaster. So without a plaster, then to say as a significant injury in the ankle, it is difficult to imagine.
Yes.
So what is that actually a sustain? Why
It's
do you
a-
say it is a significant
He
injury?
told it's a twisting injury to the ankle,
Okay.
and he was able to walk after that.
So that you have to say whether the patient was able to bear weight and walk immediately following the trauma. And he was able to continue. He was not hospitalized, he was not immobilized.
He walked and went to a hospital or anything?
Like he was partially weight bearing, and he was walking. Followed which they took X-rays. They found that it was like.
So that's what, immediately he went and
Yeah.
got an X-ray done, and they also told he has a fracture and he was given analgesics?
Not fracture, ankle sprain. They told so.
No,
That's
you
all.
told in the history he had a fracture, he was treated with analgesics.
No, he didn't say, he said it was only an injury. But how do you know it is a significant injury or not?
If it's
Because
not,
which injury you call it as significant?
if it's a trauma.
Because ankle sprain, everyone says. If there is a knee injury, they'll say that it is an ankle sprain. What do you mean by ankle sprain?
Uh,
Which ligament is injured?
tibiofibular ligament.
Huh?
Talofibular. ATF.
What is that? People are all knowing only the abbreviation, not knowing what is the expansion for that. Yeah, you have to tell us what is ATF.
Talofibular ligament.
What is A?
Anterior talofibular ligament.
Anterior talofibular ligament. So how do you know that? And do you call that as a significant injury?
If it's
So
not
what,
able-
what else will you add for these things? So he
Yes.
was given analgesics. Was he given any kind of immobilization?
No, sir.
No. How long the pain was there?
It was there like for the past 2 weeks. He was saying after injury.
No, my basic question you have not answered. When do you call an injury a significant injury?
If there's any fracture or
Okay.
if there's
Or?
not able to weight bear,
Yes.
and if there's any swelling or
Any swelling. Any injury, there even a contusion will have a swelling. When do you call it as a significant injury? Anything else? Call that as a
Which
significant
symptom
injury.
you insist to inquire about to say it is a significant injury?
One is a fracture where he is not be able to bear weight. Right. Then if
Once-
there is an instability, so patient has wobbly ankle, wobbly, so that entire support system of the ankle is gone. It
Loss
can-
of function, man.
So that is a significant injury. So the ankle sprain, everyone diagnoses. Do you call them everyone as right?
soft tissue injury.
So when a lower limb injury treated with analgesics, you don't consider it as a significant injury which is going to produce later a big problem. So probably that was something there which you are not able to elicit, or it was something else apart from the injury. These are the two things I could understand. So after 1 month the pain started and the pain gradually increased.
Yes, sir.
Pain and swelling.
And he took medications, local analgesics and local ointment.
Okay.
And after that the pain subsided.
Okay.
Like his daily activities of daily living was restricted. Like he was a salesman, he couldn't ride the vehicle. So like he was not able to stand, he was not able to sit in the Indian toilet, and he was not able to wear pants and all those things. It was difficulty in standing was there. So he was not able to stand for a long time.
So all these symptoms, how rapidly it progressed, or from day one it was very much, and which
last 3 months it was increasing, sir. He was not. From day one he was able to do his daily activities.
so that progress you have to tell. If you want to correlate that and this, you have to start from that time onwards. Yeah.
Post
No. So you have to tell that history little bit, because based on that only we will be able to understand. So following the trauma, analgesic, and he was able to carry out normal activities, toilet activity, walking, and he was able to wear his pants and everything. Right. How the symptoms progressed then? Only 3 months these symptoms. But still you want to associate it with that. Okay.
No, after the initial trauma, when is the next episode of major pain he had in its last 5 years? No. No, what I asked and what he told me was, what you told is correct. In the first, the pain was only for 3-4 days, subsided, and then by about 5th month or 6th month, he started getting a lot of pain. Again, he went back to the same doctor. Again, analgesics and all those things. Again, another 3 months, he started getting pain. So it has been an intermittent pain, and now in the last 3 months, it has progressed so much that it has disabled him completely. He can't even sit, can't squat, he can't even wear his pants. right? He uses a two-wheeler. It's very difficult. So there's a progression. That story you have to tell us always. That is what sir has been asking. You have to build up the story telling that it was a injury which was not very significant because he was able to walk and everything, right? Subsided, but then it is progressive, intermittent but progressive, and has become continuous. That gives a sequence and story for us. Understand? So which means it rules out maybe a major injury like a fracture initially, okay, because he was able to walk and almost 5-6 months he didn't have any issues. Then the pain started. So we need to see something is evolving slowly in the joint there, okay. Intermittent. First, next episode started with 5th month after the initial injury. Then it became frequent intermittently. Then it has become continuous. And now he's disabled, can't squat, can't wear pants, difficult, 3 months. Okay.
There's no history of any discharge or sinuses, and no history of any other bony swellings present over the joint, and no history of any recent trauma like last one. There's personal history. There's no history of any diabetes or hypertension. Local examination of the right ankle. On inspection, there's swelling present over the lateral aspect of the right ankle, and there's no there's no discharge or sinuses present. On and there's muscle wasting noted in the right leg, and there's no discharge or sinuses, and there's no other bony swellings or any deformity over the ankle or the foot. And on palpation, there's
So if it is involving the ankle, which area you want to see first?
lateral malleolus, medial malleolus.
On the malleolus, if there is an ankle swelling, ankle effusion, which area you want to see?
Posterior aspect.
On either side of the tender Achilles. That is the region where you have to see. Okay, right. So never forget to see on the back. So if there is a varus valgus malalignment, you have to see from the back. If there is any involvement of the ankle joint, you have to see on either side of the right.
Any abnormality in the attitude? No.
Yes, sir.
You made him stand briefly, or you made him to plant his foot down and then saw from the back?
Yes, sir.
Right. What was there? Is there any attitude? That's what sir is asking.
Foot is internally rotated a little.
Internally rotated.
Externally rotated.
Come here.
Or you can ask him to bend the knee and keep the foot on the couch just without weight bearing. How is it? Bend the knee to 90 degree and then, yeah, so both sides. Both sides. Then only you can compare, right?
Do you find any difference?
Dorsiflexion.
Any painful swelling in the ankle will result in plantar flexion.
Okay.
This one. Should we start?
See that the dirt there and see the pattern of that.
Yes, sir.
What the difference is?
He was more weight bearing on a medium.
The normal.
Which is more wide and which is more narrow? Which is narrow?
Barefoot, obviously, you can see that the dirt, the discoloration, whatever you call it. There's a difference, huge difference. So where is he trying to avoid weight?
So was trying to avoid weight.
So why do you want to say negative first? He's bearing more weight on the lateral side. He's avoiding weight on the mid. Yeah. So his pressure is more on the lateral side. So these are all the things. So always they have equinus, varus, and they want to try to put weight on the lateral aspect. Okay. Right.
There's no rise of temperature. Tenderness present over the lateral malleoli and base of the fifth metatarsal and cuboid and this cuboid was present, sir. And
Tenderness on the lateral malleolus, fifth metatarsal, cuboid. Which cuboid?
lateral aspect of the cuboid.
Okay. Which part? Is it in line with the metatarsal? Where is the tenderness?
Just proximal to the fifth metatarsal, you felt some bone, and that is the region.
Okay.
So that is the area where you thought that it was cuboid and cuboid tenderness, right?
Okay. No, any other tenderness? Medial malleolus?
No medial malleus was not, sir.
How is the sinus tarsi?
Is there any joint line tenderness?
Joint line,
Can you make out joint line in ankle?
yes, sir, from the yes, so we can make out from that crease.
In which position you can probably insinuate your finger between the tibial and the talar junction?
Plantar flexion or dorsiflexion? When the talus will come out and then you can be able to see the joint easily.
It's not very classical the way you do in the knee joint, but here you can still try to elicit if there's any joint line by moving the ankle and try to create a little more space. So is it in dorsiflexion or plantar flexion?
It's a plantar flexion.
Yeah,
Plantar
obviously in
flexion.
plantar flexion.
Okay, so you should do that. It's a more of a dynamic kind of a tenderness you should elicit. Okay, especially when you have a joint pathology, you should be able to do that. Sinus tarsi?
What does it indicate? Sinus tarsi tenderness.
Tarsal
Tarsal
tunnel syndrome.
tunnel syndrome. That is the area of the subtalar joint. So,
Arthritis.
Yeah, you have to. So you have to see about the ankle joint, you have to see about the subtalar joint and the metatarsal joints which you said. Right.
You have to test the tenderness on the bony components, joint line tenderness, and ligamentous attachments. These are the three aspects you have to see the tenderness. So bony tenderness you have seen only on the lateral malleolus, nothing on the medial malleolus. So cuboid is tender, you said, and the joint line, anterior joint line is tender. It is tender. So ligamentous attachments you see.
Yes, sir. So we dorsiflex the ankle and we lock the talus. So we look for the inversion and the eversion of the foot. He was having pain during eversion of the foot, sir.
Why do you dorsiflex the ankle?
Because your talus because your talus dome gets attached, other to lock the talus. Locking.
It gets locked in the ankle mortis. Then you are only movement. Otherwise, what happens?
The dorsiflexion, the ankle joint movements will be assisted with it.
Oh.
Where else he has tenderness?
So on the posterior aspect, he was calcaneum, also he was having tenderness.
I think his major tenderness is.
So if you see where it is, the tenderness. So first initially you should have seen for the warmth, I'm not very sure. So if you want to see the subtalar joint, so this is the lateral malleolus, this is the base of the fifth metatarsal, fourth metatarsal, and just below that. You see? So this is the depression where he has. So here he has got a lot of tenderness. Okay. So if there is tenderness here, then you will have to look for this. What is the subtalar movement? Is it painful or painless? Is it restricted? So how much when compared? Can you just show how to check for the normal side and then the metatarsal as well as what are you trying to do?
I'm dorsiflexing the ankle.
Dorsiflexion.
first thing I did was to expose the knee when I came. Right? For any ankle foot pathology, at least do this much. Okay, the knee has to be free. Okay, that's the first thing. Now you dorsiflex. See the dorsiflexion. Okay, do it.
Are you rotating or are you doing eversion inversion?
Hold the whole talus. Hello, calcaneum. Hold the calcaneum heel. That you are.
Even normal side he'll have pain at this. No.
So what you can do is, if you are flexing the knee, you can just stabilize the talus and the calcaneum together like that, and then inversion and eversion. So inversion is around 15 degree. Eversion it just comes. So there is nothing much here. Okay. So this is the extent of the dorsiflexion. I mean inversion and eversion.
Honestly, I found this very difficult.
Yeah.
It's a struggle. When I was a PG, when I was a registrar, and I have been an examiner, and I have found this very difficult. After having understood Ponsati's concept of the calcaneopedis block, I feel that this needs to be revised. This needs to be revised. And I have raised the matter at the IPOS. That's the ultimate meeting of the pediatric orthopedic surgeon, and in the Pozna linked meeting as an American Academy. And they seem to agree, but I think we need to publish this. I'll just demonstrate the way Ponsati would have done the same thing. Okay. So for PGs, for all examiners, this is what you have to do. But for your own understanding how much the restriction is, just do the Ponsati's maneuver. And what is Ponsati's maneuver? Don't quote me in the exam on this, you're likely to have trouble. But I'm just telling this for your own clarification. Is the subtalar joint moving or not moving? Okay? I've tried it again and again, it's consistently valid. Feel the lateral malleolus, feel for the head of the talus. And I have now stabilized the head of the talus. With this, now I move can you see the heel moving? When I do the Ponsati maneuver, the heel is moving nicely into inversion and eversion. Can you see that? It's nicely moving. The talus is fixed in the mortise by my thumb on the head of the talus there. Now it is doing like that. So I don't know which side is the affected side. So here it goes in, but eversion is better. This side is, see that? It's moving. You can see the heel moving. Now we'll compare with this side. See the difference? Can you see the difference? So I don't know which one is affected, but see the range of movement.
No, this is affected side, but you have to see for the eversion inversion display. Right side. The calcaneum.
Yeah.
Because this more of rotation we are seeing, but if you want to see inversion in display.
You see this?
Yeah.
See the way the joint is moving. So this helps you understand.
Yeah, but
You can do that also.
yeah.
You can do that also. I was just drawing the parallels of the Ponsati's maneuver.
So definitely
So to double check, so I use the standard method for PGs to do that. To double check for your own understanding, you can do this also. Am I right or wrong? That's all. I'm just flagging a test. As you said,
Eversion is restricted.
Eversion was clearly restricted.
Eversion was restricted, right? So it was just coming just short of uterus. That is the. So this is very important. When you are palpating, you said palpated the lateral malleolus. He palpated the cuboid fifth metatarsal. Just proximal to that, dorsally is the sinus tarsal. That is a very important area of tenderness for the subtalar joint. Once you elicit subtalar joint tenderness, then you have to move the subtalar joint. And then the midfoot also you have to move. The forefoot adduction abduction. So you have to hold the navicular and the cuboid region and then move. So that was also terribly painful. Ankle rather it was not
anterior Doyle's test, like it was positive, and
How do you do the anterior Doyle?
so so you plantar flex the ankle to 20 degree, and you stabilize the foot and one hand over the leg and give a anterior posterior translation. If you feel that the ATFL is torn, that there will be a anterior translation of the tube.
So it is easier if you sit down and make the patient sit in a couch, and then because the foot will be hanging down. So in that way you are not holding the leg and the weight of the leg, and then you will be able to better appreciate. There is normally in equinus there will be some anterior translation. Don't take that as the anterior drawer positive. So you found that because of so much of pain, you are sure that there was an anterior drawer?
The swelling and tenderness and pain, and with the history you have, you would expect instability or you would expect stiffness in this ankle. What is the range of motion? Dorsiflexion, plantar flexion?
Dorsiflexion was around 20 degree, plantar flexion was around 50 degree.
It is restricted compared to the normal side.
Compared, yes, it was little.
And subtalar is also restricted and painful also. So, would you really expect an instability?
Yes, sir.
Can you do the way sir told now? Just ask him to sit, hang his legs down. You sit down.
Yeah, really, correct.
Too speed.
So you need not ask him to do anything.
No, you just hold,
relax.
little relax.
Yeah, correct. So there is a anterior translation. You are able to see that. Okay? Right. That's right. Gently.
Slowly.
Don't else. Not of pain, because it has to be really unstable. Is it there?
Stiff, sir, but
Stiff. Then how did you expect that?
Ankle and wrist behave in a similar way. Instability actually leads clinically to stiffness. Okay, when there's ligament injuries in ankle and wrist, it actually leads to stiffness. It's not like knee and shoulder where it becomes unstable. Remember that.
Probably under anesthesia you may be able to, but not here. Definitely I cannot accept your finding that it was unstable. Right.
Thala stress test was positive, sir, for calcaneal fibula ligament test. So we keep the dorsiflex the ankle and give an inversion. So if they have tenderness over the anterior posterior side, posterior thalafibula ligament, calcaneal fibula ligament. So if it is like if they're having pain,
Posterior talofibular you are.
no, calcaneal fibula.
He's telling about calcaneal fibula. Okay, then?
So calcaneal fibular is only one.
Hmm.
There is no posterior calcaneal fibular.
No, sir.
Right.
No, only
So I got
calcaneal
confused.
fibular.
Okay, okay. Suddenly, yeah.
But I guess that it's diffusely tender there on the lateral aspect. Everything. Measurements?
Measurement normal. Both the legs were compared. The medial longitudinal arch was maintained. The lateral longitudinal arch was also maintained, sir. And the medial length was from the tip of the medial malleoli to the back.
The arch you saw it standing or lying down?
So I saw standing position from
Weight bearing.
behind the patient.
And the medial height and the lateral height?
Medial height, it was medial side. It was around like 6 centimeter.
Was there a difference?
Sir, it was a difference there.
Height is reduced?
On the yes, sir, height is reduced on the right side.
By how much?
1 centimeter.
1 centimeter.
5 to 6.
Nadu ತೋರಿಸ್ತೀರಾ?
So he walks classically with the outer border of the foot. The arch is elevated, exaggerated. So forefoot is adducted, there is inversion, varus happening at the heel, and there is an exaggerated medial arch. So these are the things which you should have told on inspection. We would have appreciated, right? Okay.
ಅಲ್ಲಿ ನಾಲ್ಕು ಮಕ್ಕಳು ಜಾಸ್ತಿ ಇತ್ತು ಸರ್.
Okay, right.
ಅದೇ
5 ವರ್ಷ ಆಯ್ತು ಸರ್.
ಅದೇ ವಾರಸಿಂಹ ಅದಕ್ಕೆ ಹೇಳ್ತಾ ಇದ್ದೀನಿ ಕೂತ್ಕೊಳ್ಳಿ.
Okay. Right, what is your, anything else, sir?
No distal neurovascular disease.
Okay, so what is your diagnosis?
Post-traumatic subtalar arthritis.
Post-traumatic doesn't mean he himself will say all these things. So what trauma you think which has happened, which has led on to a subtalar arthritis?
Eversion trauma, twisting injury to the
No,
ankle.
no, that is all right. But what structure anatomically is gone, which has produced this?
What's the primary pathology which has led to subtalar arthritis? A ligament injury can lead to subtalar arthritis. A fracture can lead to subtalar arthritis. Which one?
Second is initially for 5 months he was all right, and then episodic pain, which the frequency has increased, the occurrence, the in between duration was getting reduced, and now he seems to have continuous pain. So you want to put it as post-traumatic or anything else. Immediately after trauma, 1 month he was all right, and then gradually little pain, but he was able to carry on his activity, and gradually it is increasing.
And 5 years duration.
5 years duration. Now the pain is over the subtalar joint, metatarsal joint, forefoot adduction abduction is restricted, and the inversion eversion is restricted. So 3 joints are involved. So with all these factors, you want to put trauma as first, or you want to put anything else? The finding may be entirely different. If you are spot on the X-ray diagnosis, if you say, then you are in for trouble. Because we don't think so. We cannot be wrong. So, is it not? Universal rule. Examiners. So you should, if you say that, then it is very, very difficult for you to get out. You have told also because that is what is really bothering me. Anterior drawer is positive when it is so stiff. So if there is a talar shift in the X-ray and the lateral side is unstable, then I'll be upset. Is it not? Right.
So will you be putting it more towards ligamentous or some occult fracture which has progressed to an arthritis which has not picked up initially? What do you?
Or is it inflammatory something?
Or it is yeah. Diffuse swelling is there and multiple joints are involved. Just because we suggest don't go to that. Stick to your clinical findings, stick to your history, what you got, right?
Would you like to call only a post-traumatic or anything else is possibility?
So at least give 1 or 2 differentials. Would you put secondary degenerative arthritis? Would you put probably inflammatory arthritis?
No, sir. Like it doesn't have any other.
This is what? Yes or no?
No, sir.
No. Okay.
Right. I think it is difficult for you, even it is difficult for me. As examiners, if you ask 4 of us, then we 4 will give a different diagnosis. So this will be easy for you. So what we would expect is that to put it primarily as post-traumatic in this case is very, very difficult, because the patient was normal, no instability, and in between period patient was all right, and gradually the diseases. So according to me, it will be an inflammatory arthritis. Most likely this kind of occurrence, which the frequency, the period in which the symptoms are not there is gradually coming down, it is more. It is most likely a crystal deposition disorder like gouty arthritis or things where this occurrence happens. So if you just give in the history, it is not associated with any food habits or anything which has happened, which suddenly the pain is very acute flare-up, and after the medication the pain coming down. Is there anything like that? Something which you asked? So these are all the things which you have brought it out, then we'd have been happy. Sir, what about you? What diagnosis?
Any subtle fracture which could be missed and which can lead to complications? So what is the most common injury around that? you describe the trauma exactly for us? Was it, what trauma was it? Just a twisting injury, that's all, nothing else. Okay. Right. Yeah.
Of course.
Okay.
So what would you like to
What
do?
would you like to do?
I would like to go with X-rays and
What X-rays you mean?
Yeah.
ankle, AP, lateral, and motor solution.
Still you want ask for an X-ray ankle, AP, lateral.
And foot X-rays.
Foot separately. You don't want ankle with foot lateral? Weight bearing X-ray? Or
So it's a weight bearing X-ray.
So if you're asked to take only one X-ray, what is the X-ray you'll ask for?
Foot, AP, oblique, and lateral.
Okay, right.
This is the AP view of the ankle, showing both medial clear space and lateral clear space is maintained, and there's there's no bony there's no bony involvement present. Bony fractures will be.
Any other X-ray is available?
is there subtalar arthritis as per your diagnosis?
Any foot AP oblique and some Broaden's views? No. Any other imaging? Okay, we'll just wait. So, any other contributory thing? Apart from the lateral view, some beaking in the head of talus, we are not able to see anything.
Sclerosis.
There is little sclerosis overlapping. The X-ray view is not right. So, yeah, we could see that. So, this, because in the lateral view, the dome appears all right, and this sclerosis, I won't give much of significance. The articular surface is smooth and the space looks all right. So, I think we have to
Anything out of this except that the anterior, if you just see further.
Talus.
Posterior facet. Posterior facet.
Middle subtalar is not normal.
So this we don't know, but this part and this part, right. So these are the things.
Yes,
Some
so
Broaden's
the
view and
calcaneum also.
calcaneum
is tender.
calcaneum is tender.
Okay. What will you do?
Take MRI.
So MRI.
Yeah.
I've got the MRI.
MR.
Put the MR.
This is MRI.
Why MRI? Are we suspecting only a ligamentous injury, or why not a CT?
No, they have MR. Anything? Any other section? would you put it towards trauma or some inflammatory kind of pathology?
Comes as inflammatory.
An inflammatory kind of pathology. Okay. What will you do then to confirm this?
Yes, sir.
They don't have.
That's all. These are the images.
Yeah.
And what is the report? Because they are better in interpreting.
Yes, sir.
What is the report they have given?
They are not given anything.
Synovitis.
Very infective.
Clinically correlate and also do a biopsy. That is the report.
Yes.
No, the biopsy, the report will be that. That's all. Yeah.
So it looks like some synovitis in the subtalar joint with fluid and soft tissue shadow. So we have to take a biopsy and then we have to proceed. So this is proceeding with traumatic.
Professor Rajmani, you were telling that CT scan is, in this case, how the CT scan is going to help?
No, if they are suspecting a middle facet calcaneum, then CT would have been a better option. But our main aim was our main problem we are thinking in terms of only inflammatory. So an MRI would have given the better.
If you put the lateral view of the calcaneum, the posterior subtalar part is quite absolutely all right. The problem seems to be in the anterior. I feel the anterior X-ray, can you put it? The anterior part of the calcaneum is not very normal.
But this is not visualized properly, sir. A Broaden's view would have been a better. The Broaden's view.
The pure lateral view of the calcaneum and some axial view of the calcaneum, the X-ray will show both. But as per this available film, the posterior part is quite okay.
Sir, now we see that there is some lytic area in the palace. So retrospectively thinking. So there is some synovitis in the subtalar joint, probably an infective or an inflammatory etiology. So most likely I will go in for inflammatory and still stick on to some crystal deposition or some inflammatory. Yes, sir. So even in the MRI, it was there was in the sinus tarsi fluid and some soft tissue. Yes, sir. So there is sinus tarsi tenderness, there is subtalar joint involvement, there is subtalar and the metatarsal joint arthritis. Yes. So what is the ESR CRP and the uric acid?
You carry on. Good. So basically, all the body processes palpation, not to miss any area of the palpation, position of the knee and ankle, demonstration of the subtalar movements. This part and all nobody will bother, but you need to be very specific on those, right? Exposure of the patient,
In fact,
flexion of the knee, all these things.
a situation like this, when there is a dispute among the examiners, candidate
You have passed.
you have passed.
When we start fighting, you have passed. So don't worry.
You have passed, don't worry. I felt why because the morphologically the anterior part of the calcaneum is not all right. And the chronic inflammatory changes, no osteoporosis, no population erosion, something not there. So to confirm the morphological changes, I would like to take a CT and check the same. That's it. It could be anything.
Yes, sir.
Still,
But from the beginning,
situation, candidates are better because
Yes, sir.
there is always a difference of opinion between among the examiners. Candidate is always safe. You are fast.
with the history, actually for 5 years history of injury, whether he had a subtalar the calcaneum little bit injury, which has resulted in the cartilage damage, and only that joint is inflammation, I doubt. How can only a single joint get involved? Traumatic history is there, we can correlate with that. But the trauma history, why I don't want to go into much was, for 1 month he was absolutely all right, and there were episodes intermittent where he was not having symptoms, and in between he was having pain. So that is the one which is going against it. Gradually, if it is progressing, that is fine. And after 5 years, suddenly after for 3 months, sudden increase of pain. These are all things which is not corroborating with trauma. So if it is trauma, the beginning it should have been really painful. He should have been immobilized and he should not have been walking where he was walking to produce incongruity and pain which is leading on to secondary arthritis. And even, yeah sir, 6 months he was all right. So that history I want to discount. And here also the sclerosis or the osteophytic changes leading on to a secondary arthritis, the X-ray we don't have that much of evidence.
Sir, I mean candidates can argue for first is inflammatory disorders, trauma may be incidental,
yes,
probably maybe crystal arthropathy second.
Yes,
whether he can argue for Cox also in this case?
sir, Cox, because 5 years by now it should have progressed, and that is what I was about to ask him the next question.
Yeah, yeah.
So the Cox is, can it be a tuberculous subtalar arthritis? Because this area it is.
Sir, there's no history of any fever or any episodes.
Please don't say if an examiner asks, could it be tuberculosis? No history of fever, no history of evening rise of temperature. Don't say that. For a secondary Cox, yes, sir. For a secondary Cox, the primary should have happened 5 years ago, minimum. So the fever, everything, it need not be all the time. So don't say that. Okay, so only thing points are this waxing and waning of symptom, 5 years remaining like this without progressing, without leading on to any other problem is unlikely. Yes, sir.
So what is one surgical thing would you like to do now?
Biopsy.
Biopsy.
In this case, you would like to do the biopsy? Yeah, where do you like to do the biopsy here? Which part?
Can you take the candidate away? Can we go down?
Thank you, sir. One more case, sir, before we wind up this session.
Good morning, sir. My name is Dr. Joseph. I'm from St. John's Hospital. We have a patient. Patient by name Manav Mandal, 21 years old, comes with complaints of swelling over the right inner aspect of the distal thigh. Patient was apparently normal 7 months back, had a complaints of swelling which was insidious in onset. It was gradually progressing. Initially it was 2 cm in size approximately, now as currently of 7 cm in size. Now patient complains, the patient has no history of any relevant trauma, no history of fever. Patient has no history of any stiffness, no history of evening rise of temperature, weight loss. No, not painful, not associated with pain, not associated with any stiffness of the knee, around the knee, over the hip. On examination, There was, on inspection, the swelling was difficult to appreciate. On palpation, there is no local rise of temperature. The swelling was extending from swelling is extending from distal aspect of the thigh on the inner aspect of around 7 centimeter in horizontal and in vertical around 4 centimeter. The swelling was, the skin around the swelling was normal. There was no puckering, no engorged veins. There was no pulsatile, it's not a pulsatile swelling. Consistency was hard. Difficult to assess the complete boundary of the face. On it seems visible. On palpation, it was more.
Some fullness.
The swelling was bony in consistency. It was the swelling was not moving with the muscle, rather than it was moving with the bone. The skin was not puckering, the skin was smooth, no local rise of temperature, no swelling. Patella was no tenderness over the patella. Knee ROM was full, hip ROM was full. No local. Hip ROM was normal, knee ROM was normal. There was no lymph node palpable. So
we'll do it like a short case in the exams. What this one is? What is your clinical diagnosis in this case?
Osteochondroma, sir, mostly.
From where?
Arising from the distal femur of the medial aspect.
Why do you say it's osteochondroma?
The swelling was initially on the distal aspect and it was progressing towards away from the joint.
As per the history.
As per the history, it was it was not painful.
On your clinical examination, what findings suggest that this is osteochondroma?
It's pedunculated sessile.
No, man. On clinical examination.
Clinical exam.
Radiological findings. You see the X-ray?
No, sir. On clinical X-ray, it was adherent from the bone, progressing away from the joint. It was single incision.
On clinical examination, on inspection, what you see? On palpation, what you see?
Skin was normal, not adherent to the skin.
You see there is a diffuse swelling on the
medial aspect of the distal femur.
Without dilated veins?
Without no dilated veins, no engorged veins, no pulsations. On palpation, the boundaries was felt, the surface was.
What is the, if you directly go to the boundary or what you feel first?
The consistency was bony hard.
Bony hard
swelling. The surface was irregular. It was arising from the bone. It was from the distal femur. Distal femur, it is arising from distal femur. It was not moving with the muscle.
Swelling is deep to the muscle,
deep to the
bone,
adherent to the bone,
bony hard in consistency.
Bony hard in consistency.
Surface is
skin was smooth.
Margins cannot be made out. Or you could say that you insulate your finger.
We can not completely around the swelling, sir. On the proximal we was able to, but distally it was a little difficult, sir. Partly yes, partly was able to.
Which part of the femur? Which part of the femur?
Distal femur. Distal femur on the.
Distal femur has got metaphyseal.
Whether it is a posteromedial, anteromedial, medial, anterior.
Posterior medial mostly, sir. And metaphyseal or distal to diaphyseal, around those.
See, unless you are asked, don't commit that for this one. You get in the problem. Sir asked only from where. So you tell that it is arising from the this one. And when you start metaphyseal, then they will ask what are the common metaphyseal swellings which you may not able to know. Unless you know, you don't lead the examiners to the problem. Okay. So that's why you think it is osteochondroma.
Yes, sir. Suspecting osteochondroma might be malignant. Not sure, sir.
Now
I would like to.
You seem to be in a great hurry, Baba. Relax. Okay? So, how did you say that it is going away from the joint?
Sir, So initially with the history he was swelling, it was on the distal femur. Then he was telling that the swelling was increasing and more towards proximally he was telling. So
On palpation, you said it is away from the joint. How can you say that?
the growth was more felt proximally to the.
An exam is like in a court of law. So there are a lot of stories the witnesses will come and tell. But the court looks only the hard evidence. So you giving this soft evidence of history, but you're asked to tell why do you say what you're saying. That will be, why do you say it is growing away from the bone? You have to give hard evidence.
So
Not the historical, he is saying. We all will come with history of trauma. They'll all will come with some backtails. So
Knee ROM is normal. Not
please don't use the ROM.
knee range of motion was
Then I'll
normal.
start telling everything in SMS language.
No, sir. Knee range of motion was normal.
Baba, listen to sir. Listen to sir. Don't be in a hurry. You seem to be rattling off there.
Away from the bone, it's purely more of radiological thing, classic osteochondroma description. Right? That's why they're all pouncing on you. Okay?
Where you are able to insinuate your finger between the lesion and the proximal portion of the thigh. That is what you need to tell.
Is it possible?
You should be able to insinuate your finger in a pedunculated lesion. You won't be able to do it in a sessile lesion. So be very careful. When you say that it is growing away, it has to be a pedunculated lesion. So is it pedunculated? You have to be sure.
What is your finding
That's
about
a trap actually.
You are finding on that, but you said
Proximally, I felt it. We could feel.
peduncule is
Yes.
palpable. You said the proximal part is
Proximally
palpable. You
was
can get-
able to.
Okay. Then you now uttered a word that it is going to be malignant. Why do you say it is now is going to malignant clinically?
As a patient's age is 21-year-old. Suspicions of growth, progression of the.
No, see.
Findings.
Find your clinical. I am asking clinical findings only. You don't rely on his history.
No,
I agree that he is 21-year-old. He looks to me like that.
No, sir, not associated with any pain.
Has it suddenly increased in size?
No, not sudden increase in size.
Then why do you say it's malignant? What are the clinical findings of a osteochondroma going into malignancy? Clinical, don't tell me the radiological now. Clinical.
Associated with pain, rapid progression in size, associated with neurovascular compression.
So my next question is, what are the causes of pain in an osteochondroma? You're actually leading the examiner to ask you too many questions.
Now, see the
When you say malignancy, you see local findings of a malignancy, skin infiltration, adhesions, all these findings, variable consistency, all these things.
And don't tell that the neurovascular compression is not a sign of malignancy. A swelling which is not painful suddenly becomes painful and rapidly grow is a clinical. And on palpation, what you see, you should see the tenderness if it is there. If there are any signs of malignancy, there is increased blood supply, the dilated veins are there, it is not there. It is not tender.
Anyway, with the diagnosis of osteochondroma, you don't have malignant genes appearing at 21 years. You should know what percentage becomes malignant and at what age do they present. So you are exposing your ignorance there also.
That they will ask, what percentage of sessile this one going to malignancy?
1%.
And multiple?
15
to 20%.
Trouble, you must be very cautious in putting your words.
1% is not a this one, there is a range. Always tell you the range. Okay. Now, sir asked one important question which we invariably ask in the exam. What are the causes of pain in osteochondroma?
Fracture of the stalk, bursitis.
1 second. Fracture of the stalk, then?
Bursitis.
What bursa? What is bursa comes there? What bursa
Suprapatal.
comes there? Anybody, what is that bursa called as? Huh? Is there another normal bursa which is the normally present a bursa? Prefetala, medial, lateral, which bursa?
Coming not a regular bursae, there are regular anatomical bursaes are there. Bursae is there in the cruciate area, it is called
as adventitious bursa.
Make some adventures.
Adventitious adventitious bursa that can get inflamed. That's called bursitis. Then what are the other causes?
Compression.
Okay, compression of the soft tissue.
Soft tissue.
Okay. And fracture of the skull. These are the common and the change in the malignancy. Okay. Is he having similar swelling anywhere in the body?
No, sir. No other swellings in similar swellings in the body. No.
Okay. What do you do?
So I like to take one X-ray of
Suppose
the
you
distal.
said there is a possibility of malignancy change.
Yes,
In an osteochondroma, when it goes into malignancy, what are the radiological changes you see?
Change in the
What malignancy, before that?
What malignancy you get?
What malignancy you get?
Going into what?
Chondrosarcoma.
Chondrosarcoma of what? Anybody? The
Cartilaginous gap of more than 2 centimeter secondary.
You don't get osteogenic sarcoma, remember that. You don't get osteogenic.
Secondary.
Chondrosarcoma.
See,
So what are the radiological changes you can get in the X-ray?
See, the one word you have uttered, malignancy, you see all the troubles coming.
Yeah.
Okay, now what X-ray? X-ray is there?
So there is no other differential?
It could be a parosteal osteosarcoma.
Sabash.
Oh. you are being given a trap, you know. Yeah, you got into the trap, you know.
Actually, hello. I think you are mixing up both the radiological and clinical findings. That is the reason why you are.
What are the clinical features of parosteal osteosarcoma?
No. Clinical, yes.
Clinical features?
Where do you see
pain,
it?
Pain will be associated.
Which age group you get? Which is the common site?
Pain will be associated with the swelling.
No. Which age and which site do you get parosteal osteosarcoma?
What is the difference between periosteal osteosarcoma and parosteal osteosarcoma? Because see, it was not there in my mind. See, this is the mistake you do in the exam. 5 candidates all would have told osteochondroma, and you suddenly come with a diagnosis that parosteal osteosarcoma. Then we, for a change for us also. So we'll start asking these questions. Okay. So unless you know the things, don't utter a word in the examination. That is a very important thing you should learn. This is important thing that you should learn. Now, what are the radiological findings to say? You said it is a pedunculated. Is it pedunculated or sessile?
Sessile.
Huh?
Partially.
Part of is pedunculated, part of is sessile. You don't get it. There are only 2 types of osteochondroma. There is not a mixed variety. Okay. See the base. How do you say the osteochondroma? What are the radiological findings to say that is the osteochondroma?
The swelling arises from the metaphyseal region and the swelling grows away from the joint line. There is a stalk which is.
How do you say that going away from the sun?
So the tip is growing away from the.
Okay, then anything else?
Borders. Yes, sir.
What is there which you do not see here?
Cartilage cap is not
seen.
Not seen on the
Now
X-ray.
you tell me what are the radiological findings when it goes into malignancy?
On MRI.
No, I am asking X-ray.
On X-ray,
The
X-ray
what
mineralization
are the
difference.
Features of chondrosarcoma.
On X-ray, the mineralization will be different.
What is that called as? What you see? Mineralization, what do you call that? Cartilage tumors goes into what? This is the clue. If you are ready, you can take up the clue, otherwise it's difficult. All cartilaginous tumors, they go into calcification. do not go into mineralization. So what type of calcification you see? What you see in the margin? It becomes hazy. And you can see a soft tissue swelling with specks of calcification. Sometimes called as popcorn like that type of picture you may get. Is there? No. Then you said MRI. What are the MRI findings of chondrosarcoma?
So MRI we are planning to get if the patient, if we are suspecting of malignancy.
You are suspecting, I am not suspecting. So you take a man.
In which cartilaginous cap thickness should be measured.
How much is it?
If it is a malignancy, it will be more than 2 centimeter.
Okay. That is the important.
Will you ask for an MRI in this case?
No. What do you do?
Depending upon the
Sir is asking one question. What is the difference between diaphasia,
Achalasia and
osteochondroma?
osteochondroma.
You heard of diaphasia achalasia?
so on the
If you are given a case of osteochondroma in the exam, there is every chance that you do very bad in the exam. Okay, this is a very difficult case in the exam, though it is very easy. Unless you have read everything about osteochondroma, it is very difficult. Similarly, malunited distal radius fracture. Be careful about when those, you should know everything about that. So, that also you should know. There is something continuous with diaphasia achalasia which is not continuous with the osteochondroma. I will not tell you, you have to go and find out what it is. What will sir is asking, what will you do? You do not want to take an MRI. You have seen this one, you are planning to diagnose. Now what will you do?
excision with the perichondrium.
Excision?
Excision with the perichondrium.
Perichondrium. What is the perichondrium? Where comes perichondrium? Nice. Where is the perichondrium normally?
On the base.
You are leading us so many questions.
So,
Pericardium, where will be the cartilage part of it? Cartilage part of it, where it will be? The osteochondrium. Base
On
or
the
tip?
On the tip cartilage cap will be there.
So
On the
naturally you will remove the tip. You are interested in the base or in the tip?
on the base. Question.
You are interested in the base or in the tip?
Base.
Base. So you said the counterpart is there in the tip. So where the pericardium comes from the excision.
You are removing along not with the perichondrium, you are removing along with the periosteum. That is called as extra periosteal excision. Okay. Now where will you put the incision? Transverse or longitudinal? Perichondrium, where will you get? Sir, where will you get perichondrium?
which age group?
Younger.
It's pediatric.
Younger age.
Yeah, the epiphysis is fused.
So, incision. Would you like to put the patient in prone or supine position?
Prone, sir.
Prone. Okay, great. Where will you put the incision? Transverse or vertical? See, these are the things which we ask in the exam. We know that tomorrow if I give you a degree, MS degree, whether you will remove his leg or will preserve his leg.
Which structure you are worried about during exposure?
Medial side structure you will bother about.
You are worried about which artery?
Adductor canal femoral.
Suppose this comes as a chondrosarcoma, what is your treatment?
Wide.
How will you proceed?
Margins.
Wide excision.
Any other investigation you will ask for before going to this? Sir said something, margins. How to know the margins of the
MRI can be done to
orthopaedic and MRI? Then any other thing else you look for? Chondrosarcomas, where they metastasize? All sarcomas metastasize into. There is a general rule in pathology.
Other route, apart from the results, see the lungs, how it comes to Wi-Fi.
So you have to take that X-ray to chest also.
Not through Wi-Fi definitely. There must be some connection.
It goes to the blood. Okay. Vascular. When this will go to the blood and goes to the lungs. And so you have to do that, and you have to wide excision, not the amputation. Remember that. Would you do radiotherapy if it is a chondrosarcoma? Chemotherapy, radiotherapy?
Chemotherapy can be.
Which one? See, these are the things we should know. Management of a chondrosarcoma also. Chemotherapy is not given.
So the important thing is a straightforward looking case. You will be asked all the peripheral questions, okay? Because the central focus is simple. Distal radius, very easy. Cubitus varus, very straightforward. You will be knowing and by heart, like you started off like what you read in the books, taka 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 taka. But then when it comes to the nitty gritty, then you're in trouble. Okay?
Yes, sir. Thank you, sir.
Thank you.
Thank you for the session, sir. Sir, we proceed for the coffee break now for the faculty. It's a request to all the delegates to please, there are 3 more cases to be taken. So all of you please come forward and volunteer. After the tea break, we'll have the next session. Kindly take cases.
Otherwise, they'll be picked up.
They will be picked up, yes, sir, definitely. A request to all the delegates to please submit your email IDs outside at the registration counter for certificates, please. All those who have not given the email IDs, kindly go to the registration counter and give your email IDs. A warm welcome to all after the tea break. We'd like to start the next session now. A hip case. I'd like to request Dr. Singara Vadivelu, Dr. Matthew Verghese, Dr. Ajit Kumar, and Dr. Hiranya to please come on the dais and be the chairpersons for the case. Thank you. Also requesting the other faculty to please add on to the case scenario. And the time duration for the session is 30 minutes. Thank you.
Good afternoon, sir. So my patient Bappi, 40-year-old male from Siliguri district, photographer by profession. He complains of pain over his left groin for past 2 months. Patient was apparently normal 2 months back when he developed pain over his left groin, which was insidious in onset, gradually progressive, radiating to his left knee, not associated with any limb, not associated with any swelling. Patient was able to weight bear and walk over the left limb for about 400 meters, after which the patient started developing pain. And patient also tells a history of lifting of a box which contained 10 kg of flowers. The next day onwards, he started developing pain. Pain was dull, aching in character. It was not associated, there was rest pain present, and patient also complains of night cries, and there was no other joint involvement. There was no diurnal variation of the pain. There was no history of any morning stiffness. There was no history of any waxing and waning of his pain. And patient initially consulted a local hospital, and the pain was relieved with medication prescribed by the doctor, and patient underwent physiotherapy, after which pain got gradually decreased. And now patient is not able to do his day-to-day activities, sitting prolonged time for about 10 minutes editing his photographs. And now patient can use Indian toilets, but patient cannot sit cross-legged for more than 30 minutes, more than 10 minutes. There is no history of, there is no past history of any.
Walking distance and climbing stairs.
Patient experiences, patient had history of pain while walking upstairs and downstairs, but presently patient is not having any pain while walking upstairs and downstairs.
And is able to walk any distance.
Now patient is able to, initially patient was able to walk around 200 meters. After that pain started coming. After medication and physiotherapy, now patient is able to walk more than 400 meters, 400, 500 meters.
He is able to walk.
Yes, sir.
And you mentioned about night cries. Can you just describe about night cries?
Sir, patient comfortably goes to bed, and in between the night, in between the sleep, patient is getting pain and is waking up due to pain.
Yeah, I think you're right in saying that, but yesterday it was mentioned, cries are in children. Adults, it is disturbed sleep.
Sir.
Okay? So just to clarify. You're given a fairly elaborate history. From the history, what do you think is happening there?
Sir.
You told patient has rest pain and also night cries.
Yes, sir.
Is there any difference?
Sir, a patient is on sitting comfortably, resting. The patient is also experiencing pain. And while going to sleep, there is decreased pain. And while sleeping, the patient is having more pain. And there were incidents where patient needs to get up. So the patient is having both rest pain as well as night pain, night cry.
So does the rest pain come down on walking early morning when he gets up? Or after
There
he
is
takes
no
rest?
waxing and waning of the pain, sir.
You mean is a dull ache all through the day, which is aggravated by sitting for prolonged periods and maybe
Sir.
sleep?
Yeah, it is dull aching pain. It's aggravated while patient is sitting prolonged, so that he is not able to work. He's a photographer. He sits in front of the computer and edit his photos. He is not able to work for a prolonged time. It's affecting his day-to-day activities.
So there is one thing about, you said that there was a history of lifting of 10 kg weight following which he developed pain.
Not immediately, sir. 10 kg weight. The next day he started. He's telling a history like that, which cannot be.
No, because if you say that history of lifting weight,
sir,
and the patient developed pain,
sir,
we tend to think of some other. What is that we?
Sir, usually back pain with radiculopathy, some slip
Granular.
disc.
And
Yeah.
you also said that there is a pain which is coming from the groin, which is
Radiating till the knee,
till
sir.
the knee.
Sir.
So when you are telling the symptoms, the patient will say attribute and things, so many things.
Sir.
So you have to process that and give the examiners what is which is relevant. You think that lifting of that 10 kg of weight, the next day, that pain, is it related and significant?
Yes, sir. I think it is significant. It might be a slip disc because it is a radiculopathy.
Right. You also think in terms of a slip disc.
Yes, sir. I
then
think.
you have to rule out all the. I mean, what are all the symptoms which you think?
Sir.
If it is a slip disc, you should say that. If it is radiating, is it coming in front or in the back?
Sir, yeah, it's radiating only. The patient is complaining. I asked him whether it is radiating throughout the limb till the toes, but the radiating pain is till the knee. Only anterior.
Coming on the anterior aspect.
Only anterior aspect, not posterior aspect.
Right. Then you have to say something about the claudication and about the associated sensory disturbance or anything. So
That
if you have
I have not
already
examined.
you are going to say that? No,
sir.
The history.
History, yeah. Patient is not complaining of any numbness, any motor weakness, or.
Because you are going to say these two. Because at the end of the examination, you would have come to a conclusion what it is. Is it a hip case which you are dealing with,
Sir.
or is it a spine patient, or it is combination of both, which is very, very rare.
Sir.
And then tell the examiner only the relevant things.
Sir.
So you think that it is still it could be a slip disc after the examination in your diagnosis?
No, after examination, I found it is not slip disc. Sir.
Then why do you want to? There are so many possibilities which, as the patient is telling, you would have thought, and then you would have come to a different conclusion.
Sir.
Then only filter that and say.
Okay.
Can a hip pain patient have a radicular pain like this?
Hip pain can radiate to knee, sir, because of its nerve supply.
Initially you thought of a slip disc also,
Sir.
but on the examination,
After examination,
then it is better that it
avoid
is also one of the things which he might have walked and he might have slipped. He might say also that.
Okay, sir.
That is the cause for that. Then all those things you can edit and then you can present only what are the relevant points.
Yes, sir.
Okay.
So moment you say disc,
Sir.
as a possibility
Sir.
and you've examined and ruled it out, please filter it out. Because your description is completely contradictory. Disc pain is never worse at night. Disc pain will never wake up in the night with night cries. And the moment you say disc related things, bladder bowel and sensory symptoms become dominant. You have to rule that out. So you've done the examination, you've taken the history, you know it's a disc or not a disc. So filter that out. It's easy, otherwise you're in trouble.
So basically from the history what we are trying to find out is, this is not very clear cut, whether it is inflammatory, whether it is infective, whether it is mechanical, some such clarity. So we're not able to come to any definitive thing here.
Yeah. So
Carry on.
there is no past history of any. There is no any. The patient is not. There is past history of COVID, but patient was not hospitalized. Patient was in home isolation on not on medicines for fever to control fever. There is no past history of any other surgeries done. There is no past history of.
Is the history of COVID relevant?
Sir, nowadays it is found that the patients with COVID are coming with more incidence of having avascular necrosis of femoral head.
Who are the ones who come? Do you have some
That's why,
idea?
sir, those who are under steroid treatment, but patient is not hospitalized, he was on home isolation.
Okay.
But that too, yeah.
So there is a conflict there, sir might elaborate, because COVID itself causes thrombosis, you know, in various areas, so it could. Okay, carry on.
So there is no history of any. Sir. Sir, then there is no. The patient is not having any comorbidities. The patient is not on any regular medications. There is no history of any blood disorders. Patient is a
One sentence.
Sorry, finish.
No, one sentence can you just finish off rather than going subheadings.
Okay.
He's a young, healthy individual, no other significant relevant history. Then.
Yes, the way you put it, you know, no history of any blood disorders. I mean, then I would like to probe further. How did you arrive at that conclusion? No history. So you have to be very careful in how you word it. No history suggestive of any other medical problem. Sum it up and finish it off. No, keep repeating, don't do that.
Okay.
If there's anything significant positive, say that. Significant negative, say that. Otherwise, no, don't. The COVID was important. Steroid is important. And that's okay. But beyond that, you have to be careful.
Patient is a non-alcoholic, but he smokes.
Again, in the first today, you were told about using the expression alcoholic. His lecture, if you heard, very clearly.
Patient doesn't consume alcohol. Patient doesn't consume alcohol, but patient smokes 4 to 5 cigarettes per day for past 10 years. There is no family history of any spondyloarthropathies. There is no family history of any inflammatory disorders running in the family, and there is no other relevant history, sir.
Carry on. Don't wait for the examiners to.
Don't wait for them to open their mouth.
Sir,
Exactly, we'll be in trouble.
Keep going.
Keep talking so that they
Sir,
will keep quiet.
from the end of my history,
Nobody asked you.
so coming to exam.
From the entire history, what do you want to say?
So from the end of my history, I would like to give differential diagnosis of.
Sir, ask.
No, after that I said that.
Oh, I'm sorry.
Just go ahead. Yeah. Go ahead, tell whatever you want. After the history, what do you want to say? What are the things you want to suspect from the history?
So from the history, I want to suspect the patient is having a arthrosis of the left hip. Might be due to osteonecrosis of early stages of osteonecrosis of femoral. Might be due to osteonecrosis of femoral head, because patient is complaining of rest pain, and
any other diagnosis?
Patient complains of night.
Then you can say. You're just telling us the possibility. One is
close.
Can you stand still? I can't. I'm poor at shooting a moving target. Stand still.
Okay, that is right then.
Then patient might be having a arthritis, evolving arthritis due to post tubercular ulcer and infective arthritis.
So you want to think in terms of degenerative or an
infective condition. So now 2 months, aggravated since 2 months.
So these are the two possibilities you have.
Sir. Sir. So now coming to the examination. So patient was having coming to general examination. Patient was having no fever, no pallor, no icterus, cyanosis, clubbing, lymphadenopathy, edema.
Anything significant in general examination you want to say?
Nothing, sir.
If
Chest
there is
expansion is
nothing,
normal.
chest expansion
Is normal, sir. 4 centimeter.
4 centimeter.
Then gait is bipedal unassisted gait, sir. Bipedal unassisted normal gait. Bipedal unassisted gait.
Normal gait.
Is it normal gait?
Yes.
Can we see him walk?
Yes, sir.
Just make him walk.
Yes, sir. Just tell. Thanks. So local examination. The patient was inspection, sir. Patient was examined on supine as well as standing. On standing, head central, bilateral shoulder same level, bilateral ASI is at same level. There was gluteal wasting present over the left side.
Finish off front, side, back.
Sir.
That sequence.
Sir.
ASIS and gluteal fold is.
Okay. Sir, bilateral head central, bilateral shoulders at same level, bilateral ASIs at same level. There was no visible shortening. Then there was no exaggerated lumbar lordosis.
That should come before ASIS. Go from up down, head to toe.
No, he wanted to say that
Front side.
Front side and back. So front he has finished the anticipally explained. Then he comes to side.
Front, sir, scarpa triangle. There was no swelling present.
No, that you are going to say it in on supine position, no? Only things which are specific to standing. Okay.
From side, there was no exaggerated lumbar lordosis. From back, bilateral gluteal folds were at same level, and there was wasting of the gluteal muscles gluteal muscles over the left side. There was no scar, sinuses, deformity present over the hip and spine region. So now, coming to the local examination of hip, sir. Bilateral hip on supine, while ASIs was at same level. Bilateral GT was at same level.
What is GT?
Sorry, greater trochanter. There was no exaggerated lumbar lordosis. Bilateral anterior superior spine was at normal level. Bilateral greater trochanter was at normal level.
It's not normal, same level.
Same level.
You're
Same
looking.
level.
Don't say bilateral. Both ASIS are at the same level. Yeah.
Both
Go down all the way to the
foot.
ankles or foot. Yeah.
Both patella were facing outward and lateral, and foot was extend rotated and plantigrade. Then local examination of the left hip.
How is the limb? Is it shortened or appear shortened?
On inspection, the limb, there was no limb leg discrepancies noted, sir.
So quadriceps wasting or anything?
No quadriceps or calf muscle wasting on examination.
If you had just said both malleoli at the same level, that question wouldn't have come.
Like
You minimize the questions that you will be asked. Yeah, from the side.
this is convexity and this convexity, you think that it is the same? Without touching. Is it the same?
No, sir, there little bit of decrease.
Yes. So all it needs is only 10 to 15 days for the wasting. There is definitely wasting. Is it not?
Sir, inspection of the inspection of the.
Because if you say it's wasting, I'm not going to come and see. 2 months time when there is a pain in the hip and you say there is no wasting, I mean always there is a possibility that I will come and inspect. Okay.
Sir, coming to inspection of the left hip.
Coming to, going to, all those terms best avoided. On inspection, now you finished the front.
Yeah.
Now the side, lateral side, what do you see?
Sir, on lateral side, the bilateral GT is greater.
You cannot come out of GT, no?
Again GT.
There is
all SMS language.
So there is no scar sinuses swelling present over the lateral aspect of the thigh. There was no swelling present over the gluteal aspect. Now, on palpatory findings, sir. Palpation of the normal hip. There was no tenderness present over the
normal hip.
First palpation normal hip.
Why do you want to do that?
You finish the affected side first.
And
Why do you want to go back and forth?
Yeah. You don't go.
When you say normal side, it means everything is normal. Then why do you want to say again? You come to.
But we assume you have done that. You don't speak out that. Finally, you can say the opposite hip, same side, knee, spine, sacroiliac joint. They are found to be clinically normal. Or if there is any finding, you have to say that. Not when you begin say. You always assume that if there is some wasting, if there is some swelling, you are always compared with the normal side. Right? Okay.
Sir, on palpation left side, there was bilateral ASIs was at normal level, sir. Bilateral same level, sir. Bilateral greater trochanter was at same level. There was no tenderness, warmth, or any pulsation present over the Scarpa's triangle.
See, trochanter is on the lateral side. Okay, Scarpa's triangle is in the front. So why are you flipping from one side to the other? Why can't you finish in one sequence? That's the way you should present.
There are few points which you have to say when you are talking about Scarpa's triangle. Anticipally explained, you have finished. There is no exaggerated lordosis, first you should say again. Even on palpation. Inspection, you don't see the light. But does it always mean that there is no exaggerated lordosis? My statement, is it right or wrong? When you are not able to see the light on the opposite side, when you are not able to find out exaggerated lordosis on inspection, is it necessary to do in palpation also or not necessary?
Yes, sir, it is necessary.
Then you must say. Why?
Because if it is an obese patient and all, light cannot
Flabby
be
flank and obese patient, still the spine may be exaggerated and you may not be able to see the light. So that you will have to say. Start with exaggerated lordosis from above and then come to the anticipally explain. Both are at the same level. Here there is no exaggerated lordosis.
No exaggerated lordosis.
Right. Scarpa's triangle, what are the things you want to say?
So Scarpa's triangle, if there is any warmth,
You just tell about this patient.
this patient, there is no warmth, there is no tenderness, there is no swelling palpable over the Scarpa's triangle. Bilateral femoral pulses were palpated. No tenderness or Scarpa.
I think he's going to present the normal report. Okay.
All findings are normal. So what is positive?
Sir, left anterior joint line tenderness was there, sir.
That's what he's asking.
That's what he's asking.
Where is the anterior joint?
That's what he's asking. Is there tenderness in the Scarpa's triangle?
You said Carpa triangle, there is no tenderness. Now you say there is an anterior joint line tenderness. Where it is, joint line is where it is?
Anterior joint lines are from pubic symphysis to GT and lateral.
So this
no, just so greater trochanter.
Just relax. Relax.
These are all the questions you.
I know you are a good student and you are doing well normally, but in the examination these things will happen. So suddenly if things are not working out, you just as sir was mentioning, take deep breath and pick up yourself and then start again.
Relax.
Right.
You are doing very well in the history.
Yeah.
What has gone wrong here?
There cannot be. Okay.
Sir. No, sir.
Yeah, tell.
Relax, please. Tell.
Sir, anterior joint line tenderness was present. Tenderness was present over the Scarpa's triangle.
No, where is the tenderness you felt?
Sir, I have drawn a line from pubic symphysis to the greater trochanter. In the pubic symphysis to anterior superior spine, and the lateral 1/3 I felt the tenderness, sir.
Lateral 1/3.
Still
feel on the inguinal ligament there.
Now you're trapped.
The,
Now you're trapped.
the junction between the.
You know what is midinguinal point?
Yes, sir.
Something to do with midinguinal point or lateral root and medial symptoms?
Midinguinal point.
I think posterior, anterior, you are all confused.
You're mixing up the posterior joint line and the anterior joint line.
Right? That is why the all these things are difficult.
So you need to take a deep breath, relax,
Right?
and
Again,
then start again.
we'll start afresh.
So where is the anterior joint?
Sir, anterior joint line. Sir,
You
from
continue, don't worry.
sir, it is the midinguinal point, sir.
Midinguinal point, is it at the midinguinal point or below and
Below 2 centimeter below and lateral to the midinguinal point.
why do you choose that point?
Sir,
So the joint is there, it's a fairly oblique, long space, around 45 millimeters, that's the average diameter of the femoral head, no? The cup will be around that size, it is about 45 millimeter, 4.5 centimeter. Why do you pick that point?
All the whole head of femur is exposed or something is barred in that area?
the hip joint.
All of that is hip
Not
joint.
of them.
All of that is hip joint. Okay, so anybody from, why do you put your thumb there and say that there is no tenderness in the Scarpa's triangle at the anterior joint line? It is part of the Scarpa's triangle, in the anterior joint line. That is exactly the site where you have the femoral artery. Isn't it? Femoral artery is also there.
Femoral head.
So the extraacetabular portion of the femoral head is palpated. So any pathology on the femoral head, when you press there, you will be able to elicit it. The femoral head is not covered completely by the acetabulum. It is only 5/8 covered. Rest of it is uncovered. If all of it is covered, you will have no hip movement. It will be restricted movement. You will have to have a very thin neck for range of movement of the hip. The range of movement of the hip is because part of the head is uncovered and the neck is smaller in diameter than the diameter of the femoral head. That is why you have such a good range of movement of the hip joint. So that extraacetabular portion is what you see in the extended position of the leg. That is exactly there. And you palpate there for tenderness on the extraacetabular portion of the head. Is that clear?
Yes, sir.
Otherwise the joint line is 4.5 centimeter. It's pretty big.
Go ahead, go ahead.
Sir, sir, movements.
No, you have mentioned only about this Karpa's triangle. There are other things which you have to say.
No. Before you say movement, so there is a sequence. Look, feel, move, measure, but feel in palpation.
Sir.
Before you talk about movement, you set the limits of movement first by looking at other area deformities.
Sir,
You
palpation.
don't finish anything.
Sir, palpation coming to the greater trochanter, there was no tenderness over the greater trochanter and there was no broadening or there is no widening of the greater trochanter. Both the greater trochanters were at the same level, sir. And
Surface is
smooth,
and there is
no.
tenderness per se on the trochanter. And any other trochanteric tenderness you wanted to feel?
Bitrochanteric.
So all those things you have to say. Was it there or not? Bitrochanteric tenderness.
Bitrochanteric tenderness was not there, sir.
You
Yeah,
saw that?
bitrochanteric tenderness was there. Thrust
tenderness.
was there, sir.
Thrust tenderness was there. but
Thrust tenderness was there.
But no anterior.
Anterior joint tenderness was there.
Change.
It is there, it is there.
Okay. So then
Sir,
posteriorly.
Posteriorly, there was no gluteal mass palpated over the gluteal region, sir. There was then bilateral gluteal folds were at same level. That inspection is. So then coming to movements and deformities.
First deformity. You don't have to keep coming and going. Sometimes you come into the front, sometimes you go
was no deformity noticed.
Reading a novel, and at the end of the chapter, the next chapter going to come to this. It's so jarring.
There was no deformity noted, sir, or no fixed deformity noted. Sir, there was external rotation deformity.
There is a fixed external rotation deformity.
Yeah, there is a fixed external rotation deformity.
Okay. How much?
Sir, fixed external deformity, external rotation deformity of 5 degree, and further external rotation of 5 degree was possible. No, sir, fixed external rotation deformity of fixed external rotation deformity of 35 degree.
You need to increase your RAM.
Fixed external rotation deformity of 20 degree, further external rotation of 45 degree was possible. For further external rotation of total external rotation was 45 degree.
Demonstrated now. Now we are also confused. We are not sure.
Do you think
You're stressed and we are confused. Let's see, do it together. We'll demonstrate what you're saying.
No, do the field look identical?
Yes, sir.
Yeah, right side. Do the patella point in a similar direction? Where is 25 degrees?
From the neutral, I cannot internal rotate from neutral.
So you just see fixed external rotation, you just demonstrate,
From
and
here,
then
maybe 5 degrees more. No, maybe 5 degrees.
5
From
degrees.
here,
Yeah?
Sir.
slightly more.
If anything, which is the affected hip?
Left side, sir.
Left side. If anything, this is more externally
yeah, from
rotated.
here it is looking. This is
The right side looks more externally rotated. If anything. Yeah?
so the better way is to see you have seen an extension, correct?
Yes, sir.
Right. Which position you saw?
Supine.
Or
Supine position.
right. If you want to demonstrate with the entire leg acting as a pointer to demonstrate that there is a fixed external rotation deformity, make the patient lie prone, and then show us
Far more reliable.
far more reliance, right?
Sir.
Yeah, yeah.
And then show that there is a fixed external rotation deformity of. So
Yesterday you were told, explain to him
Yes, sir.
and make sure you don't cause pain.
इससे करना पड़ेगा कुछ होगा नहीं है ना ओके दर्द आने के बाद बताइए
now why do you want to handle the foot? Are we seeing a thigh foot angle or are we seeing the hip rotation?
sir
See, he explained to you yesterday, and you only explained. It's like the dial of a clock.
yes, sir both side
Okay, so the leg is what you're looking at, not the foot.
sir
You're looking at the leg. It's not a foot thigh angle that you're looking at.
So is there
From
an internal rotation possible?
internal rotation restricted sir
No, which is internal rotation you just showed?
sir this is internal rotation
Yeah. So is there internal rotation possible in the left hip?
no sir loose थोड़ा loose relax ढीला छोड़ो
Actually, he should be telling you.
You see the left hip alone. Is it internal rotating? Why do you want to come to neutral? Just internal rotate and then see whether internal rotation is possible.
no sir pelvis is moving
Slowly keep on doing. Right. Is it internal rotating from the 0 degree or not?
no not rotating
No, you are bringing it and then showing that there is no internal rotation.
sir but when I do that pelvis is moving sir
It doesn't seem to move. Internal rotate? Rotate? No, internal rotate. Now you just stop there. Now is it pelvis moving? No, just it was little bit more also.
Leave it. Relax over. Around. So, yes, coming here. This is
neutral sir
neutral position.
Is it neutral?
ढीला छोड़ो, बिल्कुल ढीला छोड़ो. इधर. ढीला छोड़ो.
10 degree or 20 degree is it coming? But you said
You
there
have to
is-
agree when he's asked that.
So you said that there was 20 degree of fixed external rotation deformity. But now you are able to demonstrate, even if it is coming to neutral, we'll agree with you. Then is there a fixed external rotation deformity?
No, sir.
No. Right? So it is always better if there is an external rotation deformity to make the patient prone and using the entire leg as a pointer. You can just see. That will give you a good idea whether there is a fixed external rotation deformity. Because with this, foot acting as a pointer, patella acting as a pointer, lot of times you will find it difficult. The leg will be a bigger dial. Okay.
The same thing can be repeated at 90 degrees by asking him to sit down.
Sit down.
Just with the leg hanging down. So with the
Now the
thighs
hip is 90 degree.
No, ये आप नहीं push करो, relax करो. Are they hanging vertically?
It is see from front.
Are they hanging vertically? I can't see. Asking.
See from front and then say, are they hanging vertically or is it rotated?
Vertically.
Almost symmetrical.
Symmetrical.
Almost symmetrical. So, if that is so, then there is no external rotation deformity. If you had an external rotation deformity, this side will remain like that. That's external rotation. He may have restricted internal rotation. Significant restriction may be there. Only maybe 5 or 10 degrees is possible, as we saw.
Even if it is 5-10 degree, there is no external rotation deformity, correct?
Sir, yes, sir.
Right. How much of external rotation now itself you see? Because having sir made him
How much is the range?
range you tell now.
Range of ROM.
Just see the internal and external rotation. Just see now. It's blanked out. It's blanked out.
Actually,
Right. Just
external
gentle.
rotation.
Look at so how much?
45 degree external rotation is
Right. Internal. Don't
Look at his face. Don't look down.
Yeah. Right. And now pelvis is moving up.
Yeah.
So how much internal?
some 10 degree.
10 to 20 degrees. Similar to what you was in.
So there is no differential rotation. What you saw in extension, what you saw in rotation, yes, 5-10 degrees in extension, 5-10 degrees in flexion, 90 degree flexion. If you had a difference between the two, you would say it's a differential. Is that important?
Yes, sir.
Okay.
What does it mean?
Sir, if differential rotation is present, then it's that particular area of the femoral head is affected. Anterosuperior part of the femoral head is affected, which is restricting the rotation. It's mostly commonly
So
seen in
when a different part of the femoral head, which is affected or unaffected, comes into the articulation of that joint, then you have a change in rotation. Okay? So part of the head is flattened, part of the head is oblong, then you have this differential rotation. It is usually suggestive of a collapsing head.
I think you are overshooting, sir.
Other movements?
Sir, other movements are within normal width. Other
Okay.
movements are within normal width.
The rest of the thing, there is nothing. That's all. Yes, sir.
Sir, special test, there is a Trendelenburg survey is negative. There was no telescopy. Telescopy was negative, sir. And
Measurements?
measurements, the true length was, apparent length was 110 centimeter bilaterally. True length was 79 centimeter bilaterally, both equal, sir.
No, is there any short?
No difference.
No difference, sir. And base of the Bryan's triangle was 3 centimeter bilaterally. And shoemaker's line.
It can't say.
It can't say. Shoemaker's line was bilateral. Shoemaker's line was intersecting at midpoint, sir. And Cheney's parallelogram was parallel to each other. The lines were not converging or diverging.
There is no limb length difference as confirmed by all the tests.
Okay,
sir. Your ASIS and your malleoli are at the same level. Your measurement from the ASIS to malleoli on both sides is the same. Pelvis is square. So there is no question of.
Negative.
Trendelenburg.
Negative, sir.
He said it is negative.
Negative, sir.
Yeah. Anything else you want to add?
It may be positive. Trendelenburg, for the benefit, can you demonstrate?
I'll stand behind the patient, sir. Then.
Take a step back. Take a step back. Otherwise, leave the. एक कदम बस.
ये पर ये पर ये ये पर फ्लेक्स करो, ऐसे करो, ऐसे ऐसे हाँ 20 degree 20 to 30 degree. The left side is affected.
Other side?
That's not the way to do it. You should kneel down.
Right.
You should go down to the level of the
gluteal fold.
Your eye should be at the level of the gluteal fold. Get this right. Make sure the gluteal folds are there. Ask him first on the normal side.
Sir.
This is the normal side.
Sir.
पहले इस पे खड़े हो जाओ. So the way to do it is, again, I'll repeat, I said this once. This is in literature. Patient stands with his hands crossed like this. His limb-length discrepancy is compensated. Limb-length discrepancy is compensated and with blocks. And normal side is lifted first. Knee is not flexed to 90. That's very unstable even for a normal person. It's flexed to 30 degrees. Then ask him to watch from the gluteal folds from the eye at the same level as the foot. Do that.
Right.
It doesn't seem to be dipping.
Phone. Okay, you summarize.
So in either joint you saw?
Sir, bilateral inspection of the bilateral knee joints were within normal limits, and spine within normal limits, sir. Sacroiliac joint, there was no tenderness palpable over sacroiliac joint. Sir, 20-year-old male complaining of left joint pain since 2 months with night cries with.
You need not say everything.
Okay.
So tell the diagnosis that you have. Diagnose.
Sir.
After the triangle in the OPD card, what did you write?
So my probable diagnosis is avascular osteonecrosis of arthrosis, evolving arthrosis due to osteonecrosis of left.
Anatomical diagnosis, pathological diagnosis. Anatomical diagnosis is
Early arthritis.
You know,
Arthritis, early arthritis of the
synovitis, arthritis, fibrous or bony ankylosis, coxa vara, unstable. These are the 4 diagnoses which you have to say. In all these 4, what does it fit in?
arthritis, sir.
Why do you say arthritis?
It's because the
For arthritis, what are the features you require?
for arthritis, for late arthritis, the chronicity should be there.
Don't say about late or early and the duration. That are only clinical finding. To say as arthritis, what are the clinical features you must have to say as arthritis?
So restricted joint movements, limitation of joint movements, then pain throughout the movement of the joint. Then then if it is inflammatory arthritis, there will be wax gain.
No, not history, only clinical examination.
Clinical examination.
Joint line tenderness.
Joint line tenderness.
Fixed deformities will be there.
Maybe.
Maybe.
Then available range of movement is restricted in all planes, right?
Yes, sir.
And the available movement will be painful.
Painful.
And there should be true shortening.
True shortening.
Because of loss of cartilage. Arthritis means loss of cartilage which can be up to 1 centimeter, both considering the acetabular as well as the femoral side. And then the bone starts hibernating. So joint line tenderness, fixed deformities may be there, range of movement must be restricted in all planes, and available range of movement must be painful, and there should be shortening, true shortening. Right, of all these things, what are things you have in this case?
joint line tenderness is there. That's the only finding.
That's the only find. No fixed deformity, available range of movement is painless. Only the extreme. In flexion, abduction, adduction you didn't say, but were they restricted?
No, sir.
Everything was full.
Available
Movement was also painless.
All,
he was not having any antalgic gait.
No, no, sir.
No shortening.
No,
No true shortening. Still you want to stick on with only, and he was having some spasm.
Sir.
Correct?
Sir.
So you want to stick on with arthritis at the hip? Because that itself I can test.
Early arthritis.
Why you are stuck to arthritis?
Because
why early arthritis?
Because all these typical findings will be
what typical findings?
This entire range of movements restriction, then
all end stage.
And
yeah. So yours is early stage.
What will you get in synovitis?
Sir, the terminal movements will be painful. Terminal.
Apart from that, the range of movement will be painless. Terminal range will be painful.
Painful.
So,
deformity will be flexion external rotation to accommodate more fluid in the joint.
So is it more in favor of that or this? Okay, right.
I would like to.
What's your diagnosis anyway?
Right. The pathological diagnosis.
Pathological.
That because, right, some may agree, some may not agree. I will not agree. If you are saying is arthritis, there is no feature to say that. Then, if you are going to pathological diagnosis, tell about pathological diagnosis.
So pathological diagnosis I couldn't figure out after examination. I need an X-ray and MRI investigation too.
No, what are the provisional probable diagnosis? Because the first diagnosis will think that that is the diagnosis you are keeping in mind. The other possibilities will come later. First diagnosis.
First diagnosis can be. So first diagnosis. So first, this is osteonecrosis of femoral head or tubercular arthritis.
Ooh.
Yes, because. Yeah, because
see, young man, 20 years, very minimal symptoms, just started 2 months ago. Why can't you think of ankylosing spondylitis early? I know you're talking about night cries all the time and no early morning stiffness, but you've not told us about his chest expansion. You've not done the Faber test.
Chest
I mean
expansion.
the.
Yeah, chest expansion was normal, and there was no tenderness over the sacroiliac joints.
Okay, okay. So can it still be?
So bilateral sacroiliitis is the pathognomonic feature of ankylosing spondylitis. Patient more complaints of gluteal pain.
When so many things are not fitting into avian and you're giving a diagnosis of avian, why can't you consider this also at least as a second?
Sir, here axis deviation was present, sir, which is typical of avian, and I could
okay.
So, because osteonecrosis is a radiological finding. The sequelae of osteonecrosis, secondary arthritis due to collapse and then the arthritis developing, that is the diagnosis you can say. Here it is looking like a synovitis stage, right? So in that condition, first diagnosis as avascular necrosis just because he has night cries or the rest pain, and he is not not an alcoholic and no history of any steroid intake. Very, very difficult as a first diagnosis, right? That might come later, but the other diagnosis, inflammatory arthritis or any other diagnosis may be more appropriate than the avascular necrosis.
I mean, I wouldn't put too much negative on putting AVN first because it's so common now. So you can justify it. It is synovitis, possibly secondary to this, or can be tubercular also, but that's later. But I wouldn't put past AVN as a possibility, but synovitis stage is what should come in. The synovitis, you have no other physical signs. Only thing is painful movements, and not all movements are painful. He is allowing so much of flexion, isn't it? He was sitting so nicely. so much of flexion. So if so much of range of movement is there in flexion, and that much of abduction was also there, so you wouldn't put it as arthritis as such. Frank arthritis is not there. Synovitis secondary to avascular necrosis is a possibility. Infection, inflammatory I would keep lower. Why? Waxing and waning is not there, morning stiffness is not there, chest expansion is normal, sacroiliac joints is normal, so I would keep that lower. Persistent dull aching pain, you can keep low grade chronic infective. Low grade chronic infective is a possibility that you cannot rule out without seeing the X-ray or MRI.
Already has come and he has already seen, right? What do you see in the X-ray?
Sir, X-ray showing pelvis.
Yeah, only the positive because already not more like only the positive things. Yeah, that is better he feels. This is better he feels. Yeah, just tell.
Sir, there is the left side femoral head congruity is low, sir.
Congruity
means
is
no, there is a left side femoral head defect is seen. Sir, here it is.
No, that's a phobia.
That's a phobia.
No, but it is wide.
So
That's a phobia.
No, do we see the defect on that side?
That's because the rotational problem is there. The hip is in external rotation here on the X-ray. Lesser trochanter is seen more. So you're seeing the phobia more clearly.
Do we see it even if it is area you want to stick on to, and if you want to see a defect, is that the first area which will go in for defect? That should be a weight bearing area.
Weight bearing.
Supralateral. So that is the medial most.
Middle most.
Okay. So you don't see a defect there. And that is a phobia. Okay. Then
Start with joint space.
the density of the bone, how is it when compared to the opposite side?
Sir, left side the density of bone is decreased, sir, compared to the.
Is it only the femoral head or even over the acetabulum? Head, neck, trochanter and in the acetabulum. Periarticular osteopenia.
Juxtaarticular osteopenia.
So what is it?
So more of inflammatory conditions. First
No,
condition.
but if you see here, if you compare, the subchondral bone here is nice and white. Subchondral bone here is not nice and white. That if you see here, the subchondral bone, and that's very typical. If you increase the brightness up, so the see the subchondral bone there, it's white, but see the subchondral is not as white as on the other side. It's not as white I would expect it to be. Inflammatory arthritis, the subchondral bone would appear sclerosis. Infective arthritis, especially tubercular or synovitis, the subchondral bone would look osteopenic. If you have subchondral bone osteopenia, think of non-inflammatory conditions. So here, it's all over osteopenia. It's all over osteopenia.
So, looking at this X-ray, what will be your first step? Now we want to revise. First diagnosis you had was avascular.
Yes, sir. Revise the.
Now what will be yours?
Go ahead, don't keep quiet.
Sir, juxtaarticular osteopenia is present, sir.
So much of osteopenia, 2 months history, sacroiliac joints appear normal almost. So what do you think it is, inflammatory or infective?
Constantly reduction of joint space, then inflammatory.
See, there are two things. There is the infective and inflammatory, two things.
Sir.
But to say inflammatory, what do you think, inflammatory condition?
There will be constant reduction of.
No, which condition? What do you think?
Yeah, in males, ankylosing spondylitis.
Ankylosing spondylitis. Okay. Or any other seronegative arthropathy. And it is only 2 months history now. Okay. So much of clinical findings, so much of radiological findings. Sacroiliac joints appear almost normal. Or is it affected? Sacroiliac joint, which part you have to see, lower part or upper part? Yeah, one side it looks no, because ankylosing spondylitis cannot affect only one part. It is a systemic disorder. So now coming to this one, because of the short history, probably you may have to think about an infective pathology in this condition. Sir, what do you think it is? Other diagnosis. Is a pathological, your anatomical diagnosis synovitis, isn't it?
Sir.
There is terminal restriction of all the movements, isn't it? All the movements are restricted, isn't it? Then there are no deformities.
No deformities.
There is no shortening.
Would you like to have any other X-ray?
What you'll do from this?
Proglateral view.
What you'll do next?
Any additional information you got?
Sir, that joint space is now little bit of widened, sir, left side. The medial.
Sir has asked, did you get any
Superior-
additional
superior
information
part-
in this?
Superior part is joint space is reduced, sir. Proglateral will come back to the opposite side.
Okay. Now what you'll do from this next?
Sir, we'll ask for an MRI.
MRI. Yes, yes, they put already.
Sir, this is the MRI showing pelvis with both hips with
You see, you have got some clue in the lateral view.
Sir.
You have got some clue in the lateral view. Go ahead, straight forward. Go back.
Don't put this case. You change this. Here it is. Yeah, it is there, but this right here. So you change this.
see the third row, second. Yeah. You see the head, you can see from a distance.
Yes, sir.
Okay.
So do the blood investigation whether it throws out any light or not, and if possible, try to get a needle and take a biopsy, and then what is proceed with.
Sir, you need to go for biopsy now.
You look for the inflammatory markers, confirm they are abnormal or normal, and then proceed further. And if they are unremarkable, I would put in a needle and they would do a biopsy.
.06 with the CRP, otherwise all blood investigation is normal.
Per liter or deciliter? How much is the normal value? Don't know.
So only any synovial you have to aspirate, or you have to go for biopsy, or directly go for body compression, or directly go for DHR. I don't know. Please throw the light, sir, please.
I would, yes, bisphosphonates. I think this is transient osteoporosis of the hip or bone marrow edema syndrome. So wait, watch, see how he evolves over the next 4-6 weeks.
You give 4 milligrams, 5 milligrams, sir? 5 milligrams. How long you want to watch, sir?
No, that is to be followed by 1.
Okay.
Blood report
Sir.
is normal, he says.
No, I think we should, like how we give for avascular necrosis, whether it is avascular necrosis or transient osteoporosis of the hip, the treatment remains bisphosphonate nowadays. So we can always give IV zoledonic acid 5 mg followed by oral, whatever, twice a week regime.
Another net immediately. Yes, sir. You agree with that?
Anyway.
I would add.
I'll not go in for
I'm the devil's advocate on this. I'm the devil's advocate. I have any number of bone marrow edema cases which I'm following up. No bisphosphonate, all resolved completely. They resolve completely without any treatment. Without any treatment. It's a natural process, it heals completely. I started my thesis, this current thesis which is ongoing right now is avian. And none of my patients get bisphosphonates. I'll just explain. Again, as students, your job should be to critically evaluate literature. I also started doing bisphosphonates. Then I tried to analyze why does it appear like this? So in normal avascular bone, how does it become vascular over a period of time? Perthes disease, it vascularizes, it becomes nicely vascularized. Even this, by the time it vascularizes, there are arthritic changes because the mechanics that are involved. It is arthritic by the time, so you have a problem there. So the vascularization process is by creeping substitution. And how does creeping substitution happen? By neovascular genesis that is there. So yesterday there was a discussion on vascular stimulants to the vascular neogrowth that is there. So how does that happen? A blood vessel can grow in if it is created a channel. And what creates the channel? Your osteoclast. What do you do by bisphosphonates? You're preventing osteoclast from functioning. So what you're doing actually is delaying vascularization by preventing osteoclast from being functional there. So you're delaying. So when you delay that, the collapse of the femoral head is also delayed. So you think that you're actually healing or preventing collapse by bisphosphonates, you're only delaying the recovery process in a much longer way. The results, again, how did I start thinking on this? Because of my work on fracture neck femur, which was a golden jubilee oration thing that I gave, fracture neck femur. So when I looked at the literature, the percentage of avascular necrosis which happens in fracture neck femur varies in published literature right from 30s onwards, from 12% to 86%. That's the description, from 12% to 86%. So if such a wide variation, there is something wrong either in your denominator or your numerator, because no statistician will accept that variance. in a normal population of a particular condition. So when do you have, then I looked at the papers again. When I looked at the papers, the variation was happening because of the time for endpoint for classifying it as avian or no avian. If it is 6 months, the results are somewhere between 12 to 20%. 6 months to study for avian. If you make it 2 years, immediately jumps to 29%. If you make it 4 years, it jumps to around 30 some percentage. So it's the duration of follow-up that helps you diagnose. And in the past, we can't compare because they did not have MRI. They only had X-rays. So we cannot compare with past literature. So we need to have a robust, randomized control, future study which will only resolve this problem. It is a total conundrum in terms of validity of the research protocol. So if you follow the Indian article which I mentioned yesterday, I have reviewed it in my journal club, I have reviewed it and criticized it back and forth on all the flaws in that article. The endpoint is the catch, endpoint is THR. And the variables that are there as your controls, that is also a problem in that article. So I would say that article needs a re-review and re-understanding of how bisphosphonates, it delays, probably need to delay it to prevent collapse. So what are the factors? Again, in this, what is missing is a geographical select segmental area that we have in ordinary classical sectoral collapse that you see in normal avian. We don't see that here. That is the problem. That's why we're thinking of bone marrow edema, transient bone marrow edema, transient osteoporosis. That's a self-limiting condition. Even if you don't give zolendron. In fact, Dr. Brisha Madhuri is doing research work on zolendronic acid. She says categorically don't give it Matthew because we are seeing far too many complications with zolendronic acid. Give pamindronate. Don't give zolendronic acid. So these are things which are not resolved, but we are practicing on day-to-day basis. Do it. Keep doing your research. There's no end point. I don't have the end word. None of us have the end word. We need to keep an open mind on all this. That's all I can say.
Sir,
Sorry.
I'm really enlightened what you have spoken, but in the exams what student expect?
Yeah, sir. Can I just say, whether it was that wrist, it was that ankle, whether it is this hip, it is all your history taking, clinical examination, eliciting your signs and coming to a proper diagnosis. This, don't bother about this part at all. Just don't bother about it. This is all, absolutely.
But you'll pass or fail because whether you can justify it is synovitis, arthritis.
It's okay, but he is already 55, but you may get 60 if you get a good answer. For this point, what answer you have?
So, if he's in a gold medal running position, then if he says, sir, I have seen probably this looks like bone marrow edema syndrome, sabash, go.
But I feel in this case, there is a sectoral problem is going on.
Sectoral?
Personally, sir, do you, but see, only diffuse osteoporosis will happen only in one condition called Cox. Or just articular in inflammatory, but is neither fitting to anything.
No. So, if the candidate is clever enough to say, 2-month history, he is very healthy, no pain, only that night sleep is disturbed, it doesn't fit in with tuberculosis, at least in his opinion. If he justifies those points,
just rule out the infection and
absolutely.
Okay, no, weight bearing or non-weight bearing.
Forget about exam. If the patient comes to me in the OPD, what will I do? I mean, I can't make out that sectoral thing. There's a doubtful area. Maybe it is there. I would look at the stir. I would look at the stir. Yeah, there is something there.
Yeah, it is there.
Yeah, if that is there, then there's no doubt. It's avian. Then you go by this classical treatment method. You can, because all examiners would expect bisphosphonate, answer that. That's it. No problem in that. I'm just telling you, keep an open mind.
Bisphosphonate versus co-decompression. That's all in the exams.
So
the examiner will ask.
Again.
I may not ask. That's fine. Sir will ask.
Again, for co-decompression.
And I notice when I see this, I definitely ask. We'll wait for this, or already there is a change. You say this is normal, this is gone.
Yeah.
So do you want to wait to collapse, or you want to revasculate?
Sir, so looking at the picture, it's a 2-month history. Chronic pain, rest pain is there, and there is also a diagnostic dilemma. Also, if you see Dr. T.K. Shanmugam's classification of tuberculosis, There's an avian type of Perthes type of tuberculosis also. In children, he calls it Perthes type. There's an avian type also. So that may also be there. So I've had a patient in whom I have done a biopsy. It turned out to be tubercular. So you have core decompression. This is a case where I wouldn't mind, I wouldn't hesitate doing a core decompression. Because help me, two conundrums are solved. One, it will biopsy plus decompression, both are done. A bird in, with two birds in one shot.
Any condition, one should rule out tuberculosis, you mean to say at the end of the discussion.
Yes.
That's why golden word says, so tuberculosis is the one, it can mimic anything, it can cause anything except pregnancy.
So for the student, I would argue, sir, in this patient, he is having persistent pain every day, and I would like to, it looks like synovitis, I would like to rule out an infective process. Two ways of dealing with. If he says, no, doesn't it look like to be, it looks like transient. So two, if it is transient, reasonably certain, I would think wait for 6 weeks, repeat an MRI. Look at the inflammatory markers. If they're elevated, I will go and do a biopsy. If they're not elevated, wait for 6 weeks, don't do anything invasive, repeat MRI, and then plan for a biopsy. That's what I'll do. Sorry, we overshot significantly.
Thank you, sir. That was a very enlightening session. Proceeding to the next hip case, the clock is already ticking. Another thing I'd request, there are 2 more cases to be taken. I'd request the faculty to kindly pick up 2 candidates randomly to take up the 2 cases so that we can proceed accordingly. Thank you.
Chris presentation and Chris findings, no? Shivkumar is there and Srinivas Reddy sir is there. Sir, please. Shivkumar sir, Edward Nazar sir and Kamataka sir.
Come. Huh? What? You're presented? When? Call your neighbor. Baba, you look very intelligent. Come.
Good morning, sir. Good morning, sir. My name is Dr. Humaira. I'm from NRI Medical College, Vizag. I'm a second year postgraduate, sir. Today my... Good morning, sir. My name is Dr. Humaira. I'm from NRI Medical College, Vizag. I'm a second year postgraduate. Today my... Today my case presentation is on hip examination. Patient named Jayanta Sarkar came to the OPD with chief complaints of right hip pain and inability to bear weight from past 8 months. He's 48 years old. He was history of presenting illness. He was apparently all right 8 months back. Patient met with a trauma. He was in auto rickshaw and he was collided by another auto rickshaw, and after post-trauma he was not able to bear weight. He was not able to bear weight. During that, he was not able to. Pain was severe, and he was taken to home. During that time he was bedridden. After 2 days he went to his he went to hospital, during which he was taken radiograph was taken, and operation was suggested, and immediately next day itself he was operated for the same. After that patient was discharged on POD 5, and then post that he had regular follow-ups, and then after 1.5 for 2 months he was advised non-weight bearing. After 2 months he started partially weight bearing with his partial weight bearing of the foot was started. During that he had aching pain and he was not able to bear weight, and the pain was non-radiating. Pain was not radiating, and during that time he had no history of fall. I'll mention one more history point, sir, which I missed previously. During the history of trauma, he was bedridden for 2 days, and there was no open injury, sir, during that time. And after 2 months, when the gradual weight bearing was started, he was not able to weight bear. He was complaining of falling away. He is saying that he is not able to weight bear. If he tries to weight bear, he says that he will fall down. And during that time he didn't have any fevers or trauma during that time, sir, or past history, no history. He is a diabetic and is on medication.
What for years now?
He's not able to bear weight, sir, with this.
How long?
8 months.
No.
Yes, sir. 8
Now,
months.
after the study, he started bearing weight 2 months after the surgery, and over the 6 months, is the problem has progressed or it is remained the same? That's what.
It has progressed, sir.
His pain has increased, disability has increased.
Pain has progressed and disability has also progressed, sir.
Okay.
When he started off partial weight bearing with toe, he was not able to do activities, sir. Even now, the pain and both of them has progressed.
How is he? What is he doing? Sir is asking that. He has to use a walker, crutches to walk.
He has a walker, sir.
What about his other toilet purpose? What he does?
Whether he can able to sit and squat.
You didn't ask. Okay, fine.
So you said about the auto was stopped. Is it a severe trauma or a trivial trauma?
That was a severe trauma, sir. For
Severe
which,
trauma.
yes, sir. For which he was operated, sir.
He was, he went
yes,
to the
sir.
hospital after 2 days, and immediately after the went to the hospital, he was operated.
Probably what may be the cause? Immediate surgery within 1 or 2 days.
Major trauma, sir. Which
Major trauma means what? Major trauma?
or
What
femur
fracture?
fracture or acetabulum fractures.
Huh?
Femur fracture or
Femur fracture.
Okay.
More specific. What femur? What femur?
head of femur fracture.
Head of femur.
Head or
Maybe
fracture.
it's so common head of femur fracture.
See, you can
48 years old.
you can say that there is a proximal femoral fracture probably for which he was operated immediately. That should be this one. Okay. And though he was asked to bear weight, was he suggested any further surgeries? Has he gone back to the hospital?
He has gone back to the hospital, sir. Initially, non-weight bearing was suggested for 1.5 months, sir. After that, gradually weight bearing, partial weight bearing.
Now I'm asking, after for this particular problem which he is having, has he gone back to the hospital?
Yes, sir. He is doing regular follow-up.
What is suggested to them? Is he suggested anything?
No, sir. They started only weight bearing.
Weight bearing. Okay, fine. Okay.
It's a auto upside down turn, or it was a head.
No, sir. Both the autos collided.
Yeah, that actually the history of exactly what he has sustained, how he has sustained, will give a clue to you what might have been the injury. If he is sitting and there is a head-on collision, probably there is a direct impact. It may give to a clue to you, whether it is a fracture or dislocation or something else. If it is turned, you don't know what has happened. So he also may not be remembering. So that is very important. You should have taken a little bit more history at that time, what exactly has happened.
Which is the commonest injury? Not a softening.
Direct collision.
Direct collision.
Direct collision. He was sitting, no?
See, there is another important information which he went to the hospital for follow-up after 2 months. The doctor has told him that his ball of the femur is likely to become deranged in a future. वो हिंदी में इस बोलता है ये खराब होने का संभव है. Then when he went, then they said अभी खराब हो गया है. So this is important because in your diagnosis history, when you ask, this is all information which he gives, which you can elicit. There is no problem. Okay. So this gives lot of problem. Now we are almost sure that probably he had a fractured neck of the femur, for which he has operated, and it is going into which he was already told by the doctor. That is the history. Okay.
He was operated after 48 hours or 24 hours?
48
No,
hours.
that is a private hospital, so operated immediately.
No, even then, that also will give a clue to you.
Yeah, no, that is what I asked.
If it is a dislocation, probably they might have taken immediately. If it is a fracture, most probably they might have waited. So that will give a clue to you.
Initial 2 days he did not go to the hospital.
Okay, fine. Okay, fine. So there is past history, nothing significant, no problem. Nothing. Okay.
Like any general examination, positive findings?
No, sir.
Okay.
No. Go to local examination.
Okay.
Gait, sir. He's bipedal assisted gait, sir.
Patient is walking with the walker. He cannot walk without a walker.
He cannot walk without a walker, sir. I have done my examination in supine position, sir. Attitude, head is in center, arms by the side of the body, shoulders appears to be at the same level. Can you please see?
Then you tell the findings.
Okay, sir. Head is in center, shoulder appears to be at the same level, arms by the side of the body, and ASIS appears to be at the same level. Patella facing, right patella seems to be proximal, facing upwards compared to the left side. Medial malleoli is slightly at the upper level.
Facing inwards or outwards?
Upwards, sir.
So it is proximally placed.
Yes, sir, proximally. When compared to the opposite limb, it is proximally placed, sir. Medial malleoli appears to be at the higher level when compared to the left
You can
side.
say the limb appears shorter compared to the other side.
Yes. And then level of ASIS were at the same level, sir. On the posterior aspect, I'm going with the positive findings, sir. On the posterior aspect, there is curvilinear incision, 10 to 15 centimeters, which is healed by primary intention.
Posterior?
Yes, sir. Posterior lateral incision, sir.
Posterolateral incision, what is the length?
10 to 15 centimeters.
10 to 15 centimeter long incision they have put.
Yes.
Okay.
Curvilinear, extending from the posterior aspect of the thigh to lateral aspect, sir.
You can say then a particular looks like in a particular incision. It goes by name. Approach.
Southern Moor approach.
It looks like a Morse approach.
Yes.
Okay, fine.
Upsurge.
Okay, fine. So on inspection, there is a surgical scar. There is wasting of the gluteal muscles.
Yes, yes, sir.
Thigh muscles.
Thigh muscle wasting is there, sir.
And limb appears shorter compared to the other side.
Yes, sir.
What about the rotation? Do you think the limb is in internal or external rotation?
Limb is in neutral position.
Neutral
so when
position.
yes,
Okay.
sir.
Okay, fine.
And
On palpation?
Overall limb length?
It says it is shorter. Shorter.
Shorten, sir. Apparent shortening is present.
No. Now, on palpatory findings.
Apparent and true shortening both.
No. Palpatory findings. I am not asking the measurements.
No local rise of temperature. No fullness in the Scarpa triangle. There's thigh wasting, sir. And femoral pulses are normal and comparable.
You say that anterosuperior spine at the same level. See, palpation is better. You say that there is no exaggerated lumbar lordosis.
Yes.
You are examining the supine position. Okay. Then you go to anterosuperior spine. They are at the same level.
Yes, sir.
Then go to the Scarpa's triangle.
No fullness or swellings at the Scarpa's triangle, sir. And anterior joint line tenderness is present, sir.
Anterior joint line tenderness present.
Yes, sir. And then
One more important thing there on palpation.
femoral pulses are palpable and comparable.
Okay. Okay.
Measurements, movements, sir.
Then palpation on the lateral side. What about the trochanter, position of the trochanter, whether it's proximally placed, all those things?
It is not, on palpation, it appears to be a little bit thickened.
Appears to be?
Thickened.
Thickened.
Yes.
Is it tender?
It is tender.
See, there are a lot of things are there in the palpation of the trochanter. One is the position of the trochanter, whether it's broadened, whether it's thickened, whether it is tender. And then you can also do a trochanteric thirst tenderness also. So what is your findings?
Tender, sir, and broadened.
Tender, broadened, and proximally placed?
Yes, sir, proximally.
Proximally placed. So you think that it is broadened, irregular broadened?
Yes.
You could palpate some implants there also? No, you are. Anything, if you are able to palpate, you only have to tell. Otherwise, you should not say that I cannot palpate any implants there.
Could
Okay.
not palpate.
Okay. Okay then.
Is it
Then,
prominent or?
sir?
The trochanter is very prominent or it is?
It is not. It was not.
When compared to this?
No, sir. It was not prominent.
Okay. What about the scar, surgical scar? Is it fixed? You have to palpate and see the scar also. Whether scar is tender, scar is this.
Scar is not tender.
Okay. Then.
Fixity, what does it tell to you?
Whether fixed to the skin or bone.
You see whether it is healed by primary intention, all that you have to tell in the inspection. On palpation, you have to see whether scar is tender, whether it is fixed, means whether he had an episode of infection earlier.
No,
Okay.
sir. Scar is not tender, it is not fixed.
That those things you have to tell in palpation.
Yes.
Then, next movements.
Movements, all the movements are normal, sir, but terminally painful, sir.
All the movements are?
All active and passive
What
movements.
about the active movements?
He is able to do abduction and adduction, all the movements.
All the movements able to do, and they are
Terminally painful, sir.
terminal restricted and painful.
Yes, sir. Flexion is more painful, sir, when compared.
What is happening is, when he is flexing, say at about 80 degrees, he suddenly feels pain. Then again he can freely flex further. Okay.
External rotation. Internal rotation. External rotation and internal rotation.
Compared to that, same. He is having pain, spasm.
He is having pain, so they terminally restricted. Yes, sir, terminally restricted. He is able to do active adduction.
The abduction is exaggerated.
Yes, exaggerated.
You have to keep your hand on the anterior spine and gradually move. See, there is so much of exaggeration. It is not normal. इधर लेके जाइए आराम से. Is it exaggerated? And also, at terminally, I could feel a click also. Passive is exaggerated. Both abduction and adduction are exaggerated. Then what is the other thing?
Flexion. Measurements, thigh component appears to be shortened, sir.
Louder. Where is your mic?
Thigh component appears to be shorter, sir.
First thing what they ask the measurement, what you have to tell is what is the apparent measurement, what is the true measurement. Then you go for wasting. What is happening?
Shortening, sir.
Is there any difference in the apparent and true?
No, sir.
No. Then what is the limb length discrepancy?
1 centimeter, sir.
Only 1 centimeter.
Yes, sir.
And that is supratrochanteric, infratrochanteric.
Supratrochanteric, sir.
Okay. There is 1 centimeter of supratrochanteric shortness. Okay, fine. Then telescope is there.
No, sir.
If you do,
Can you do it now?
can you do it?
So one of the most important tests.
One of the most important tests in telescopy should not miss.
Can you do?
Special test you have to do.
भैया थोड़ा मोड़िए. अब कितना होता है उतना ही.
fresh, you can see here. See, I have fixed this. See here, come here. I have fixed this pelvis.
Yes.
See what is happening. In a
Transmission.
fresh post-operative case, you can get away by saying, sir, it's recently operated. I have not tested telescoping for safety.
Keep your hand here.
But 8 months down the line,
Keep your
there is
hand
no
here.
question of
No,
safety
no, no,
there.
like this.
A non-union would be a non-union, and a problem would be a problem, which is best to assess it.
Can you feel
So
something
there is
is
no
hitting
escape
your
of
hand?
not doing telescopy in this
Yes,
case.
sir.
Something is hitting your hand, isn't it?
Yes, sir.
Both the tests, special tests you have to do, telescopy as well as straight leg raising.
See, in this case, when he is having so much of exaggerated adduction and abduction, telescopy has to be done.
Because you have no way of knowing whether that exaggerated movement is happening at a non-union site or at the joint. So you have to check for it.
It is head or trochanter is coming and hitting your head. We do not know exactly what is hitting your hand, isn't it? But some hard structure, that is either trochanter or this one. And with the movement, you can feel that there is a click is felt.
Sometimes it's the hardware also.
Hardware, that is a hardware, sir. There is some hardware is felt. That click is because of the hardware.
Okay, what is your conclusion now with all the history and the examination?
You have seen the incision there. Okay. What that incision is normally put? Southern approach. In a trauma case, normally where they put that? Which surgery normally? Is it for fixation of the fractured neck of femur?
Can be used, sir.
No.
Southern approach, never.
Not done.
Never.
In your institution, do they do? No. Fractured neck of femur, they don't do like that. Okay.
Southern approach is used for routinely what cases?
For, yeah, in a
Acetabulum.
trauma, it's mostly done for the acetabulum. This patient had a fall. After 2 days, he was operated, and that too immediately. And there is a poster, this one, probably he had a fracture dislocation. Clinically, we do not know. X-ray may show something else. Okay.
It's a long incision. It is going up to the posterior superior leg spine. Almost.
Initial 2 days, whether they have put any skin traction or a
They have put
skeletal
skin
traction?
traction, sir. They have put skin traction, sir. But it did not have any deformity, sir,
Okay.
during that time.
That is
Okay.
for pain relief, they might have done it. Okay. What is your
Now, the present condition looks like what?
Post-traumatic secondary arthritis due to
Why do you say arthritis?
all the
There is an,
because
I showed you so much of adduction and abduction. What restriction? And your click is also felt. Telescope is positive.
Incision is going beyond the posterior superior leg spine.
almost up to that?
Maybe don't
Cocker-Langen.
that one. So probably they would have attempted to reach superior the head, probably.
It is probably a
Reaching
now
up to the PSIS.
thing is it looks like a non-union.
Sir, in this case, there is a telescope is classical present or just small click?
No, it is present, sir. Classically
No,
present.
no, I saw that. Yeah.
Yeah.
Small click is there. Initially, it was not there. After the repeated movement, it is coming now. Telescope.
So we only have done something.
Don't say that it has been now created. It's not created.
He can file a case,
These
sir.
abductors are zero. There is no power at all. Abductors. Yes.
Yeah, you can read the
Now, what do you think might have gone wrong at that time? Now tell what has gone wrong.
That is a clinical diagnosis. Radiological diagnosis can be something else. But what we said is there is a fracture dislocation he had. Ah. Okay, okay. Can you read the X-ray now?
This X-ray of pelvis with both hips showing acetabulum was fixed, sir, with implant in the acetabulum, and there's degeneration of joint space on the right side, so when compared to the left side. This a plain radiograph of pelvis with both hips with implant in situ of the acetabulum. On the right side, there appears to be fracture of femur head, sir. Here, there appears to be fracture, so small fragment, and degeneration.
What has happened to the Shenton's line?
Broken, sir.
Huh?
Shenton line appears to be broken, sir, on the right side.
So that indicates that there is, what does it indicate? Is a broken Shenton's line. Though head appears to be in the acetabulum, probably it is not there. Okay. We do not know. Okay. Then there is a fracture is not there. There is superior rim of the acetabulum, which is there.
Pointer.
There are two screws are there, isn't it? Two screws.
Where is the screw? Not in the head. Yeah. What is those screws? What are those screws? Where are they?
Those are used to fix the fragment. Some fragment, and after that they try to fix the acetabulum also. That is the superior part of the acetabulum. Then they have put a plate. Now what is this present problem now? Now how many months?
8 months old.
Is the fractures united?
Fracture in the superior part, that is the acetabular area. One view it is clear where there is a gap. Here of course it is an overlap, that is why you are not seeing the gap. So there is a plate there, big plate, reconstruction plate. Yeah.
And the click which you are feeling are probably those two screws which you are feeling, that they are feeling is a click and movement. What you will do from here? Now looking at this is recent CT, you can see that implant also is there. So now it is not united. United. What is your, now looking at the CT, what is your diagnosis?
8 months old post-traumatic acetabular fracture but non
Huh?
Basically, it's a two-column fracture. They are not addressed well.
Okay. Now what you are going to see, now the clinical diagnosis can be different because we felt telescopy, that is I think whole that fragment was coming and hitting our this one, we do not know. So, and this other problem, you can say that there is probably some non-union. Yeah, you can say non-union, but when a radiological diagnosis is different. From here now what you will do? You have to revise the whole thing. That is the best thing, answer to say that. You have to revise, remove the implant, and you have to, there is a 2-column fracture, you have to again freshly try to fix it. Would you like to do an MRI now to this patient? I am asking.
MRI.
Why? Can you do an MRI? The implant is there, no?
Yes, sir, we cannot.
You can get some artifacts there, but still you have to know the vascularity. Can there any other thing you can do to know the vascularity other than when MRI is not able to be done? Can you do some scanning? Bone scan. Bone scan also can give some information if the MRI is not, because that is an important thing to know, because the head is already probably is avascular or something deformed and all that. Then you will have to do what you will have to do. Can you do THRs?
With ACE.
Whether is required to be done or not required to be done?
No, it's already 8 months now. So it is going on. This problem is going on for 8 months. Already arthritis is set in. The head is deformed. The fracture is, of course, not united. You can solve all.
Will you do it
one
in a
go.
single setting or in the 2 settings?
2 settings.
What you will do in the first sitting?
First, we will fix the acetabular fracture, sir.
Replacement surgeons.
So in this case, your problem is trying to reconstruct this will not prevent him from having pain. That head is deformed there. That weight-bearing portion of the acetabulum is bad. Whatever you do reconstruction, he is not going to be pain-free. He'll need a THR. So the question is, are you doing a single-stage THR or a 2-stage THR? What is the argument for single stage and what is the arguments against single stage? Because there is a frank non-union and there is a separation of the 2 columns from the upper weight transmission segment, you may argue that first I would try to achieve union of the fracture and then go in safely and do a THR second stage.
What she said, sir.
Or you can go for or you can have a very modern type of a cup placement which takes care of fixation, and you have a femoral head, morselize that into graft, pack it there, freshen everything, have a large cup which has spans this. There used to be an octopus cup. There is polyhole cups which are there which can be added on with trabecular metal to build in your defects there. Do a THR same sitting. So the argument is 1 stage or 2 stage. Your argument, sir, he will need a THR, but he has a non-union, can be 1 stage or 2 stage. That's all I'll argue.
Yeah. Okay, okay, fine.
You have to justify 2
Any
stage
questions?
or 1 stage, both you have to know.
This is basically a simple case in the MS exam because there are no coronal plane deformities, there is no fixed deformities. It's a trauma case. Trauma cases most of the time is a good case in the exams if you get. Only thing is, you'll have to elicit the findings properly.
Am I done?
Okay, fine.
Thank you.
A request to all the outstation delegates to kindly go to the registration counter and give your email IDs. Moving next to the spine session, sir, I'd like to call for the next spine session, I'd like to call Dr. Rajamani, Dr. Srinivas Reddy, Dr. Shingaravati Velu, and Dr. Goni to be on the stage and be the chairpersons.
Good afternoon, everyone. We have a patient by name Monty Kumar, 28-year-old, hailing from Bangalore, occupation as a welder. His chief complaints of low backache with pain radiating from the buttock to the leg. Low backache is since 7 years, and the pain from the buttock to the leg is since 5 years. So, patient was apparently normal 7 years back when he had a low back till the foot, sir.
Pardon?
Till the foot, sir. Complaints of pain radiating from the buttock till the foot on the back side. Yes, sir. Okay. So patient was apparently normal 7 years back when he complains of low backache, which was insidious in onset, gradually progressing. It was dull aching in character, aggravated on standing and lifting heavy weight. Initially, he was able to lift weight. He used to rest for 5 minutes. Later, in the last 3 months, he was not able to do his occupation work. He is also having complaints of pain that is radiating from the buttock to the foot. He is able to walk only till 500 meters, after which he has to take rest for at least 10 minutes. Again, he can walk up to 500 meters. So there is no history of bowel and bladder incontinence. There is no history of fall or trauma. There is no history of weight loss.
Rest release pain means, is there any particular position?
He feels comfortable on sitting and lying down.
Sitting and lying down.
It's aggravated on standing and lifting heavy weight and walking after 500 meters.
That is for the past 5 years, or it's only recent?
Since 7 years, he's having the back pain. Since 5 years, he's having this pain from the buttock to the foot. But it's increased in intensity since last 3 months, sir. He is not able to go to his occupation as a welder, so he has come for further management. He does not have any history of fall or trauma. There is no history of bowel or bladder incontinence. There is no history of significant weight loss. There is no history of fever, evening rise of temperature. There is no history of any waxing or waning of symptoms, sir. And in past history, there is no significant comorbidities for him. No infection, no family history doesn't have any contact of TB. Patient was taking analgesics for the few months, after which since 3 months, since it was severe, he has came for further treatment.
Any other treatment?
No other treatment, only analgesics he has taken, no physiotherapy or other treatment he has gone.
Any?
Sir?
What is this type of pain?
It's radicular pain he is having, sir, with claudication distance of 500 meters.
How he gets relief there?
He is getting relief on sitting down and lying down, sir. Only on standing and walking after 500 meters, he is having severe pain.
No, you must be very, you say radicular pain and claudication, both are different. Why do you combine both?
Now at present he has claudication also. Initially he had only
Initially
pain.
he did not have.
It was only a radicular pain.
Only radicular
now he
pain.
finds
Now
it
he
difficult
has
even to walk, and walking 500 meters produces pain. He has to stand, sit or
sit for 10 minutes.
10 minutes, and then again he is able to able to walk.
What is the nature of the pain?
Nature is dull aching, sir. Initially on the low backache. On the leg is sharp shooting pain, sir.
Is it associated with any sensory symptom?
No, no sensory symptom.
Abnormal sensation?
No sensory.
No abnormal sensation, sir.
Whether he is able to climb up and down?
Sir, he's having severe. He's comfortable on climbing upstairs rather than climbing downstairs, sir.
What does it signify?
It signifies there is a neurological claudication rather than a vascular claudication, because neurological flesh.
No. Why the position of spine?
Spine will be in flexion on climbing up, so it will be comfortable.
It doesn't do with anything with vascular. You understand the question?
Sir.
By extending the spine or flexion of the lumbar spine, you do not have any implication on the vascular. See, when you climb up, you lean forwards. When you climb down, you balance, you bend back. So when you go back, it is an extension, the ligamentum flavum goes in and the disc is there inside, the canal gets narrowed. That is why it is a confirmation of the canal stenosis. When you come down, descending down will produce pain. That test is only for neurogenic claudication, not for vascular claudication. Doesn't do nothing to do with the vascular claudication. So the pain is only one side or both sides?
Only on one side, sir. Left-sided, he is having more.
Only one side claudication pain. I don't agree, but anyway we'll see.
But that's what.
Yes, go ahead.
You do not use the staircase climbing to differentiate between vascular and neurogenic. No. Don't mention that. Please don't mention that. If at all you want to mention about differentiating, stationary bicycling and walking. That's the way to differentiate between vascular. Because a spine patient, he stoops forward on a stationary bicycle and uses his legs, he will happily do it. A vascular patient will not be able to do bicycling, stationary bicycling. So you just send him to the therapy department, ask the therapist, get him to do on a stationary bicycle. If he is able to do, then his spine. If he is not able to do, then it's vascular. It's cheaper than sending him for a Doppler.
And the pain you said about for 7 years, was the pain continuous or intermittent for 3 months, 6 months? Pain, total pain relief, on and off.
It's telling he is having severe pain only on working. He used to lift 20 kilogram of weight on his working occupation. So that time only he was having pain, sir.
No,
initially.
this past 7 years.
What the question is, pains for 3 months or 3 weeks and then no,
No,
pain
sir.
at all, then pain comes again.
No,
That's
sir,
what,
not like
the
that.
question
Not
is.
like that, sir.
Usually it is the discogenic pain. There will be pain-free period where it will be normal and suddenly there will be pain when the annulus gets ruptured and it comes out and then stops, and one day it becomes severe. Right, okay, he doesn't say that.
No, sir.
Go ahead.
Okay. On examination, sir, general physical examination, patient is moderately built, moderately nourished, oriented to times, place and person.
Anything relevant in general?
No, sir.
Right, then go for the...
Local examination, gait is normal, bipedal unassisted gait. On examination, either better.
Can you remove the... Make him walk.
2 minute walk करो.
Remove his shirt.
ऊपर करो.
Remove his shirt, it's better, is it not? Even for our examination, right? He works now.
No, never have the arms when you are assessing gait. Remember what I said? Hat segment.
Yes.
Head, arm, trunk. You need to see the spontaneous movements of the arms also. Just roll it up, tie it up there and then get him to walk normally. This is artificial walking. This is not normal gait.
Okay, local
Anything
exam.
unusual?
No, sir, I felt
No?
normal.
There's no high stepping. Sure. Get him walk.
Yeah, can you just walk?
Jara chalo zara.
Ah.
Straight jaw.
Right side.
Right side, right side. Observe
So
right. Yes. See, right side, you observe right side.
That's why I'm asking.
Right side. Right side. Right side will be.
And roll up his pajama. Just roll up his pajama. Yeah. But right side he seems to be lifting more than the left side. There. So why have I come at this level? If you have a doubt, you want to see, can you see more of the sole of the foot at this level? If you can see more of the sole of the foot, it's a high stepping gait. It's a very simple way to confirm.
Make you come.
Yeah, I can see more. Anyway.
See,
It's a subtle difference. Maybe he has a gait pattern which is variant.
Yeah.
I don't know.
Here it was looking artificial because of the restricted area.
Elevates more.
So on inspection, the head is central, neck is central, bilateral shoulder. Local examination. Local examination, head is central, neck is central, bilateral shoulders are the same level. There is no exaggerated lumbar lordosis on lying down. There is bilateral ASI, so the same level.
No,
Bilateral
you are
patella.
going to examine which system? Spine, or is it going to be a hip?
Spine, sir.
Spine. No, okay, now he has come to the... right. Okay.
By-
So then more than exaggerated lordosis, anterior spine, we would be interested in knowing about any coronal plane deformity.
There is no kyphoscoliotic deformity on inspection. There is no step deformity on the.
he was
Anything
asking
abnormal in the
coronal
pelvis?
plane. Don't say kyphoscoliosis.
Kypho-
Don't combine both.
There is no kyphosis deformity or no scoliosis deformity. There is no step deformity. There is no scars, swelling, sinuses present over the back.
Yeah, go ahead.
On palpation, there is no local rise of temperature. The point tenderness on the point tenderness was present at L4, L5, and S1 level. And he is having tenderness over the point tenderness with the thumb. We'll palpate on the spinous process. Either way to
And demonstrate how did you check for
कुछ भी straight करो.
No, around.
Around. So let him hang his leg down.
How did you check for point tenderness?
So from
Points
the
you check.
C7 to on the spinous process, we'll see any tenderness is present. It
That's
usually
not called
present
point tenderness. That's direct tenderness
direct tenderness.
and indirect tenderness. There are only two ways of doing it. Direct is directly over the protruding spinous processes. Indirect is, now did you check for indirect?
Thrust and rotational tenderness.
How do you do that?
Rotational, we'll rotate the spinous process either to
No,
one
that's
side.
not how you don't slip your fingers.
Now, what do you try to do by this?
Rotating the spinous process to either one of the sides.
Where indirectly, where do you try to push?
To the on the side of the spinous process, so that we'll push
No,
it.
spinous
to one
process
You don't have to
already.
push the spinous process. You don't have to push the spinous process. You have to keep the thumb on the side of the spinous process, and then you give a rotatory thrust. That is it. So by doing this, what you are inferring?
Any anterior elements in pathology is present or not if the patient is having tenderness.
Yes. So it is more specific than the direct. If the direct, this tenderness on the spinous process it is more for
posterior element of the
elements. So here, this direct one is preferable or other one is preferable?
He complains of pain on the direct. Sir.
He complains pain on the direct. It means some posterior pathology.
Posterior.
So you are going somewhere else now.
But that is a fact he wants to say.
Usually in a chronic issues like this,
Yes, what, sir?
a chronic
No other points, sir. Yes, sir. On paraspinal muscle spasm is present, but dimple of venous no tenderness, sir.
How did you look for the paraspinal spasm?
On inspection, there will be deepening of the furrow, and on palpation, on flexing, the prominence will be more, sir.
sit there, ask him to bend forwards. So after these,
After Sarvik finishes.
you see that, you see.
Paraspinal muscle spasm.
You see, you feel. You can see also, you can feel also.
You can see.
That's both way. Is there a spasm or not?
I felt there is a spasm. I thought there is a spasm.
You thought, where is the spasm?
He sits so comfortably. And
Spinally, it tenses, That is a paraspinal muscle, spasm. I don't think so there is a spasm here.
No, as such, this.
He bends.
There was a reflex spasm on the right side. I could see it from here.
Okay,
Once you do, the idea is you stretch the muscle, which automatically becomes very taut. That is how you check for the paraspinal spasm. Okay? And direct tenderness, indirect tenderness, and then this paraspinal spasm will not be there much in a chronic case. This seems to be a chronic case. So unless otherwise there is an acute infection or infective pathology, all these things will be positive. Otherwise, in a chronic case like this, you may not have that finding of a direct and indirect tenderness. Okay, go ahead. Yes, go ahead.
Sir, on motor examination, the on L2 to S1 was normal. There was no deficits bilaterally.
No, you have to check his spine because his spine is the primary area of pathology. Then you go for the motor examination, dermatomal pattern or motor myotome. You have not completed it, no? The special tests and everything.
So SLRT was positive on the left side at 30 degree.
Don't tell the abbreviation. Straight leg raising test
was positive at 30 degree. So when the patient reproduces a pain from the buttock to the foot, if patient is having pain, that pain is considered as positive till 7. When the patient tells he is having pain from the buttock to the foot,
up to what level?
up to 70 degree, it's considered as positive.
Why? Okay.
Because beyond 60, the entire nerve would have stretched to its maximum. Beyond that, it doesn't mean. Okay, right. This is 30 degree.
30 degree
Is there
was
any
positive,
confirmatory test to say that it is only because of the stretching or anything else? How to confirm? What are the other supplementary tests?
Bradgard's test is there. We can 10 degree. We can flex it down and then dorsiflex the foot. If he's having the similar pain, we can confirm that.
And the popliteal?
Popliteal, we can at the same degree we have to flex the knee and give the anterior push on the peroneal nerve. If he's having the pain, it's a confirmatory test. For him, he did not
push. You just palpate. He'll have a pain. Okay, bowstring side.
Bowstringing off.
Bowstring side.
These two are positive.
So bowstring was I couldn't get positive.
You have to flex it further. It cannot be at the same level. So if at 30 degree you are getting positive, you have to flex the knee, then the pain will subside. You have to flex it little more so that the sciatic nerve is bowstringed. At that point, if you press on the posterior aspect, you just palpate the sciatic nerve, it will be painful. Okay, it's not at the same level.
Okay.
Then for a Faber test was done, sir. It was negative, sir. Bilateral.
What for you do that?
Sir?
What for you do this?
For SI joints, sacroiliac joint tenderness is present or not, flexion, extension, rotation.
Any other, when you flex, where do you flex it? Why do you want to flex and adduct or rather abduct?
At the hip, sir.
You do a flexion.
You do the straight leg raising and then all these.
Better. जिंचिन है ना बोलो, ठीक है? So, a normal side, sir.
Be very gentle. Okay, it's positive then?
Yes, sir. So, then bend the knee.
Confirm again.
Reduced actually.
Okay.
No tenderness.
Was asking to SI joint.
Sir, bring the patient to the tip of the bed.
Cancellance and
Ulta switch. No, nothing.
No problem. It's normal.
Normal, sir.
Okay, agreed.
Sir, the motor examination, sir. Motor examination, sir. From L2 to S1, the patient had no deficit, sir. We'll check for hip flexion, sir. Upper.
No, you tell me. Tell what are the tests.
Okay.
Tell what nerve root and what muscle. You just tell.
L2 is hip flexion, L3 is knee extension, L4 is dorsiflexion of the ankle, L5 is EHL, S1 is plantar flexion of the toes.
Right. How did you check for the hip flexor?
Hip flexor, give resistance.
Lying down or ask him to sit?
Lying down, I did, sir.
So ideally it should not be on lying down. Right? So you should be, patient must be sitting and then asking to lift the thigh up. Okay.
How do you test?
I did doing supine, sir.
Ask him to sit.
Better. ये पैर ऊपर उठो ऊपर नहीं
why he should lift the
लूज करो ये लूज करो
Don't extend the knee.
ये पैर ऊपर करो, ठीक है?
Give resistance to that.
Correct. Okay.
That is the way.
ऊपर करो.
Okay, this is for
L2, sir, hip flexion.
Right. Then
the knee extension L3, then dorsiflexion of the ankle L4, then EHL.
Only one nerve root or more than one?
so each
Two nerve roots.
but predominantly you. Right.
So then L5 is dorsiflexion. L5 is EHL. S1 is plantar flexion of the toes.
You just check all those.
ये ऊपर करो, ठीक है?
So it's always better. Now you are checking the dorsiflexor.
Yes, sir.
It's
Dorsiflexor
always
of the-
better to check grade 3 power.
Okay, sir.
Then you can go up and down,
Okay,
up to the tibialis anterior. And then probably for EHL and DHL, FHL, you can just check it like that. So how do you check for grade 3 power of tibialis anterior?
tibial. So ऊपर करो.
Is it, what is grade 3 power?
So again, against resistance he has to do. Sorry.
Against resistance.
So against gravity he has to do.
Against
So
gravity, right. So
he
you have to flex the knee and then
flex
now
the
you
knee,
do
then
it.
he has to lift up.
Now you do it.
ऊपर करो.
Give resistance.
पैर ऊपर करो. ऊपर करो.
Just distal to the insertion of the tibialis anterior. Where is it inserted? Where is tibialis anterior?
Posterior aspect of the first metatarsal.
Posterior.
And we can do inversion and then check for the
So I asked him to check the grade 3 power. So that is the reason. Grade 3 power. Okay. One
So-
up or down. Right. Okay. Where is it inserted? Okay. Difficult questions.
from the first metatarsal.
Right. Time is going up.
First,
Medial cuneiform and the
medial
base of the first
base of
metatarsal.
the first
Okay.
metatarsal.
Right. So you have to just go distal to that and then check. Okay.
Okay,
Right. Tibialis anterior is acting.
Then
EHL.
ये ऊपर करो. ऊपर ऊपर. Sir? Is normal side, sir.
You keep the knee flexed.
So this is more easier.
Yes. Ask him
ऊपर
to
करो.
just- Yeah. Do that.
नीचे करो. No, sir.
Equal pressure on both sides.
नीचे करो. Yeah, this is pressure is little lesser.
पंजे ऊपर करो. ये वाला. ये वाला. Over resistance. I'm able to overcome. ऊपर करो. ऊपर करो.
What about
See
your
that?
finding?
I use one finger. I'm not able to overcome. With one finger, I'm able to overcome. That means the power is less.
ऊपर करो.
It is less. You're able to
FHL?
Okay.
You cannot overcome that side. You can overcome this side.
FHL you do it?
नीचे करो.
Problem was you were checking here. EHL is here. See
Yes, sir,
this?
distance.
EHL is here. It's inserted at the base of the
Distal
distal phalanx. You are checking at the proximal phalanx. Therefore, you're getting a fallacious result. There's a clear weakness of the EHL here.
Right. Then
Just one people back. Just demonstrating how to check for tibialis anterior. Tibialis anterior is inserted at the base of the first metatarsal and adjacent part of the medial cuneiform. The finger has to palpate for this muscle here in front. The patient is asked to do dorsiflexion and inversion. So what do? I ask him to touch my finger which is kept dorsal to the foot and on the medial side. मेरे उंगली पे पैर लगाओ. यहाँ नहीं, यहाँ पे. इधर. Yeah. He's doing it and it's contracting well. I give resistance in the opposite direction, plantarwards and in the evergent direction. अब फिर से वही करो. वैसे where you place your hand. This is classical method described in Kendall and Kendall, muscle testing and function. This is the exact way they show it. Okay?
Okay, go ahead. Always palpate, see the muscle area, anatomical area, whether it contracts, whether some other muscle is performing the function. And then try to palpate, feel your contraction over the muscle. And then test in a proper position and do this. So whenever you test a muscle power, these three things are important. First, see whether the area is contracting. Then palpate the contraction. And then the proper position, do it. Okay, go ahead, yes?
Sensory, there are no deficits.
Any other,
Yes.
now we have found out that L5 and the sir has demonstrated L5, right? You found only S1. Any other muscle you want to check apart from the FHL? Because you have to see other muscles also. If it is normal, then it's okay. So what are the other muscles which are supplied by?
L5S1.
Flexion of the toes.
Apart from
Apart
that
from
muscle.
FHL, what are the other muscles of S1?
Anything on the back?
Gastrocnemius is supplied by?
Yes, L5, S1.
Gluteus medius? Which one? L5 or S1?
Superior.
Predominantly.
Hamstrings. See, a lot
Hamstring.
of muscles are there, That's why, spine case, you need to know very basic anatomy, myotome, dermatomes, reflex, that's all. We don't expect beyond that. You are getting stuck up at that stage itself. You must know very clear, this is after all your first year subject. When you are not able to answer these questions, your whatever thing you answer, probably we don't account for this. These are basic supposed to be simple. Yes? You have tested that?
Only FHs.
Oh,
You have to.
you
Because
should-
this
should
you have
not.
to be very thorough. So you cannot afford to test only one because there is nothing much here. You have to check the myotome, you have to check the dermatome. For each root is different. Now that you found out S1 is affected, you should have checked about gluteus maximus, you should have checked about the gastrocnemius. And sir has also found out that tibial is, EHL is also there. So the hamstring, how is it? Gluteus medius you have to see for the L5, right? Ask him to.
Nowadays, because hip and spine are equal. You need to do equally better. Easy, provided if you know this.
So,
You carry on.
So sensory on L1 to L5, there was no difference on bilaterally. Reflexes was normal, superficial and deep for the knee and the ankle and the abdominal reflexes and the cremasteric.
The reflex ankle jerk root value.
For ankle is S1, for knee is L4. Was
Demonstrate sensory deficit of
here he says that there is no sensory deficit.
No reflex. Reflex is normal.
hard to believe.
Reflex is normal.
reflex is normal, sir.
Right, demonstrate ankle
Actually,
jerk.
normal, which area you have tested?
So for ankle,
Which segment you have tested?
for reflex
Sensation, which
Sensation.
dermatome you have tested?
L2, L3, L4, L5 and S1.
No,
and
that's a routine. In this case,
Where is L5 and where is S1? So,
that's
So
why I'm
S1
asking
is
directly
behind.
that way.
S1 is behind.
But
L4
don't
is
say
an anterior.
behind, where you have tested. Relax. So the area where you have tested for L5.
L4. So this aspect.
first to L5, you should not
Ask him once again.
ये दोनों सेम तो है.
आराम से बता देना.
Both are same?
बराबर है 19-20 का फर्क हो.
Both are same, or they'll be able to, there will not be total absence of sensation. There will not be total absence. You must ask them, is there any difference? Sensation will be intact, sensation will not be absent. You must ask them, is there any difference? Perseverance is both same side. You see now, what he say?
एक ही साइड कम है, एक ही साइड ज़्यादा है.
You see that? When you say you are able to feel, he will say both sides it is present. But in these situations, sensation will be intact. You have to specifically ask whether it is equal on both sides.
The person without symptoms, the person after certain age likely to have a partial weakness of the EHL line, sensory weakness, unless it is poor. Everyone will have a disc.
Okay, so you have to test properly. Don't say L1, L2, L3. You are planning, we know where you are coming. You say EHL weakness means you are coming to one particular route. So sensation you have to test in that particular dermatome, and then sensory loss will not be there. You have to ask the patient whether you are able to feel the difference on both sides. Okay, yes?
Can you just check the hamstring and gastrocnemius? At least once we'll see.
Yes.
Just that.
ऊपर करो
Hamstrings.
That is towards
Is it the best way? I told you, whenever you test a muscle, you see the muscle first, area, the particular anatomical area you see, and then you put your fingers over that, because when you ask to do some movements, patient will try to very sincerely trying to obey your commands and then try to do some trick movements. So you must be very wise enough. Which position you will see?
Make it grade 3. Then only it will be easier. Grade 3 of hamstring, grade 3 of gastrocnemius.
You want to see first, I say, yes.
You have to see the hamstring. Maybe check
ऊपर करो
You have to go, keep distal, just distal to the insertion. Okay.
ऊपर करो
Right.
Sit on one side.
ऊपर करो
Keep one hand on the hamstrings. Hamstrings.
ऊपर करो
Hamstrings.
that's there ऊपर करो
Whether both hamstrings are working, both medial and lateral.
both are tight sir
Resistance for that.
ऊपर करो
That's not the way. These are the hamstrings, right? Huh? You give resistance here. Okay. Okay. You see this biceps here, semitendinosus, semimetendinosus. You feel the muscle. So you have to use both the hand. You give resistance and feel the muscle. Right.
Both are same, sir.
It is weak. Then how do you test for the
Gastrocnemius?
Gastrocnemius.
so
Flex it. Why you want
This
to
is normal. This is normal, no?
this is normal sir he has to
Which is normal?
left side is affected sir right side is normal
Right is normal.
Okay.
that is affected. You
this is
just check.
affected this is normal
Okay, that is normal. You see here? You see?
Hello.
ऊपर करो
ಇದನ್ನ ಮೇಲಕ್ಕೆ ಮಾಡಬೇಕು. This is against gravity. Give resistance for that and feel the muscle here.
Right. Check both.
ऊपर करो
Feel the muscle.
yes sir
That is for 4.
Then
Similarly, you feel that.
ऊपर करो
Hold this here.
ऊपर करो
See?
You have tested, while in examination you have tested this. No, the way in which, the same thing happens in exam. You say 3, 4, the examiner definitely will ask you to demonstrate. And then you are got up there.
because this is the
ये सीधा ऊपर करो
small things you'll have to
ये
examine.
पैर ऊपर करो
Answer. That's all.
ऊपर करो
Ask him to lift the whole knee.
ये पूरा ऊपर करो
Yeah.
You can ask the knee to be flexed.
it's tight sir
We expect only muscle testing, the myotomes. This only we will ask, particularly in a case of a disc. So you must be thorough with that. So in fact, spine is relatively simple than any other hip problems. You need to know only the basic neuroanatomy. That's it. Okay.
so reflexes was normal bilaterally knee and ankle was normal
Just show.
superficial
Ankle
better
jerk alone. Ankle. Just show the ankle jerk. That's it.
Then Sir, preventing plantar flexion. To check for the tone, whether
So
the
you are doing what?
ankle
flexor.
flexor.
With the left hand, what were you doing?
So checking for the plantar flexion.
Plantar flexion. You are dorsiflexing the ankle.
So, yeah, dorsiflexion, sir. So
How
that
much you have to dorsiflex?
so we can see the we can see the muscle and the
Whenever you want to check, see, it should be free. It should be free. You are hitting on the tender Achilles. You have to stretch a bit. So you ask him to, divert his attention.
ये करो
ऐसा करो. What's that called? Leave it loose.
Reinforcement.
See, you dorsiflex a bit. Tap on this. Okay. If you don't get this reflex at 10 degrees, you little more dorsiflex. But when you dorsiflex to the total extent, you will not get the reflex.
Yes.
So it is a stretch reflex after all. So you don't need to completely stretch. You stretch a 15 to 20 degree, that's a bit enough. Otherwise, still it is not coming, you can stretch more. Don't fully stretch it. It is a stretch reflex. You keep the muscle under stretch under physiological circumstances, and then you give a tap. That is the basis of stretch reflex. Okay?
Pretty bit. Sir, sir.
What is this known as?
Reinforcement.
Yes, go ahead. Go ahead. Go ahead.
So superficial reflexes are normal bilaterally.
What reflexes? What superficial reflex?
Abdominal reflex and the cremasteric reflex, sir.
What for? For routine examination or with a specific
routine examination, sir.
routine examination? Okay.
Check for the cremasteric, see for the pull of the testis, it was present bilaterally. And for the abdominal, the pull was present.
Any other special test or anything you have done?
SLRT was, straight leg raising test was done. Lessard bow-string test was done. Then
Okay.
I like to come to my diagnosis, sir.
No, upper limb you have tested?
Upper limb was normal, sir. Motor sensory was normal.
Hand
sir.
grip you have tested?
Sir?
Hand grip you have
Hand
tested?
grip was tested, sir.
Checked it, hand grip.
With the, yes, sir.
You know, because sometimes usually you get a
Hold on.
fallacy. You ask them to lift it, they will able to lift it. But specifically you look for T1. Most of the times patient also will not give a complaint and then they try to do it. And another one is any other examination before coming to the diagnosis?
So hip examination was normal.
Okay, any other
Neurosensory,
pertaining to
peripheral
spine?
pulse.
Plantar, you're told,
Yes, sir. Plantar reflex.
present or absent?
Ankle was normal, sir. Plantar was normal, sir. There was flexion, sorry.
Okay,
There was
any other examination you have done?
normal? Babinski was extension. If there is extension, it might be.
Any other special, that's why he's asking. To complete the list.
So plantar is? Flexion is present of the toes. If there is extension, means Babinski.
Plantar is flexor.
Flexor, sir.
Flexor, okay. Any other, you have to examine anything else?
To end the story.
To end the story for completion shake?
Knee examination. Hip.
No, anything else. In a routine spine examination, you have to make the patient, examination is lying, examination is standing. And sometimes people will say, I'm able to, do you have any other weakness? Patient will say, no sir, I am walking, and then coming to your office. And so when you ask them to sit down and then get up, they will not be able to do. They'll be, especially they'll be have a gluteal weakness. So the simple way of testing is you ask them to squat or yoga position and then ask them to get up from that. The weakness will be exhibited. Usually patient will not accept that. I am walking, I am sitting in the chair, I am got all right. So you have to make them to see all these things. And then particularly you should look for a hand grip. You will miss that. And then one more examination in standing, whether turning
Modified
on. Pardon?
Modified showburst test was done, sir.
Okay, that's all right. Anything
Chest
else?
expansion was.
You measured chest expansion may not be relevant to this case, but you have completion sake. Any other relevant tests you have not done? making the patient stand up and bending, right bending and then the left bending
List
painful?
was, he did not have any list was not positive, sir, on either sides, on left or the right side when he was bending. He didn't complain
List,
of any
he
pain.
could not list.
He could not list.
Do it.
But no, but stand from A side, A side.
You said you are not able to bend it.
No, he is able to bend, sir, but there is no
No pain.
there
Okay.
is no complaints
Okay.
of pain
Okay. Okay. Yes, go ahead.
So, but
There's one more test I want to do it. Ask him to walk on the heel. Ask him to walk on the heel.
I say walk around.
Okay. On toes. Oh, he is doing reverse even.
Okay.
Okay. Yes. Yeah. Go ahead. Anything else? Anything else you have examined? Because you told that there is claudication, radiculate pain and then the claudication. Anything else you have tested?
Pulses was felt bilaterally
Pardon?
equal. Pulses was felt bilaterally equal on after making me walk for
Where you put femoral?
peripheral pulse. Only.
Femoral?
Peripheral pulse only.
Where? Peripheral means where?
Dorsalis pedis arteriolae palpated.
Dorsalis?
Pedis arteriolae palpated after making what?
Only one. Then anything? Only dorsalis pedis. Any other artery is coming there in the leg?
Posterior tibial artery is there, sir, but I didn't palpate. Okay.
You have to palpate both sides. Better see when they, because when you committed, there is a claudication in your presentation. You must check that also to complete that. Otherwise, don't use the word claudication pain at that time. Okay, because you are putting in another entity, totally different entity there, vascular. So checking the peripheral pulse, particularly dorsalis pedis, posterior tibial, popliteal, is a must. Okay, yes?
So patient with 7 years of low backache with left-sided radiculopathy, suspecting of chronic disc prolapse with secondary to lumbar canal stenosis at the L4 and
No. You are putting whatever thing you know.
Chronic 7 years.
Chronic disc.
This level you say.
At
This is the question I wanted to ask when you were talking about the claudication. I mean, relieving and aggravating factor. Now you are adding a LCS. Yes.
Chronic disc prolapse mostly at L4, L5 level, sir, with L5S1 involvement also.
So why originally you said stenosis? At that time itself I stopped. It is a claudication when you mentioned. I asked you whether it is one unilateral or bilateral. Bilateral I asked. Isn't it? Okay. So if you said the diagnosis of a lumbar canal stenosis, you must also examine the patient after exacerbation. After walking for 10 minutes, you have to once again re-examine again. Because a lumbar canal stenosis, it is a clinical enigma. Straight away there will not be any findings at all when you examine. But when you make the patient walk for 10 or 15 minutes, this happens regularly in the exams. When you present the case, no neurological deficit. But the examiner asks the patient, keep on talking to you, and then ask the patient to walk for 10 minutes, and then examine, he will have a weakness. So when you make a diagnosis of a lumbar canal stenosis, make the patient walk for some time, exaggerate for some time, and then once again do a revision examination of your motor system, and then pulse also. Okay, yes, go ahead.
Only positive points. 1, 2, 3, 4.
So L4, L5 disc space is reduced.
You will not start like that.
So, this is a radiograph of the.
Yeah, this is. I don't want this also. Radiograph of
Straightening of the lumbar spine is seen, sir, with reduced disc space of L4, L5 with retrolistis.
How many lumbar vertebrae are there?
So 5.
Count. Can you get a pointer?
The accumulation of lumbar vertebra.
You count from the way in which you count it. Do you have any
L4, L3.
pointer? Oh, sorry. Here.
Calculate it on the APV or in the lateral view? They are asking about lumbarization or sacralization. Right. That it is better to calculate and count it in the lateral view or in the APV.
APV will tell about the lumbarization of the.
That is what is asked now. how many lumbar vertebrae are there. So better to do it.
Count from below.
AP view.
So, L5, L4, L3, L2, L1.
Then
Is that the last rib?
It is always better from the floating rib.
No, it's always, you see, the complications of disc surgery. If somebody asks me what is the complications of disc surgery, I'll say number 1 wrong level, number 2 wrong level, number 3 wrong level. Then only I think of other things. You see here, see this is a problem. So when we describe, nowadays we say the last segment and the last but one segment. That is how we describe, because it is always difficult. Either there is a rib may be absent or this is sacralized. How will you do that now? Is there any other ways to do it? Any other clue? Suppose if I say the rib is absent. I say the rib is absent, or the thing is...
See, although it's ideal to count from C1, given a lumbar spine, Shyam is discussing.
Highest level is L4 level, so with that we can count from above.
So highest level is corresponds to L4 you mean.
Level, yes.
You know, the longest transverse process would be L3.
See, this is the one. We don't know. This one. See this transverse process. Or this one. L3 transverse process usually horizontal.
What is
I,
syndrome?
See, the longest will be the transverse process, L3 will be the longest. Of course, we have to finally count from above and then confirm. But these are all the local points to have an additional support. The highest point of William corresponds to say L4 we say, but not always. As now the more and more the minimally invasive surgery comes, a lot of things, high ilium, low lying ilium, high lying ilium, all these things will come into play. But for your purpose, highest point is L4. And another one more point you can have is the longest will be the transverse process, so L3 will be the longest.
See, L3
so
is
with this you have a substitution, and then further you can confirm it from proximal, of course. Of course, MRI you can count from C2 and then you can count down from that. But majority of the times when the exposure is not good, and then we may do a wrong level surgery. That's why I said commonest complications in this surgery is wrong level, wrong level, wrong level. Okay? Yes, go ahead. Anything else you will see?
Suppose if we take this as L3, L4, this is L5, am right?
Yes, sir.
That is sacralized, am right? What about this?
So one is the straightening of the spine, your findings. Then you come to the disc space reduction.
L4, L5 reduction.
Involvement.
And retrolisthesis of the L4, L5 level part, grade 1.
Look at the canal diameter in the lateral grade. Okay, is there any list? If you closely watch, there is a mild list on the right side. Okay?
See, now you see the numbering now. You see the number now? There were 6 lumbar vertebrae when you saw the X-ray. You see now they are numbered. Probably the radiologist has got a pressure of advantage of starting from C2. So they have counted, and then it is L4, L5 now. But it was not there in the X-ray. So wrong level segment, you must be very careful in doing that. Okay. Yes, go ahead. Yes.
There is a paracentral left.
So now your question of canal stenosis is there?
No, sir, disc protrusion, sir. Disc protrusion.
Disc protrusion is
on the
not...
paracentral and the lateral aspect.
Okay.
Mostly on the left side more than the right.
Okay.
This or this? This one?
Central and the...
You see only this is enough for you or anything else? You see the sagittal section also. You have to know exactly the more and more minimally invasive surgery is advocated now. You must know which story it is, which is the zone, foraminal, central, lateral, foraminal, extraforaminal, all these things you are supposed to look into it, okay? And then you look into the SAG MRI. SAG, yes. You can see the foramen exactly. Can you show me the nerve root just for the postgraduate to see that? Nerve root.
So,
can you show me the nerve root?
Go back.
Nerve root. Show me only one. No, don't show in. This is a midsection. This is the midsection. This is the extreme, both right and left. You see, this is the nerve root. You see here? You know this?
Keyhole.
This is the nerve root. Proximally it is wider and then it is getting narrower. You see here. So it means it is extending almost into the far lateral side also. So all these things, where exactly there is mid-sagittal section, nothing will be seen. You will be seen unless it is in the center. So reading an MRI, as long as if you are going to be a spine faculty or going to operate on a spine surgery, you have to, for any, even for knee, etc., you don't too much rely on the radiologist report. You have to see yourself where exactly it is. And then you see where exactly you are going to go there. All these things you must see. Now what are you going to do now?
So patient has not undergone any physiotherapy or medication. So first
Yeah,
we'll
you
be
tell
planned for
what's your mode of treatment now. That's all. Don't tell stories.
so,
You do surgery, no surgery. That's all. If you do surgery, what surgery? If you are not doing surgery, what else?
so initially conservative
8 months.
advice, sir.
8 months already he
Sir,
was
he is
suffering.
suffering last 4 to 5 years. Last
4
6
to 5
months,
years.
Last 6 months he is almost he is finding difficulty to carry out the work.
See, still almost patient was on treatment for 6 years, 7 years. Now it is getting more. What do you do?
He is from
L4,
Bangladesh
L5
actually.
L4, L5 discectomy can be done, sir.
The natural process of the disc pain, it is only dehydrates and it shrinks and it relieves the compression. It is 7 years and 5 years the pain, and now he has come to you with more pain. So it is not going to get relieved. That is the reason why you have to advocate surgery, and also there is a neurological deficit. So nerve root compression must be relieved and must be given a relief, pain relief.
What the recent most surgery you know in the disc? Not elaborate, just to know.
Only coming to the cervical spine.
Any cervical sagittal is there, not loaded.
Okay.
Clinically is intact.
Okay.
So all these cases, that valid point, actually you have to read whole spine X-ray, especially in old age. If you have tendon compression, true cervical myelopathy or cord myelopathy. What is this?
Partial stabilization. Thank you, sir.
Good. Okay. No, sir, you are short cases.
Very good.
Thank you, all the dignitaries. Now we are proceeding on to 2 short cases, 10 minutes each. I'd like to invite Dr. Prakashappa and Dr. Hiranya on the stage, please. Thank you.
Kanagaraj. Good morning. A 42-year-old male patient Kanagaraj came with a chief complaints of ulcer over the right distal end of leg for the past 1 month.
Sorry, loud, I didn't hear that.
Came with the chief complaints of ulcer over the lower end of right leg for the past 1 month.
Wound over the lower leg or
Yes,
ulcer?
wound over the 1 month, sir.
1 month.
Yes. The patient was had a RTA 10 months back. He sustained a
RTA.
road traffic accident, sustained a trauma to the right thigh and right leg. he brought to St. John's Medical Hospital. He diagnosed with the fracture of right thigh bone and right leg bone fracture, sir. So he advised surgery. He went surgery for both thigh bone fracture and leg bone fracture on the same day.
We are given 10 minutes diagnosis.
Sir. Yeah, post-traumatic, post-surgical osteomyelitis of right tibia, acute osteomyelitis of right tibia.
The foot is
What
not
is the duration?
So 1 month.
To somebody sitting here, what is striking here is severe cavers, clawing of the toes. There is the way he walked in. He needed support. He needed help to get up.
Yes, sir. Patient is a known case of left lower limb residual paralysis of polio since
You
5
didn't
years.
say that.
Lower limb.
No. When you say the diagnosis, it is obvious. Do you think that all the deformities are due to trauma?
No, sir.
Then when you say it is nothing to do with the trauma now, you tell that what is striking. Patient is not able to walk, foot is different.
Yeah, that's it.
That will be better.
So simple.
So that you can rule out other things. What examiners expect, all those things, you know.
In a known case of post-polio residual paralysis involving both lower limbs and the trunk. Trunk is also not normal.
Scoliotic deformity.
So now you are saying that. Just as I saw him walk in, I saw so many things. So obviously he was a paralytic case. Obviously his spine involvement. So I am thinking in terms of a paraplegia with sensory deficit with non-healing wound. That's what went through. I didn't know about the road traffic injury. So you have to educate me on that. So when I ask you to tell me the diagnosis, I want to know the baseline and the current nature of the problem. I give you one more chance. Give me the diagnosis.
And as a spine surgeon, my view was both foot deformities, non-healing ulcer, something wrong with the
Yeah, I was also thinking of the same thing.
Go ahead.
So you think it is osteomyelitis with non-healing ulcer?
Yes, sir.
Justify your diagnosis.
Sir, it's occurred just 1 month back, sir. It's before that he don't have any
1 month
ulcers.
back it is chronic osteomyelitis.
Acute osteomyelitis, I am telling.
Acute. 1 month acute. In a adult patient like this, is it common acute hematogenous, acute post-traumatic?
Hematogenous.
Hematogenous in this age group.
This is actually after surgery, post-op period, last 9 months, he don't have any complaints, sir. Since last 1 month,
Initially, is it a compound fracture or a?
No, sir, it's a closed wound.
It's a closed wound.
Now ulcer is there, na? Yes, sir. He last 1 month back, he developed a small swelling. Insidiously, he find out. Chronic, sir.
1 month is anyway going into chronic.
Yes, sir. Inside already tibia fixation is there, sir. Yes. Yes, sir. He went 1 more time for a debridement.
Sorry, I don't know Kannada.
Sir, Tamil. In the ulcer, in the
touch you can feel வித்தியாசம் different
ஏதாவது வித்தியாசம் இருக்கான்னு கேட்குறாங்க ஒரே மாதிரி இது எவ்வளோ நாளா இருக்கும் Yes, sir, tibia nailing, sir. Sir, actually, no implant is palpable, sir. He have tenderness over the edges of the ulcer. Yes, sir, maybe. sir.
I think osteomyelitis produces sinus. But osteomyelitis do not produce a bigger ulcer.
So the ulcer can infect the underlying
Bone.
periosteum and the cortex, and then it might go into the. Because if you say osteomyelitis, this is the marrow as well as the cortex.
Cortex
Both
involved.
are
Involved.
You think that is what has happened here?
Sir, it may be due to the secondary ulcer, non-healing, the healing ulcer because of previous cellulitis also, sir.
Okay, now I will ask you now, what are the points to say it is an osteomyelitis? What are the points to say it is an osteomyelitis?
Any clinical
History
findings?
Of, history of surgery.
That side local.
Sir, it's a screw site, that's what I am thinking.
Okay, it's just surgery. Any other evidence? Why do you say it is an osteomyelitis?
What are the clinical features of osteomyelitis?
In acute, sir, or chronic?
This case chronic, don't say acute.
Nobody will put the acute cases there. Only that it will be a chronic one.
Chronic one.
When
Yeah,
I
1
asked
month,
the-
1 month duration.
So tell the clinical features of acute osteomyelitis.
Osteomyelitis.
Osteomyelitis, and then tell what it fits in.
Sir, any discharging sinus?
Okay.
Any skin over the lesion is, any tethering or puckering is there or not?
Okay.
Any local rise of temperature?
Okay.
And any
This
bone is
chronic,
papules
how can you
is
get
coming
a-
out
This
from
looks
the
like
sinus.
a nishar. You know what is a nishar?
Anything else?
This is a nishar.
If the bone is thickened,
So it's a nishar is forming with inflammation all around, with a discharging area. That whole thing is puckered to the deep bone,
Deep bone, oh.
and the bone is tender.
Yes, sir.
He doesn't have pain on walking. I've asked him that. So he doesn't have pain here, but he has pain in the ankle when he's walking. He has pain in the knee when he's walking.
Yes, sir.
He can acute tenderness in the probably an implant site in the proximal site. When I pressed there, he almost cried.
Oh.
On this side, there's an implant there.
Yes.
bone is thick.
Proximal screw.
Yeah, probably the proximal screw is acutely tender. So here is a patient in a baseline case of post-polio residual paralysis involving the trunk and the lower limb, having a road traffic injury with post-operative, post-implant, probably a nail has been put there. I can feel a proximal screw there, with now a secondary infection which has come up. It is infection is in the bone because the ishar that is formed is adherent. The entire skin is adherent to the bone there with a discharging sinus. With an active infection because skin overlying is red, angry looking. And he has got pain. 1 month history.
If the bone is thick,
Sorry?
the bone is tender.
It
bone
can
is
be an
thick.
acute and chronic.
See, chronic osteomyelitis,
It,
bone
this,
will be thick.
most likely it is osteomyelitis because the way the whole skin is puckered to the bone underlying. It's adherent. I can't move it at all.
No, the bone will be thick. The bone will be tender. This ulcer or sinus will be adherent to the underlying structure. Okay. So whether any of these things are there clinically. Now you see
The ulcer is right over this. It's right over the fracture site. That's all I can say.
Can you show why it is get?
Osteomyelitis. In between us.
So what you can say is chronic, because chronic osteomyelitis producing sinus,
Ulcer.
thickened
Bone.
tender, all those features are not there.
Yes, sir.
It is an ulcer primarily with an ishar as I was mentioning. And underlying bone is also getting infected.
Acute tenderness over the implant site. Acutely tender. He almost cried. Actually, I regretted having pressed him there.
It is how long the injury?
Sir?
1 year history, no? 8 months history.
Sir. Yes. Sir, it may be due to previous arthritic changes because of polio.
No. Question is that why pain in the knee and the ankle? Okay, here because of the problem, any intramedullary infection is going on or only superficial infection, you have to see. Okay. Any implant is irritating there? Any intramedullary infection?
Thing is going on around the fracture site, both AP and lateral view. Other view.
On this TV screen, we can see the fracture is not healed. We can't make out here, but there we can see lateral view. We can make out. There's a line visible. Yeah. There we can see the clear.
Dense sclerotic bone.
And that area seems a little more sclerotic. Yeah, that area is more sclerotic.
So what is going on?
Sir, with the 9-month history, it's going into the non-union, sir. With dense sclerotic bone at the edges of the fracture site, it may be the sequestrum.
Probably that is set in. Yes, sir. Okay. What will you do?
What will you do now?
Sir, I will first go with the blood investigation, sir, whether the patient is in acute phase or not. Sir, I will see the blood investigation whether patient is in acute phase of infection or not. Sir.
ESR is high, white blood count is high. Now what do you do?
What?
First, I want to go with the 2-stage procedure, sir. First, I will remove the implant. I will wait the infection to subside. Later on, I will go with the revision.
Remove the implant and do a debridement. Not just remove the implant and do a debridement and thorough washout.
Thorough washout. Later on, once the inflammatory markers came down, I will go with the revision surgery. If needs, I will go with the bone graft.
If need, bone graft.
Yes, sir.
In presence of so much of infection, so how will you stabilize? First stage, after removing this, what will you
I
do?
will debride the fracture end, sir.
And do what? Leave it like in a plaster.
I will check the stability.
He is now working on internal splint. That's with the proximal tibia because all the load is coming on the proximal tibia because of the screws. That's why it's acutely tender.
Sir, I will check the intra stability, sir. If it is, I will apply X-Fix, sir.
X-Fix, yeah, that you can see.
Sir, if fibula is obstructing the tibia to get union, I will do the osteotomy at the fracture site. I will do it now.
What are the issues you are seeing? One is non-union,
sir.
Another is infection.
Sir.
Is there any limb discrepancy?
Plus that dead bone that is there.
No, sir.
So you have to deprive. You might lose some more bone. There might be
shortening at the fracture site.
Plus that dead skin might come off and you will have a skin loss also, exposed bone also.
For iliceral fixation, sir.
See, the test scar is there. No, you don't want to do anything for that one. Unless you do something for that one, if you do the next surgery also, you won't get the union.
Some plastic surgery also. Coverage.
For wound coverage.
So in the exam, since we have only 10 minutes, in the exam, sorry. Yeah, so in the exam, the student has to flag, sir, there are two parts of the problem. The fracture does not seem to have healed and there is infection from the bone and an ishar which is causing a skin loss. So the first step is to address the infection. So I'll need to take out the hardware, debride the bone. That dead bone will be clearly visible. It might be loose, it might just come out. It doesn't look so because it's splintered by the nail. The whole thing might come out, you end up with a skin loss and a bone loss. Both will be there. So what will I do? I'll allow the fibula I won't touch, I'll leave it there. Two possibilities, I can do a primary external fixator, clearly understanding I'll need to reconstruct that flap with a flap, either yourself or a plastic surgeon to help you to cover the skin. And then second stage, address the bone gap and non-union using an Ilizarov. That will probably be the best option. What will I do? I'll do the same thing, but minus the external fixator in the first stage. Just give a plaster, allow the wound to be covered with the plastic surgeon's help, or I do it myself. And then secondary Ilizarov will be required. In this patient, Ilizarov would probably be the best option. Okay?
So you can do the fibulactomy.
Two stage will be required. Why? Because there will be a plastic, because that's going to give a nice big hole in your skin.
It will give a
You need to address that. Anything else you would?
Any questions? It's a common case. If you get it in exams, you may fail. You have to answer 100% in this case.
So first stage external fixator followed by Ilizarov, or you may do it in an external fixator. LRS. LRS can also be done. You will need to prepare for bone transport. Yeah, fibula is providing stability.
Sir, what about
Before
going
doing
again
this,
with the intramedullary
we will
implant?
opt for to know CT, how much that is bone is there.
I don't think, well, too many interference will be there. You will get no additional value.
Sir, what
After
about
removing, maybe yes. After the hardware is removal, yes. Antibiotic nail I would have done if there was no anticipated gap. There's an anticipated
what
gap
about
that
the
won't
second
cover up.
stage? Again the intramedullary implant.
Intramedullary implant.
Sir was telling, no?
Sir?
If there is a gap, just an antibiotic nail won't help. You need to fill the gap.
Thank you.
On to the next short case.
Thank you, thank you.
In fact, the patient attended one more case. Yeah.
She must be polio. She must be polio.
She is also.
I know that. I see it every day. Polio patients married to polio patients.
Please observe the gait, this patient, all of you sitting back. Yeah, please present.
Patient name Saraswati, age 45 years old. It's a history of weakness present over the bilateral lower limbs.
Just come to the diagnosis.
Status post-paralytic residual paralysis of the bilateral lower limbs with foot drop present over the right.
Foot
left.
drop.
Yes.
See, in case of poliomyelitis, don't say put drop, you have to, what is over is remaining, that's all. Sensor is involved in this case?
No, sir.
So deformity and remain in the power.
Left side she is having foot deformity present.
Cavus is there,
Cavus
varus is
there.
there. What is happening in the heel?
Power is 0, sir. Plant of dorsiflexion is 0, sir.
See, in the exam you will be given one side or one ankle or one knee or one foot
You
to
can examine
examine.
the left side and tell, no problem.
So just the left side you can tell us what is there.
Hip abductors are L3 is 3 by 5 and
No, I'm not asking you muscle
Only
power.
the ankle of
What is the deformity on the left side? I only want you to tell me the deformity.
it's
You saw her walk?
genovalgum is present, sir, and cavus
Sir is
deform.
asking only the
Only the foot.
Foot
Cavus,
I am making your task simple. Ignore the rest of the body. Just the left foot. What is the problem? What is the problem with
equinus is present, sir.
equinus? Okay. I think all of you should try to recognize. If you see the way she was walking, when would you say there is equinus? Vali irukilla?
If you see this heel and see this heel, come from there and see. Which heel is bigger? No, don't block others' view. Side. Okay. This heel is broad. This heel is broad. This heel is small. This heel is inverted. This heel is in eversion. Most of the weight bearing is here. There's eversion. It's in valgus. This is a classic calcaneovalgus foot. Calcaneovalgus foot. Because the patient is predominantly walking on the heel. Right from childhood, heel is broader, heel is larger, more prominent. Right from childhood, she's not putting weight. See this? She's not putting weight so much on this side. It's inverted. It's a little equinus. There is equinus here. There's no equinus here. This calcaneo. See this? It's a calcaneovalgus foot. It's a classic calcaneovalgus. The gait was also typical. No push-off. Calcaneus means the paralysis of gastrosoleus. So there is no push-off. So if I ask you to test for the gastrosoleus, what will you find? So if I were to do that, I'm not making a lie down. I put my hand there and ask her to pull the heel up like that. No, down. Down. Yeah. It's contracting. Tendo Achilles is working. Whereas on this side, if I ask her to do that, nothing. It's a totally paralyzed gastrosoleus. No contraction there, no movement there, whereas this is moving. It's not an equinus foot. It's a calcaneus foot. Okay, I think Dr. Mallikarjuna just wanted to flag the calcaneus foot, is it?
Yes.
Yeah. He wanted to demonstrate a calcaneovalgus foot as a spotter. And that's what it is.
Because CTV, neglected CTV, today OPD, unfortunately we didn't receive. That's why I got this.
Just watch the gaze. Just lift it up. When I came, I checked only one thing. I wanted to be sure a patient with calcaneus usually will have a hand on thigh gait. She was not walking with a hand on thigh. The only thing I checked was, did she have a quadriceps? Yes, she has. The quadriceps is functional.
Normal fast walk ಮಾಡಿದ್ರೆ ಕೈಯಲ್ಲಿ ಸಪೋರ್ಟ್ ತಗೋತೀರಾ ಹಿಂದೆ
No hand support, no hand on thigh. Correct. So I asked her to do this.
So you people in the exams they will ask P body classification.
Quadriceps is intact.
Okay.
Down. This side. Quadriceps is in. That's why she is walking without hand on thigh. But she has a calcaneovalgus on the left side, equinovarus on the right side. She has a problem. Valirika? Illa. She has no pain. So she just happens to be an attendant. She's been brought here. So in the exam, if you start talking about surgeries, you're in for trouble. Okay? Anything else you want to ask, you can ask.
No, only theory you people have to read. Post polio is lesser and less you see nowadays. Even the Campbell is almost vanished, that chapter. But if we get a case in some center, especially going for DNB, you should be thorough about that. P-body classification definitely has. Okay? And you have to thorough about the theory and how you will balance whether required bony procedure and soft tissue procedure are combined. You have to discuss that.
So when I took the lecture on gait, I did not cover the paralytic gait. If you give me 2 minutes, I'll cover one important part.
Why not, sir? Please.
One important part of gait. In a paralytic patient, you'd look at the muscle strength. And this I learnt as a postgraduate when my registrar taught me and took me to a polio camp. He said, you need only grade 9 power in 3 plus 3 plus 3 muscles. That's it for independent walking. And what are those 3 muscles? If you remember my gait basics, I said gluteus maximus, grade 3, quadriceps femoris, grade 3, and gastrocnemius, grade 3. 3 plus 3 plus 3, you need great power only for walking. If you have quadriceps loss of power, then you will need to prevent that buckling of the knee in the foot flat, no, but in the mid stance. So the patients will use a hand on thigh. They'll do this. They'll do this. They'll do this.
Antony gait.
As a hand on thigh or a hand on knee, or as they grow older, become conscious of the opposite gender, they don't want to show they have a limp, they'll do this. But it's basically a hand on thigh gait.
Inside of the pocket.
Okay, they'll keep their hand in their pocket and walk like that. That's a hand on thigh gait. But they don't need it throughout the walk. Only when mid stance is the axis of weight bearing is behind. The moment it comes on top and in front, you don't need that push. So that's it. However, if the patient has a quadriceps paralysis with calcaneus, there is trouble. You will always have a hand on thigh. If the quadriceps power is weak and there is gluteus maximus and there is a little equinus, then again they won't have hand on thigh. So that is known as alignment compass. So they learn gluteus is there, this is not there, and this is there. They learn that if they hold the foot in equinus and delay that whole process of heel strike, prevent heel strike, then again don't need hand strike. So that's known as alignment stability. And that alignment stability is what you need to understand the principle of. So normally when you put your heel down, foot flat, mid stance is buckling. Quadriceps is not there. So the way of compensating is either this or create a recurvatum. So that is what was the classical extension osteotomy which is done to create recurvatum in the knee. So the axis of center of gravity falls in front of the axis of rotation, so no collapse, all fine. But equinus can help you do the alignment stability. How do you do that? So instead of heel strike and foot flat and heel off, the final equinus, if it is there, first thing is toe down. He is putting the directly toe. He has bypassed the first 3 stages. Heel strike is bypassed, foot flat is bypassed, mid pass is bypassed. You suddenly straight come to the toe off stage. At that stage, where is your center of gravity? Your center of gravity is in front of the knee joint. So what these patients do, they take short steps and throw their body weight forward, and that brings a CG in front of the axis of rotation of the knee joint, and the knee doesn't buckle. So all these patients that have good gastrocnemius, good gluteus maximus, do alignment stability and walk without hand on thigh. They walk like that. They always walk like that. So I wasn't sure whether she is walking like that, but the knee looked a little deformed. There is a little recurvatum there, and that is also contributing stability. So I wanted to be sure, is it recurvatum or is it quadriceps functioning? She has a quadriceps functioning and also a little recurvatum. Both contribute to a stable knee, and she is happily walking despite a calcaneus foot. Only other thing that I would check, in the examination would be gluteus maximus power. I need nothing else.
Sir, if you don't mind.
Is that clear? Yeah.
If a patient has got quadriceps weakness, anti-knee gait, how flow reaction will help such kind of patients? Can you tell us?
Flow reaction. So what is the principle of flow reaction? It is based on the principle of alignment stability of equinus creation. So if the patient has a gluteus maximus, has weak quadriceps, and also has a partially functioning gastrosoleus, which cannot hold the foot in equinus for sufficiently strong time. A flow reaction orthosis is based on two principles. First principle is creating equinus at the ankle. So the flow reaction orthosis is always, you heard yesterday Dr. Athani telling you, it is held in 15 degrees of equinus. It's not a neutral. A PTB is a neutral, but a flow reaction orthosis is in 15-degree equinus. That is there. Second, that provides alignment stability. So delays heel strike, allows early forefoot strike, and prevents all the previous stages, which allows buckling. The second thing is, when your foot is touching the ground, the forefoot is touching the ground, ground reaction forces, Newton's law, third law, equal and opposite ground reaction forces, they come onto your brace, the flow reaction orthosis, transmitted along the, it's an oblique force now. So all oblique forces are converted into, they have vectors, a horizontal vector and a vertical vector. The vertical vector helps neutralize the body weight, but the horizontal vector doesn't become apparent till the front thigh extension comes up. That gives a little push back at the knee. So flow reaction orthosis is useful in those patients with borderline gastrosoleus function, with quadriceps paralysis, with good gluteus maximus, which delays heel strike and provides alignment stability by equinus, and two, harnessing ground reaction forces to provide a posterior thrust, to provide that little pushback to prevent buckling of the knee and allow walking without hand on thigh.
Why specifically I requested sir to explain, because last DNB when I went for 515 students, only 12 to 15% of the candidates have been answered correctly. Rest of them have written whatever they like. Okay? Please understand this. Yeah.
I hope that's clear.
No, sir. Fine. What she is wearing, sir? Sandals she was wearing outside.
I think we'll end up this. We have some cases post lunch. Some short cases are there. Okay. I think post lunch we'll have some 2 short cases followed by some talks. What not to write. Okay. And some X-rays and wardrobes. So many things are in there. I think we will go for short break of valvular function now. Okay. Yeah. Because we want to have a group photo before everything disperses. After somebody will be on the way to airport, train. So valedictory function is little bit premature because I am doing the 2 reasons, and the post lunch some of the people will sleep up, and our distinguished faculty they are in way to go back their places, and even the students, those who are procured whatever the prizes, they may not be there to receive the prizes. As a customary that we are going to announce the winners of both the quiz and as well as the case presenter. Before starting that, I extremely thankful to all the faculties. They have come all the way from Jammu and Kashmir up to Kanyakumari, I can say. I am really thankful to Matthew sir and Rajmani sir, Gupta sir and Vadivelu sir, and as usual our friend Ajit Kumar sir and Kamat sir and Edward Nazar sir. Ashwin Kumar sir, please accept our acknowledgement, our thanks. And our local Srinivas Reddy sir, YSS president, our good friend Goni, and Hiranya sir and Prakashap, our local HODs from the Vaidehi and Sanjay Gandhi Hospital. And of the people, so many our faculties are not there. Yesterday they have left. On behalf of St. John's Department of Orthopaedics, I am thankful to everyone sparing your valuable time. Hopefully, it is much more utilized by our students, and I really thankful to the people that come all the way from few states, all the students. I hope it is quite useful. And thank you once again, sir. Thank you. And we are going to announce the quiz. Because shortage of time, you have reduced the quiz times and you have taken some models. And winner of the quiz goes to Dr. Kiran Kumar Y, Dayananda Sagar Hospital, and Dr. Prakyat from People Tree Hospital. He's a runner-up, huh? He's a runner-up. What I announced now, it is a runner-up from the quiz. Okay, please come and accept. I request Singar Medivalu sir, please come. It has got a small amount of cash prize. Okay. Next winner of the quiz will goes to Yenaro Hospital, Visakhapatnam, Dr. What is that? Kabilan, Dr. M. Janaki Shri. I request OIS's President, Srinivas Reddy Garu, please honor them. Big applause to them, please. These are the prizes assessed by the neutral judges, the outsiders actually. You are the case presenters. The best case presenter award goes to Dr. Monish N. Is our student only. And by judges, I request KOA President Edward Rajaras sir, please hand over. I don't know which case he presented. Spine case he presented, I think. Cervical myelopathy. Who are the judges? I don't know. Anybody in behalf of Monish can take the award? He must be in somewhere area. Big applause. Although Monish is missing. Once again, thank everyone and thanks our management. And before concluding that, from IOA PG committee, I think I request Gupta ji to speak few words. Please come, sir.
First of all, I must, thank Professor Mallikarjuna for acceding to our demand. Demand is my request, our request also for conducting this program here in this institution. So I made this request about 6 months back, and he, acceded to that. So this is our 4th program. We are conducting it all over India, and next program is with in Chennai. Yeah, in Chennai next month, first week of is first and second, sir. 2nd September, 2nd, 3rd, 2nd, 3rd, 4th. Second week of September, yes. So we have to conduct 4 more this year. So 8 to 9 we are conducting every year. So I think it is going to be beneficial for you people as far the exam is concerned. One thing I must tell you, you must interact. What I found here was interaction was a little bit less. If you will not interact, then there is no use. So I'll request 2 students to give us the feedback. This is for us also. What you found about this course, useful, useless, whatever you want to say, you can say. 1 female, 1 male, yes. Female here. Only 2-3 words, whatever. Quickly. About this course, what you found useful? Okay. So it is useful.
Yes, sir.
Good. So what do you want us to do more in next courses? Anything different? No. She must have the 2 days she is seeing the things. Everything is okay?
Yes, sir.
Good. Any mail quickly here from this side? Yes. Yes. Stand up. You stand up. Yeah. In few places we had.
It was very useful, sir. It was very useful to us, sir.
Very useful.
Yes, sir.
Anything extra? Yes, because we can see. I always say negative feedback is very, very good, for improvement. Positive feedback everybody will give. If you give us a negative feedback, we can improve on that. Anything? Nothing? Okay, thank you. Then we must give a standing ovation to Mallikarjuna for wonderfully organizing this conference. Wonderful hospitality. Rajkumar is here. Raj is here.
I feel all this thing goes to my department. My voice is not because of me. I am just in front there. That's all. Okay. Thank you.
Thank you very much. Thank you.
And post lunch session, before going, we are going to have photographs with distinguished faculties. Post lunch, please come back. You have interesting part. What not to write in the exams. Okay, you all write so many things. That will by only one, our known Professor Edward Najaras sir will talk. And we have ward rounds and x-rays and implants. If you want, we will have some cases if you want to discuss. Okay? Fine? Come for ad for the photographs. Thank you one and all. Thank you.
Good afternoon, everyone. I would like to call upon Dr. Vijay Goni and Rajesh Gupta for the X-ray sessions, please. Oh. Okay, sir.
Welcome back after a lunch session. I hope everybody is fresh and fine.
मेरे पास
Voluntarily, anybody can get up and read.
We'll get them up, you know. You start from here, yes, you. Read the X-ray, just read the X-ray, what is it?
Sir, X-ray of the right femur in a skeletally immature.
Good, go ahead, go ahead.
Person.
Showing what?
What could be the possible?
Osteolytic area in the distal 1/3, mid 1/3 junction, and area of
What is here?
area of sclerosis, cortical thickening,
Huh?
cortical thickening.
Cortex?
Cortex is thickened.
So what do you say? Sclerosis, yes?
Yeah, sclerosis.
So there is a sclerosis, there is a lytic area. What else?
Radiologically, what type of lesion it is? Geographic, permeative?
Permeative is
Or martyrdom, which one?
so it's a permeative type of lesion.
Not permeative, it is not permeative. So how it look like, you know, there is somewhere there is a thickening, somewhere there is a thinning, you know, there is sclerosis, and there are lytic areas. So what would be,
Is there a bone reaction?
Yeah.
Is the bone reacting to it?
No, sir.
Periosteal reaction.
There is no periosteal
A
reaction.
new bone is formed.
No periosteal reaction.
No periosteal reaction, no new bone. So essentially, does it look like a benign lesion or a malignant?
It looks like a benign lesion.
So then, if you are mentioning like a permeative type, then it means that something ominous.
So, yes, in a child.
Site you mentioned, no periosteal reaction, possibility.
Next.
Anybody?
Good. Looks like.
Any other differential diagnosis?
You call it as fibrous dysplasia or something else?
There is going to be a question shortly.
Fibrous cortical
I'll
dysplasia.
ask one more question. Either the fibrous dysplasia or something else.
You get a localized fibrous dysplasia like that?
It is a localized lesion, isn't it?
Osteoid does not look like this. There's more localized in the cortex, not that diffuse.
What is the pathognomic feature of the osteoidostoma?
Nidus will be present in that.
Yes. And how it is differentiated from osteoblastoma? How it is differentiated from osteoblastoma? radiologically?
What osteoblastoma has, osteoblastoma doesn't have.
Say yes. How much? How much? So osteoblasts are usually more than 2 centimeter. Usually more than 2 centimeter, right?
How you manage osteoblastoma?
So this
The
diagram.
patient, first we will treat with NSAIDs. It's a prostaglandin secreting tumor. First I will treat with the NSAIDs.
Which NSAID?
That's what I want. What amount?
Sir, COX inhibitors.
Can you specifically tell something?
Aspirin.
Yes.
Dosage. Chart. What is this? We debug now.
Sir,
Somebody said it.
fibrous dysplasia.
Fibrous dysplasia appearance is classical or something different.
Could it be osteomyelitis?
But periosteal reaction is not there, sir.
Maybe quiescent?
Child it will be more.
Maybe it started here, now it is healed. Can give this type of picture. You may not find periosteal reaction, you know. Someday it may reactivate again, then you can find anything, everything. So that is another possibility.
Maybe healed
Yes.
diaphyseal osteomyelitis. Subacute.
And any other thing? If you see cortex here, it is thinned, you know, we cannot comment on one side cortex, only on two views. As per age, can it be Ewing sarcoma? So this is all differential diagnosis, you know, you should know it should be in your mind. Everything will be discussed on the X-ray. Could it be Ewing's? What is against Ewing's?
Side, sir, diaphyseal.
Oh. That is normal. Ewing's is diaphysis.
Can come in metaphysis, but mainly it is in diaphysis.
There is a lot of sclerosis is there, lysis is there. So
Lamellated appearance, like an onion peel.
Onion peel appearance.
Okay, lamellated bone formation. Multiple layers of bone.
Oh.
Next.
Person.
So the X-ray spine showing the AP and lateral view, sir. L5, L4.
What do you see on the X-rays?
Area of interest.
Sir, L4 and L3 regions. L3, L4, L5 region.
Okay.
What is this level? What is this one?
That is L5, sir.
What is this?
L4.
L3, L4, yes. So what has happened?
This doesn't look like congenital, sir. Maybe trauma.
no, what it is, you tell
Trauma.
them. What has happened?
Disc space మొత్తం
Two vertebrae are there, intervertebral space is affected.
yes, sir. L3, L4.
This
L3,
space
L4,
is
this
lost.
space is lost, sir.
So you should understand that there is one which is here. So there is one pedicle here, there is one pedicle here. There should have been one pedicle in body which is not there. Or is it only the two?
Or it is a post-tubercular.
Post-traumatic.
Post-traumatic or post-infective? Why the disc space has gone?
Post-infective also.
It is a healed or not healed?
It looks like healed.
Can you see that anteriorly there is a continuity between the two?
Yes, sir.
Okay. Ah.
Trauma, you get a burst or a wedge.
Two vertebrae involved.
Tuberculosis. So what could be the possibilities?
One One might be post-tuberculosis, sir.
Speak in the mic.
Healed tuberculosis.
One. Second. What else?
Can it be congenital condition?
Something here not good, maybe congenital, we don't know.
Maybe.
It is
So
a,
there
yeah.
is one,
Bar is there, so it may be congenital.
So there are two transits.
Yeah. Third possibility can be trauma.
That can be trauma.
Unlikely. Why?
If there is trauma, it should be completely burst like fracture and all.
You get a clear-cut pattern of fractures in trauma. You get anterior wedge fracture or a total wedge or it is a burst fracture.
So usually in trauma, disc space is maintained. So there are few things about disc space, little bit. So about the disc space, few things has to be there. We can differentiate many things. This is what I teach to my undergraduates also. Now everything depends on the end plate. If the end plate is normal, the disc space is decreased. We usually say it is a disc prolapse. But disc prolapse we cannot comment on the acute case. In a chronic case, yes, it may decrease. But in acute, no. Now disc space is decreased, and there is a fuzziness or destruction of the end plate. Mostly goes in favor of tuberculosis, or we can say even discitis also, pyogenic. But tuberculosis is more common, And even there are points to differentiate that. I'm not going into details of those. Now, disc space is maintained in few very, very important conditions. One is trauma. Usually we say in trauma it is maintained. Okay? Second, it could be tumor also, collapse. It is maintained, but then there are few things in the tumor to say is the interpedicular distance, all those things. Third, there is some, the vertebra plana, the Schurman's disease. So many things, the disc space is maintained. Even central type of the tuberculosis, disc space is maintained. So many things, you can, diagnose with a disc space only. So here there are 3-4 possibilities, you have to keep in mind. Yeah, congenital, traumatic, and trauma are rare. Oh, itna bhi kafi hai. Ye kya ho gaya? Yes.
Sir, this is a plain radiograph of a skeletally mature individual of showing an AP view of a pelvis with both hip, and so in this we can see there is a heterotrophic ossification in the left hip.
Most likely.
Heterotrophic ossification.
Yeah.
Is it heterotrophic ossification only, or there is destruction is there?
Is there any destruction of the proximal femur?
What has happened to the proximal femur? What has happened to the acetabulum? What happened to the adjoining ilium? Ischium?
First you should say that the pelvis is rotated, so you will not be able to compare and comment. So the operator foramen here is not seen, here it is seen. Pubic symphysis is not in line. So it is completely rotated. This is the operator view, this is an iliac view of the hips, which you are seeing. So here you see that there is a remnant of the neck and the head, but there is huge ossification. Bony mass, which is crossing from the ilium to the femur. Yes. What do you think it is? Is it? Is it some tumorous condition, or is it traumatic condition? Trauma involving here.
So once only. No idea. No idea.
So what more clue you want? So who is prone for heterotopic ossification? So if there is one area in the posterior or anterior, you can understand. But a huge global heterotopic ossification, who are prone for? Where, in which patient they are head injury patient? So most likely, some head injury patient who have
Opening, no? Opening. Yeah, then you. Paraplegics. Like that.
Yes.
What is the prophylactic treatment for heterotopic? The sir said everything. Head injury on ventilator. How will?
What is the one term you do?
Indomethacin.
How much?
200 ml.
200
From where you get
75 ml.
It comes 25 and 75.
75.
25 milligram TID. Okay.
Okay.
Next.
One from this end first.
Thank you. See you. See you. See you. कौन बोल रहा है? Who is volunteering? Come. Fast.
Sir, X-ray of.
Read.
So it's a plain X-ray of a mature skeleton of right leg, showing hypertrophic fracture ends of both bone of distal 2/3 and the proximal 2/3 and distal 1/3 junction. Mostly hypertrophic, might be non-union, depending on the history.
Diagnosis.
Possible causes.
Trauma, sir.
So we agree this is non-union. So what are the possible causes here?
So, improper fixation, sir.
Yes.
In the inadequate fixation.
Where is the fixation?
So,
biological problems.
So this is mechanical inadequacy.
Inadequate, improper.
If you
Patient is from Chittoor.
Local osteopaths.
if this is the X-ray immediately after the reduction, presume that it is not the post-injury X-ray. Immediately second day after the X-ray, will you accept this reduction or no to apply plaster?
So the question is, what are the criteria? What are the values you accept in a close reduction? If you have done a close reduction, so how much you can accept?
What you can accept?
Sir, external rotation is accepted, sir. Internal rotation is not accepted.
No. There is a value, There is a value for everything. What is the anterior posterior, varus valgus, rotations?
And most important,
How much?
angulation.
Angulation, yes. No, anybody?
Chalo, go and
No, actually, close karte nahi hai aajkal. Okay, they don't do. Everything operated.
तो चित्तूर वाले को पढ़ाना पड़ेगी. Yeah, alternatively, one from you, one from me.
X-ray of a skeletally mature patient of the knee joint showing in AP and lateral view, showing a lytic lesion over the lateral aspect of the distal femur, sir.
So what are the other components of the lesion? There are many things here now.
Yeah. It's a oval-shaped lesion, expansile in nature, around circumference around 4 centimeter.
What is the extent? You know, see there. What is the extent here now?
From the
See, what is the extent? It is going right up there. If you see the X-ray.
Yes, sir. So looks like a malignant lesion, sir.
Yes, good. So what are the findings you are seeing in the X-ray? Just read the X-ray. What you are seeing.
So lytic lesion over the lateral aspect of the distal femur, and the lesion is around 4 to 5 centimeter in.
No, that is all not required. What the lesion has done to the bone, what bone has done to the lesion.
Soft tissue involvement.
Soft tissue involvement is present, and the lesion has encroached into the bone, causing lysis. Predominantly lytic lesion. Yes, sir.
See what?
I mean to say lytic lesion, sir. It's a lytic lesion.
There. What are the other findings? You know, quick.
No, no, a bony tumor that has encroached into the soft tissues. So, looks like primary tumor, sir. Primary malignant. So most probably osteosarcoma.
What is the age of the patient?
Skeletally mature.
So if it is osteosarcoma, what type of osteosarcoma? You just want me to rattle off 3 or 4 types of osteosarcoma. It looks like a mature bone.
Yes, sir.
At this age, you get osteosarcoma is very rare. If at all osteosarcoma, sir has asked what type?
If not.
If not osteosarcoma, what else?
GCT.
Aggressive diagnosis.
Yes, aggressive type GCT.
ACT.
Some septae are there.
See the marrow involvement.
It looks highly malignant.
Can this be a secondary spondylosis?
So secondary mostly will affect the diaphyseal region, and secondary will mostly affect the diaphysis and will be lytic lesion in the center.
This is what you see is the patella.
It's
Just read the X-ray.
it's a plain X-ray of the knee joint of a skeletally mature individual, showing a sclerotic bone lesion on the distal one third of the femur, with the lesion extending periostally also, parostally also. There are areas of sclerosis and lysis also. Both are there in the distal femur. Yes, sir. Periostal elevation is also periostal reaction. Codman's triangle, sir. Present. Osteosarcoma, probably a telangiectatic or a parosteal type of. Yes, sir. Yes, sir. Awesome.
Now you tell us the types of osteosarcoma still pending.
Can this be parosteal osteosarcoma?
How you classify osteosarcoma? That's the physical question.
Periosteal, parosteal, then
Primary and
secondary.
Primary and secondary.
secondary.
Primary could be 1, 2, 3, 4, 5 years.
Go back. Okay, they'll read up. Okay, it is osteosarcoma. Principles of management. Principles of management.
How you manage a case of osteosarcoma?
First and foremost,
I think you are the
blood investigations, imaging.
second,
We need to look at
biopsy by the treating surgeon. Right? Read about all about it. Three,
surgical, definitive surgical.
neoadjuvant chemotherapy. 4, definitive surgery. 5, already 4 o'clock. Adjuvant. Okay?
Yes.
Staging, all that you got to read up. Is a long question, Baba?
It's a definite question. One of the question, very question or case.
Yes.
What do you call this? Describe this deformity. Hello.
They know it. They know it. Diagnosis? Chalo.
What long-term complications?
That is it. सब भाग रहे हैं हम रह जाएंगे
All the best. Both of you. See you there. Yeah, diagnosis.
They have already told diagnosis already.
Okay. Go to the next one. Fantastic.
Trauma. Next.
Who's a trauma surgeon?
Clear cut diagnosis.
Plain radio X-ray of skeletally matured patient showing pelvis with bilateral hip, APV with posterior dislocation of left hip.
Posterior.
Head is not visible, sir. It's
What type of
Flex
dislocation is this?
it's flexed, abducted, and externally rotated. It could be anterior or inferior.
So what type of anterior? Anterior what type? You know, if it's lying here, it is obturator. If it is lying here, it is pubic. Simple. So this is a very unusual X-rays. You know, anterior is not common. It is a posterior dislocation which is very very common. So you
What
must
is
know
the
this.
gene that one you mentioned was pubic diastasis? Go back.
There's something here also.
The pubic diastasis.
He's talking about that one only.
No.
Bladder injury must be there. That's what I.
Maybe.
Okay, next.
Next, who's that?
Diagnosis.
looking like this one, sir. Forearm ulnar shaft fracture, sir. Ulnar shaft fracture, sir. Distal 1/3 ulnar shaft fracture.
What is it? Diagnosis?
Proximal, sir. Proximal, sir. Proximal 1/3 ulnar shaft fracture.
There are two.
Montage fractures.
Yes.
What is that line called as that comes from here?
Radiohumeral line.
Radiocapitular line.
So you must know this line, you know, it's very, very important, otherwise you will miss this injury.
Oh.
This passes to the capitulum, you know, this here. So otherwise you will miss this injury. Okay?
Okay, sir.
How will manage? Repetitive trauma, SJMC.
Reduction and ORIF plus plating, sir.
What will ensure in reduction?
So open reduction, internal fixation always, you know, there is no role of conservative management in this type of injury. So when you lengthen this, it will automatically come.
Okay,
Only
sir.
in chronic cases, if it doesn't come, then we need to, you know, reconstruct the annular ligament. Otherwise, 99% they will come. You know, length is maintained, it will automatically come.
So next.
Okay.
Diagnosis.
It looks like a bimalleolar fracture.
Who said bimalleolar? I wanted him to show the third malleolar.
Trimalleolar, sir. Twisting injury to the ankle. External rotation. Supination.
See the median lines like a pull-out, transverse fracture. See that syndesmos is also gone. Oblique fracture.
Oblique fracture. The donation, exploration. What do you do?
Next.
The plating for lateral malleolus and CC screw for medial malleolus.
What is this next?
No, that is the foot and ankle ಯಾರು ಬಂದಿದ್ದು ಅತ್ನಿನ ಅವರೇ अच्छा that Athini is from
In this thing.
Speak up.
Distal, both one fracture of the legs, sir.
Fresh or old?
Old, sir, malunited.
United or it is so much of callus there? You see the fracture line still here.
See, the fracture line is still there. Lot of callus is there.
Hypertrophic non-union, sir.
Along with that, anything has happened to the ankle?
That I know.
What you'll do? What you'll do?
Elbow dislocations, posterior elbows.
Fresh or old?
Old, sir.
You were not able to make out with the fresh or old in a dislocation. If it is old dislocation, what you will do? Neglected dislocation, elbow, what you will do?
Soft tissue contracted, no? What will go? Biceps.
Triceps lengthening, then reduction. It will not come otherwise. Okay. Then you have to assess the function, which side it is, how much disabling to the patient. Patient should not become more disabled by your surgery. Some people are able to manage even with this, you have to see, and depending on that you have to treat.
So whenever we are doing these old cases, if they are more than 3 weeks old, usually they require open reduction. Okay, and then all these things will come, contraction and all those things. But always look for the articular cartilage when you have opened it up. Usually this is from 3 weeks to 3 months, we may be able to reduce it, by open reduction. But after that, it is very, very difficult, and cartilage, if you see the cartilage, it is worn out. And then there are other possibilities, arthroplasties and all those things.
Next one. This is the last X-ray. Anybody? What is the implant used?
Dynamic condylar screw.
So what has happened?
95-degree DCS has been used, sir.
DCS?
Yes, sir.
Dynamic condylar screw. It is not the plate.
Yes, sir.
What has happened?
Sir, fracture has collapsed in varus, and there is a,
This is surgery, primary surgery, or it is a secondary surgery?
I can't tell on this.
Yeah. Probably this was normally it is done for us when there is lot of comminution here. This is done for subtrochanteric type of fractures earlier.
Yes, sir.
I think walking around.
Yeah. We'll go for the next session, no? Sir, what not to write?
Good evening, everyone. I would like to invite Dr. Edward Nazareth for the session, What Not to Write in Theory Papers.
Good afternoon. At the outset, I thank Professor Mallikarjuna sir and the Department of Orthopaedics for giving me an opportunity to speak here. Normally, I used to write how to answer the PG papers. That was my talk. But Mallikarjuna sir told me to give a talk what should not be written in the theory papers. This was one of the answers which I received recently. Can you read that?
Thomas splint was made officially by Sir Thomas for his wife. As he has written, her wife was going through severe night cry due to, I don't know due to what it is. And this is the answer which people write in the exams. This was a UG answer, not a PG answer, which I received in the last session, and I only saw this. So it was written that congenital talipes equinovarus is a common congenital anomaly occurring in children, especially newborns. It is so common that common man cannot recognize it. It is recognized only by skillful orthopedic surgeons, like the examiner correcting this paper. Such examiners are required for the society so that congenital talipes equinovarus will be eradicated from the world. Hats off to the parents who gave birth to the examiner, who stands with the, and India stands with those parents all the time. He must be very much influenced by the one who always stands with India. So these type of answers which we get, and many times people think that examiners do not read. That is the basic problem, is that you think whatever you write, it is okay, you get the marks. But many a times there are some crazy examiners like me who read what you have written there. So now theory is very important because valuation is blinded. When we were taking exams, or Mallikarjuna sir was taking exams, our theory papers were hardly read by the examiners. So once you pass in your clinical examination, at the end of the exam, they all used to sit over a cup of tea, see the papers like this, and whatever the percentage of marks which you got in the clinical examination were the same marks which you get in theory also. I remember in my D-Ortho exam, I got 65% in clinical, 65% in theory. When it comes to MS exams, then they used to give grade. So they were never used to read. But nowadays, we read the papers. In RGHS, you know that 40% minimum is required in each paper, and 50% aggregate is required. Even if you get a 39% in a one paper, candidate fails. There are examples. We know the candidate who has got 39% in one paper, though he got aggregate more than 50%, he had to write the exam again. And as I said, there are some strict examiners, some crazy examiners who read the answer papers. Because each answer paper, we are given 5 minutes. So we have to read there. You cannot just brush up and go to the next answer paper. That is why we are forced to read and examiners read. So keep it in mind that you cannot write whatever comes to your mind. This is a very important thing to be remembered. So this is a short notes written for compartment syndrome. Basically what happens, you all become rag pickers. Whatever comes to your mind, you put there in like a rag picker putting in a gunny bag, and you expect us to sort it out, segregate the waste, and give the marks. Style of presentation is very important. So there are so many flowers in the garden, but if you pick it up and put it in a flower vase, it looks beautiful. So you may be knowing so much thing, but the presentation is one of the important thing. Don't present the answers as it comes to your mind. So this is a very good presentation. Question was damage control orthopedics. Moment we look at the paper, the way it is presented, we get impressed. We may not have to read the entire this one. Out of 10, a stingy examiner will give a 6.5, a liberal examiner might give 7.5. So this is how the way the presentation is very important. Don't start answer without knowing how to start. When you get a question paper, when you see that one answer has to be answered, first thing you have to think how I should start the answer, because starting the answer is one of the important things. This is a very important thing in theory paper. So a question was asked was a vertebroplasty. I don't know how many of you can read there because that scanning was not good. This is by MS candidate in the recent examination. He has written, it is a replacement of vertebral body by an artificial prosthesis which looks like a native vertebra can be done alongside the disc replacement, mesh placement, cage placement. How can you expect for an examiner to give marks? A MS candidate doesn't know what vertebroplasty. So this is the way people write. See, well begun is always half done. A short essay on alkaline phosphatase. So how nicely he has begun. He has written what is alkaline phosphatase and what is the normal value. Maybe he's written other things also. This is the way you have to start. Definition. Then what is the relevant only you have to write. See, this is one question was asked. Define idiopathic scoliosis. What are the radiological findings in congenital scoliosis? He has just defined what is idiopathic scoliosis. That is what was asked. Then they were asked about the radiological findings. So he has written what is radiological findings. This is because the 10 marks question, he doesn't have more time because he has asked, write another 9 questions are there. So he's writing what is relevant to the point. Same compartment syndrome. See how nicely he has written. He has written what is compartment syndrome and what are the clinical features. Sometimes you start very blunt. Joint replacement, total knee replacement surgery was the short notes or the main question. So you at least to define what is total knee joint replacement. Don't directly jump and write indications. They are not written, asked what are the indications for joint replacement. So you are supposed to ask, this question should not be asked because there are textbooks on total knee joint replacement. So I don't think this is a proper way of asking the question, but somebody has asked, so you should know how to answer these type of questions also. Many times what happened, you beat around the bush. This mainly happens when we come to know, see an answer and candidate has, student has written, is beating around the bush. We are almost sure that he doesn't know the answer. See, vitamin D resistant ricket was asked the question. Nobody asked what are the layers in the growth plate. Nobody asked. Nobody asked what are the types of rickets. It is not asked. Your answer should be what is vitamin D resistant rickets, what are the types of that, what are the clinical features, what are the radiological features, and how do you manage. That is exactly what is required. Nobody has asked like that. Now this was again one of the questions recently asked, what is the blood supply to the scaphoid? You'll have to search there, find out where he has written about this one. He has written something there, but it is not the proper way of presentation. This is a multi-drug resistant tuberculosis, again in the recent exam. And these all screenshots were taken by me before Mallikarjuna sir asked me to prepare this talk. I have a very bad habit of taking the screenshot and saving because they come to use sometimes like this. So multi-drug resistant, nobody has asked what about the tuberculosis, how it spreads, what and this. And his entire answer, multi-drug resistant TB, that definition is not there, the management is not there, nothing is there in that. Multiple myeloma was the short notes. Nobody asked the classification of bone tumors. This is again 10 marks question. So you should not beat around the bush. You should just define what is multiple myeloma, what are the clinical features, what are the radiological signs, and how do you manage orthopedic manifestations, and how do you manage. That is what is required. Again same, osteoid osteoma, he has written about classification of bone tumors. Don't expose your ignorance. Always try to cover it away. I am sure that all of us are not genius to know everything that is asked, but be very careful while you are answering this one. Computer navigation was the question that was asked, and he has written what is the use of computers in orthopedics. He has written from computers are used in everywhere, during taking USG, during surgery, during something, all that, whatever has come to his mind is asked. Computers, use of computers in orthopedics is not the question. Question asked was on computer navigation. Don't write about the cow when you are asked to write about the milk. So when we ask to write about the milk, you write about the milk, don't write about the cow. Which cow gives how much of milk and how the milk has to be stored and all that. It's not required. See, this is how computer navigation, same thing. See how nicely he has written. He has answer is separated into several segments and he has nicely written. And This type of answering, this is very important. Now fractures around the elbow is the question. See, all written about the elbow and all the things, and finally somewhere here, fractures around the elbow is written. This again was the last question was asked, fracture neck of the femur in children, 10 marks question. Nobody has asked about the blood supply to the proximal femur. I have corrected a good number of papers. Many people have written about the blood supply to the proximal femur. It is not required. You should write what are how common they are, what is the mode of injury, what are the clinical features, classification, how it is managed, what is the complication. That is what you are required to answer. Avoid paragraphs, use points. So this is asked about the management of Colles fracture. See, this is how nicely a boy has answered how Colles fracture has to be managed. Short notes on osteoid osteoma. Radiological findings, how nicely it is written. What are the X-ray findings? What are the MRI findings? Limb salvage was the question. See how nicely it is written. Sometimes what happens is the handwriting is very bad. You may not able to do a lot of things when the handwriting is bad. You cannot correct it. Can you identify which language it is? This is a PG paper, answered. When I told the examiner, showed him sitting next to me and asked him what language it is written, he told me, you should appreciate that this boy has come to PG in orthopedics, having with this bad handwriting. You should appreciate that he could reach up to that level. So short notes on uric acid. It looks like his pen itself has hyperuricemia. His handwriting is bad, but he has written something which probably we can read. This is another one. I was trying to find out one English letter in the whole paper. But whenever a handwriting is bad, there are several ways of answer the questions. One is answer by points. Answer by points. Give some space between the two lines. If possible, underline, but don't use red ink and green ink while underlining. It is not acceptable. Take a black ink and underline. See how his handwriting is not good, stem cell in orthopedics, but he has written it and presented it in a proper way. At least I can read how the technique it is done, what are the stem cells, what it is used. Underline when others can't read. See, this is a bad handwriting, but is okay. Okay presentation. Don't hesitate to draw. This is a very important thing. Whenever you know questions are asked, put your answers in drawings. This is very important. So mallet finger. When we see this, what is written, I don't have to require to read rest of the thing. I know that this boy knows what is mallet finger. He knows what it is. I would just like to see what is the management he has written. So congenital scoliosis, the question, radiological findings. He has nicely written what are the common congenital scoliosis, what radiological findings can be there. There's a drawing there. Histopathology of Ewing sarcoma. See how nicely it is drawn. He knows the things. If such an answer is there, I'll guarantee you out of 10, you get at least 7.5 marks you will get. Management of T12 bust fracture. Instead of writing one complete page, he has just written a diagram and showed how the pedicle screws are now used to manage bust fractures. Don't draw for the sake of drawing. Is the apex of scoliosis is not required. I was thinking that he has drawn a snake initially. Then I realized that he has drawn vertebrae. So draw this way. This is the nice way you have to draw. Instead of writing page, you can just draw. The question was, how do you manage fracture neck of the femur with the ipsilateral fracture of the shaft of the femur? See, this is the way where it is managed. You put a DHS there, you put a interlocking nail here, Maybe it is done when the facilities are not available, but that is not the standard method of management. You have now reconstruction nails, they are the one which is used. Even if it is not done in your institute, you should be knowing that how fracture neck of, if such a diagram is there, probably will not have to read much. But don't draw something which is not known. See, he has written something using a plate there. Trochanteric plate is used for a fracture neck of femur. Flow charts is another important thing. Many people draw, but draw it properly. But don't have a wrong flow. There's again going to be a problem. If you know correctly, then only you have to write properly. So question was ipsilateral fracture neck of, he could have drawn a diagram. See what all he has written. So important things what you have to remember in your PG theory papers. Now most of the universities as well as in DNB, 10 questions, 10 marks. Then you have to, initially itself you should know how much time you have to restrict for each answer. It is not more than 15 to 17 minutes. You should be able to answer a question within 15 to 17 minutes so that you get 150 to 170 minutes. Then you require another 5 to 10 minutes may be required here and there. So keep up the time. Remember that that's how it has to be, this one. Do not waste time on few questions. Don't write too much to few. See, what has happened, he had written somewhere, he wasted the time. Finally, he didn't get time, so he just scribbling whatever comes to his mind. So this is how you waste your time. You write unnecessary things which are not asked, you write. See, again, same thing, you waste your time. Actually, asked was, I think, how do you manage the fracture? Something was there. That is exactly what was the answer was required, not that rest 1.5 page was wasted. So radiological finding in rickets was asked, and he has written everything about rickets. Don't do this, don't be stingy. This is again is not good. There are two important tips you should remember. One, you have to prepare. Preparation is the key. If you do not know, you may not be able to answer. Second thing is the presentation. These are two important things. While preparing for the PG, this one, other than the textbooks, go through the previous year's question papers. At least 50 to 60% of the questions are repeated. When we are asked to set the questions, we don't go and randomly select something and this one. Most of the time we ask the standard questions which are asked in the previous years. So go through that question papers. Now the question paper available online also. You get all the DNB set of question paper. In most of the university, question papers are available. Question bank is available online. So you can go through that, find out which questions are commonly asked. And you have to always practice. This is a very important thing because these days you people don't write and use only the SMS language. So in the exams it becomes very difficult to sit at one time and write for 3 hours. So you have to practice writing before. I normally what I do is, even my PGs do not like, I conduct them theory tests. 1 hour in a month and 4 questions I give, ask them to write for 3 hours. Not to know their knowledge, also give them a stimulus to read, but another thing is to time management as well as to practice of writing. This is a very important thing. If tests are not conducted, you yourself take a question paper, sit at a corner and answer 3 questions in 1 hour. And you get the speed, you know how it has to be written, then you yourself read and see how much marks you can give to that answer. This is the way you have to prepare. Don't take theory lightly. There are 2 ways. One, it is required to have the knowledge. Second thing is also required to get the marks. So don't use tablets to study. It is always better to use the textbooks because when you read the textbook, that goes to the cortex. It does, otherwise you don't go. Tablets are required or computer or mobile phones are required only for the reference sake. Textbooks are required not only now, when you start your practice tomorrow, they are required. You ask any successful surgeons, most of them, even if they have done some 100 surgeries, on the previous day of surgery, sometimes they open the Campbell and see how it has to be done. If complications come, how it has to be managed. So these books are required. And another thing is, if possible, make notes while reading, because writing once is said to be reading thrice. And if your mind becomes alert also, you get a lot of scribbling pads now. Take this, write some answers, write some points at least. If possible, file them and keep. So you should know what is the exact style of writing, what can be done for better marks, what does the teacher really expect, how to create an impression on the examiner. These questions you should answer. Read the entire question paper first. In the last exam, there was one question on fracture management of supracondylar fracture of femur in adults. And of the questions which I corrected, I got at least 20% of the people have written about management of fracture of humerus. You can't give marks. We cannot give marks. I have to give 0, even though he has written properly. But question was asked different and answer is different. We cannot give marks. Read each question before answering. So this is the question. Discuss the radiological findings scoliosis. Write briefly on the recent advances in the management of idiopathic scoliosis. Nothing else is asked. So neat, legible, highlights and points. This has to be remembered. Plan your answer. Don't answer and plan. Failing to plan, you always know that is it is plan to fail. So what is asked? What all I know? How shall I begin? What shall I fill in? And how shall I conclude? These has to be the questions you should remember. So in conclusion, study well, found out which frequently asked questions in each topic. Don't read like reading a storybook. When you read a chapter, in a particular chapter, you find out which is commonly questions that are asked in this particular chapter. For example, if you get you are reading about the bone tumors, what are the commonest benign bone tumors we ask in the exams? We asked about osteochondroma, we asked about enchondroma, chondroblastoma. These are the few tumors which are commonly asked. We don't ask about fibrous cortical defect normally. So this you should know. Not that you should not read others, but make notes, file them, may add points next time. You take a file for bone tumors, file for fracture upper limb, fracture lower limb, infections. So make the file. Whenever you read, make some notes, file there, keep in that. Next time you get a new thing, you add that. If seminar is done on that, add that. So before the exams, it becomes very easy, very handy to refer that. And this becomes a very easy and you can get good marks. That is the way you have to prepare. Learn the art of presentation, practice answering questions and time management. This is a very important thing to remember. Thank you for your patient hearing and thank you, sir, for giving me the opportunity to speak.
Thank you, sir, for all the valuable inputs. Heading to the next session is ward rounds by Dr. Ramesh Krishna. Sir, please welcome.
Good afternoon, everyone. First of all, I would like to thank Dr. Mallikarjuna and team of St. John's for inviting me here to be part of this postgraduate teaching program. I've been coming here since last 4 or 5 years. So I also bring greetings from Bangalore Medical College and Victoria Hospital, and I would like to say hello to all my other colleagues also here. So ward rounds is the topic given to me. So I will be, as I think some of you got confused that I will be taking you for ward rounds, but I will not be able to do that because I won't be able to cover all that I need to tell you during ward rounds that you need to know during ward rounds. So in about half an hour, so 30 minutes, I should try to finish and let you know what you need to know. So ward rounds examination especially for the DNB candidates, and in some of the states like in Tamil Nadu and other states, there is a separate 50 marks kept for ward rounds. So you need to be attentive and see during your postings as to what are the things available in the wards and what are the various questions that can be asked you. So I have decided for you to understand better, for you to understand what is in the wards. So as you see, as you enter the wards, there are 3 things. One are the patients, or the cases. Second are the materials that are put on the patients. So, and then the materials that are seen in the wards. So these are three important things that you see in the wards. So questions, so I've divided my talk also in the similar fashion, and the questions also may be asked based on these. So these are some of the things that they may be asked, the questions that may be asked regarding the patients and the cases. So I'm not going to go into details of all this because I'm sure last 2 days you have been having lots of case presentations and much of discussions has been going on about cases. So I will not go so much in detail. I'll just touch upon a few important cases, what you need to know. And the materials on the patients, like the dressings, the POP, fiberglass cast, traction splints, etc. And the materials that are present in the wards, for example, the case sheets, the x-rays, the catheter, crutches. So I'll just touch about these topics today. Coming to the patients or the cases and what they can ask you. Of course, they can ask you about the various types of gates. Again, I'm not going to go, as I said, I'm not going to go to the details of all these cases. And common cases that you see in the wards are the CTV cases. We need to know about all the clinical features, types, and the scoring systems, and management, the various methods of management. And coming to the fractures that are commonly seen, that are kept in the wards, are the trochanteric fractures, very common fracture, the various deformities, various tests, and the management. And dislocations, again, the case of shoulder dislocation may be in the ward, so you need to know the details about that, about the various infections, acute osteomyelitis, the various clinical features, what is pseudoparalysis, and diagnosis and management, especially the multiple drill hole management is important in acute osteomyelitis. In chronic osteomyelitis, these are the few important clinical features that you may have to show during on a patient, like bony tenderness, thickening irregularities, and radiological findings, and various methods of management, which I'm sure would have been discussed in the last 2 days. And coming to the tumors, the important tumors, the osteochondroma, osteosarcoma, the features of malignancy, and the various classifications, and specific radiological features, and of course management of various tumors. And degenerative conditions, this again may be kept, may be seen, osteoarthritis, a knee joint waiting for TKR, about the deformities and the radiological findings, and they may also ask you about these surgical procedures of TKR. And coming to the spine, again, paraplegia, the various deformities, if at all is there, the deformities, about the range of movements that you should know. So if at all there's restriction of movements, for you to say there is restriction of movements, you should first know the normal range of movements. And of course measurements, all this I'm sure you know. Various important special tests. Yeah, this is another thing. So if there is a case of polytrauma, they may ask you about these various methods of scoring, the GCS, the injury severity score, and the MES. These three things you have to know. I'm not going to answer all these questions, and it is up to you to read up. Of course, head injury, the GCS, this is a chart showing the various, how the GCS is assessed. And again, this is the injury severity score. It depends on the various organs that are injured. And this is the MES score. This is as per the skeletal and soft tissue group, and you have the shock group. And management of any polytrauma case, they may ask you about the primary survey. What are the things you would like to see, examine, and what are things you would like to do? Primary, secondary survey, and tertiary survey. And this is about the various types of wounds. A patient may have a wound seen, so you may have to know the definitions of these wounds, whether it's an abrasion, laceration, avulsion, an incision, puncture, and an amputation. You should know the definition of all these. And compound fractures, if it is there in the wards, the various classifications, the
Vivek, Ankit Verma, and Arnab Kumar. Anyone?
Not there, we are not sending.
ಯಾರು ಮೈಕ್ ಮಡಗಿದ್ದು ಯಾರು ಆನ್ ಮಾಡಿದ್ದು ನಾನು ಆಫ್ ಮಾಡಿದೆ ಗುರು ಆಫ್ ಮಾಡೇನೆ ನಾನು ತೆಳಗೋಗಿದ್ದು
Check.
ಯಾರು ಹೇಳ್ತಾ ಇದೀಯಾ ಮನೇಲಿ ಹೇಳ್ ಬಂದಿದ್ಯಾ ಇರ್ಲಿ ಬಿಡು ಕನ್ಸಲ್ಟ್ ಆದ್ರೂ ಇರ್ಲಿ ನಾರ್ಮಲ್ ಆಗಿ ಆಗಿರ್ತದೆ ಇದು ಯಾವತ್ತೂ ಹೋಗಲ್ಲ ಅದು ಹೋಯ್ತದೆ ನನ್ನ ಮಾತು ಕೇಳು ಒಂಬಕ್ಕ ಬೊಂಬಕ್ಕ ಜಿಮ್ ಮಾಡ್ಬಿಡ್ತದೆ ಆಮೇಲೆ ಇದು ಹೋದ್ರೆ ಅದಿದ್ದಾಗ ಹೋಯ್ತು ಸರ್ ಅಷ್ಟೇ ಹೇಳಿದ್ರೆ ಅರ್ಥನೇ ಮಾಡಲ್ಲಪ್ಪ ಇವರು ಇಲ್ಲಿಗೆ ಎಲ್ಲಿಂದ ಕೊಟ್ಟಿದ್ದೀನಿ ಬಂದಿಲ್ವಲ್ಲ ಪ್ಲಗ್ಗು ಎಲ್ಲಿವಲ್ಲ ನಾನು ಕೊಡೋ ಯಾರಾದ್ರು ಇವಾಗ ನಾನು ಹಿಂಗೆ ಆಡು ಅಂಗ್ಳಕ ಬಂಗ್ಳಕ ಚಿನ್ನ ಮಾಡ್ಬಿಟ್ಟಿದ್ದೀನಿ ಎಲ್ಲ ಫುಲ್ಲ ಊರಲ್ಲಿ ವಿಂಡೋಸ್ 4 ವಿಂಡೋ ಹೋಗ್ಬಿಟ್ಟದ ಎಲ್ಲ ತೆಗೆದುಬಿಡಲ್ಲ ಅದನ್ನ ಯಾರು ನೋಡ ಇದಾಗೈತೆ ಒಂದು ಪವರ್ ಬಂದಿಲ್ಲ ನೋಡು ಯಾವ ಸೆಂಟ್ರದಾ ಕೆಳಗಡೆ ಲಾಸ್ಟ್ ಸೆಂಟ್ರದ ಎರಡನೇದು ಕೆಳಗಡೆಯಿಂದ ಎರಡನೇದು ಲ್ಯಾನ್ ಏನು ತೆಗೆದಿರ್ತಾರೆ ನೋಡು ಲ್ಯಾನ್ ನೋಡೋ ಮರ ಇದೆಯಾ ಲ್ಯಾನ್ ಬಂದಿಲ್ಲ ಎರಡನೇದು ಲ್ಯಾನ್ ಬಂದಿಲ್ಲ ಎರಡನೇದು ಎರಡನೇದು ಬಂದಿಲ್ಲ ನೋಡು ಈ ಕಡೆ ಹಾಕಿರ್ ಲ್ಯಾನು ಇಲ್ಲಿ ಲ್ಯಾನ್ ಹಾಕು ಲಂಪಿಲಿ ಇಲ್ಲಿ ಸಿಗ್ನಲ್ ಹೋಯ್ತಲ್ಲ ಎರಡನೇದು ಹಾಂ ಅದೇ ಇನ್ಯಾವುದು ಇಲ್ಲ ಬಂದಿಲ್ಲ ಸಿಗ್ನಲ್ ತಗೊಂಡಿಲ್ಲ ತೆಗೆದ್ಬಿಡು ಒಲಿ ಅದ ತೆಗೆದ್ಬಿಟ್ಟು ಲಂಪಿಂಗ್ ಕೊಟ್ಬಿಡು ಲಂಪಿಂಗ್ ಕೊಡ್ಬಿಡು ಆ ಕಡೆ ಆ ಕಡೆ ಚೇಂಜ್ ಆಗುತ್ತೆ ಮಾಡುವ ಮತ್ತೆ ಫೋನ್ ಮಾಡಿದ್ರು ಬಂತು 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 ಒಂದು 6:06 ಆಗ್ಬೋದು 7 ಗಂಟೆ ಆಗ್ಬೋದು ಹೇಳೋಕ್ಕಾಗಲ್ಲ ಬಿಟ್ರೆ ಸುಮ್ಮನೆ ವೆಯ್ಟ್ ಮಾಡುವಾಗಾಯ್ತು ಬಂದು ಒಂದು 5:15 6 ಗಂಟೆ ಬಿಡಿ 6 ಗಂಟೆ ಅಲ್ಲಿ ಬಿಡಿ ಎಲ್ಲ ಒಂದೇ ಗಾಡಿಗೆ ಐತಕ್ಕಂತ ಬನ್ನಿ ಏನು ಮಾಡೋಕ್ಕಾಗಲ್ಲ ಹುಡುಗರು ಯಾರು ಬರೋಕ್ಕಾಗಲ್ಲ 2 ಗಾಡಿ ಇದ್ರೆ 2 ಗಾಡಿ ಇಟ್ಕೊಂಡು ಹಾಂ ತಗೊಬನ್ನಿ ನಿಮ್ಮಂತ ತಗೊಂಡೋಗಿ ನಾಲ್ಕು ಪಿಂಡನೇ ಬರೋದು ಈಗ ಮತ್ತೆ ಕೆಚ್ಚ ಏನು ತಗೊಂಡಿದ್ದೀವಿ
already put, my panel is working there. ಅದನ್ನೇ ಅವ್ರು ಹೇಳಿದ್ರು ಆನ್ ಮಾಡಿದ್ದೀವಿ.
Huh? Okay, so let's continue. This is about various cases that that may be there in the wards. Again, a case of nerve injury, all those have been discussed. And about the skin grafting, cases with skin grafting, the various indications and other things. And various types of skin flaps, what it does, and the amputations, etc. A case of fat embolism, where the common causes are the fracture shaft, femur, and pelvic fractures. Bed sore patients may be there in the wards. About another case of electrolyte imbalance, they may ask you. And coming to the materials on the patients, so I'll start off with the dressings. So the various layers of dressing, we have the contact layer, we have the absorptive layer and the compressive layer, the gauze, cotton, and the roller bandage. And what it does, they usually, the indications are for the wound dressings, as you all know about that. And the cotton roll, the most commonly used is this Gamzee roll, which has 2 layers of cotton with 2 layers of gauze. And the adhesive plaster, we have various types, the paper plaster, Dynaplast, and the Primapore. And the paraffin gauze, what it does is it keeps the wound moist and prevents adhesion of the dressing onto the wound and acts as an antiseptic. And strapping, so buddy strapping, as you all know, used for phalangeal fractures. Again, various other types of strapping, the chest strapping, arm chest strapping, and the Jones strapping. And compression bandages, the various types of bandages used as splints. And what it does, various types of slings, the triangular slings and other types of slings that are used. And various modifications, the figure of 8 bandage and the ball bandaging, etc. Coming to the plasters, various types of plaster, the POP and the fiberglass plaster and the stockinets, cotton roll and the roller bandage. Again, questions may be asked on these. The composition of POP, what is the composition and various sizes that are available, and again what it does, the various types, the slab cast and the FCBs and the uses where it is used, the cast. The fiberglass cast, the composition of the fiberglass cast, and again sizes, and sorry, it should be the uses there, and again same indications. And the important thing here is the difference between POP and the fiberglass cast. So the POP is easy to mold and sets early, whereas sets later around 4 to 5 minutes, whereas the fiberglass cast, it takes about 1 to 2 minutes, much lighter, and it is 2 to 3 times stronger, and it is more durable. And some of the upper limb casts, again some upper limb casts, various types, upper limb cast, Coley's cast, Cafford cast, etc. Lower limb casts, the Aboni cast, Bijlani casts. The serial casting for CTV, this is also another important thing they may ask you. And this is the walking heel, so it is used along with a PTB cast. And the walking iron is used in fractures of the foot. The pin plaster technique, this is a combination of pin and the plaster. It prevents the rotations and helps in preventing joint stiffness and helps in early mobilization. The FCB or the fiberglass caster, the Sarmiento technique, and the spica, the various types of spica, so single, 1.5, or the human in the human position, and the indications for splitting of the cast. So it may be any of the following that is mentioned there. And cast wedging. Where do you do cast wedging? When there is an angulation up to 10 to 15 degrees, and it should be done immediately within 2 or 3 days. And this is a cast window. I'm sure you would have done this. And there's bivalving of the cast, so especially for observation of the fracture site in compound fractures and for removal of the fiberglass cast. Coming to the important things that you should know here is there are the tractions. So what is traction? It's a force applied manually or mechanically, and it is used to achieve relative immobilization or to reduce fractures or dislocations. So various uses, it reduces fractures or dislocations, and it helps in relieving pain, and it keeps the joint surfaces apart. Types of tractions, you have the manual traction, the skin traction, skeletal traction, the balanced and the fixed tractions. Coming to skin traction, so indications are the long bone fractures, the IVDP, weight usually it's about 10% of the patient's body weight, and complications are the skin allergy and the pressure sores. And the brands of the gallows traction, not commonly seen nowadays. It's again a question that may be asked for you in the theory. It's a bilateral above knee skin traction, and the buttocks, as you see in the picture, should be off the bed, and the weight of the child should be less than 18 kgs. Maximum weight is around 10 kgs. The indication is for any child of less than 2 years with a fracture shaft of the femur. Proximal femoral traction, you should know the various sites of applying the traction in different types of tractions. So here it is 2.5 centimeters below the greater trochanter. The indications are central fracture dislocation and acetabular fractures. Distal femoral traction, the site is the junction of the lines along the upper border of the patella, as you can see in the picture there, and anterior border of the head of the fibula, indicated in acetabular fractures and fracture shaft of the femur. Proximal tibial traction, again the site is 2 centimeters below and behind the tibial tubercle, and indicated in fracture neck femur or the IT fractures, the shaft of the femur and supracondylar fracture femur. Distal tibial traction, it is 5 centimeters above the ankle joint, as you can see again in the picture there. It is midway between the anterior and the posterior border of the tibia. Indications, knee fractures, dislocations, and proximal tibial fractures. Calcaneal traction, the site is 3 centimeters below and behind the medial malleus, and 2 centimeters below and behind the lateral malleus on the lateral side, indicated distal tibial fractures, ankle fractures, and dislocations. These are some of the upper limb tractions, which the names at least you should know. The Dunlop traction, the olecranon traction is also applied. Metacarpal traction, cervical traction, commonly indicated in fracture dislocation of the cervical spine, cervical spondylitis with radiculopathy, and these are the Crutchfield tongs. So nowadays we don't see that. It was commonly used earlier. This is the picture showing a cervical traction being applied, and the pelvic traction commonly used for IVDP. Some various modifications, the boot and the bar, the Chanley's traction unit, the Russell traction, and Agneson traction, the 1990 traction, various other modifications depending on the site of the fracture. Coming to the splints. So a splint is defined as a device which is used to immobilize the part of a body. Again, splints are of various types, the wooden type, this metallic splints, plaster splints, the pneumatic or the inflatable splints, and various others which can also be used as splints like the newspapers or the cardboards, etc. This is the Kramer wire splint. It is made of metallic wires. It is moldable and used for temporary immobilization of fractures during transportation. Thomas splint, you are very familiar with this, and used for tuberculosis of the knee and etc. It has 3 parts, the circular ring, the parallel bars, and the notched end. So where this should be should rest on the ischial tuberosity and the ASIS, the circular ring. The parallel bars has to bend to accommodate the greater tuberosity, greater trochanter, and the notched end is to apply the traction. So again, this is important. The measurements that are seen there, you can have a look at it, look at the picture. Coming to the precautions, the position of the limb should be in flexion and abduction, and adequate padding should be given. Uses, again, transportation of lower limb fractures, hip dislocations, fracture shaft femur in children. Thomas splint, again, modifications. You can see that the padding, how it is applied, and Thomas splint with Pearson component, and there's another bent Thomas splint, again, various modifications. The BB splint, again, I'm sure you're very familiar. The common question they'll ask you in the wards is, the 3 pulleys, what is it used for? The first pulley is used for calcaneal fractures and distal tibial, calcaneal and distal tibial traction, whereas the second one will be for the distal femur and proximal tibial traction, and the third will be to prevent foot drop. And splints are used to mobilize spine, immobilize the spine as well. You can see the hard cervical collar, the Philadelphia collar, and the long spine board. So these are coming to external fixators. The various parts, I'm sure you know about all this. I'm not going to go into the details. Indicated and compound fractures, and you should know the meaning of dynamization. LRS is another improvisation where the shank screws are tapering here, and it gives better purchase, and there is no screw protrusion, unlike in the external fixator. Ilizarro external fixator, again, a common question if it is there in the wards. So various parts of the external, the Ilizarro, the rings, wires, connecting rods, etc., tension device, and indicated in commonly for the infective non-union, deformity correction, and limb lengthening. External fixators, various types, the pin fixator, the Ilizarro fixator, so both can be used together as a hybrid fixator. This is a pelvic external fixator used for pelvic fractures and pubic symphysis diastasis. Pin track infection is another thing they may ask you how to manage. And of course, there's a classification. It's called Checkett's Otterburn classification. Please read about it. The VAC or the VAC, the vacuum assisted closure. So this is another thing that is commonly used nowadays, which is a negative pressure. So indications in open fractures, and promotes wound healing and prevents infection and allows the wound to heal faster. Coming to the materials in the wards, so about the case sheet. So if it is the case sheet, the various things they can ask you about case sheets, the medical legal case documentation, the daily notes, what you are going to write. Of course, you would have done all this, and how to consent, various methods of consenting a patient, pre-op instructions, OT notes, and post-op, the usual things that you have been doing all these years. X-rays, again, the various common X-rays that may be with the patients. I'm not going to go into the details of all these again because there's a separate X-ray class which was taken. Common radiological features in various conditions like osteomyelitis, osteosarcoma, then osteoarthritis, and indications for THR. If there's a post-operative case, THR or TKR, there are various indications, how do you do a pre-op planning, and how do you select implants, approaches, etc., and difference between when you use a cemented or uncemented, and rehabilitation, etc. CT scan, advantages of CT scan over a normal X-ray, better appreciation of the fracture configuration. It gives a 3D reconstruction for better orientation and useful wherever MRI is contraindicated, and is usually used for around intra-articular fractures. MRI, the advantages are the ligaments, tendons, soft tissues. They are soft, are well appreciated, and commonly used nowadays for the knee injuries. MRI is also used, as you know, for various spine conditions. And this Foley's catheter, where it is used, and how the procedure, how you put a Foley's catheter, and what is the procedure, how you do it, and indications for bladder wash. And dressing trolley, so contents of the dressing, so this is very important. You must have seen a dressing trolley next to you with the patients when you're doing a dressing. what are the contents of a dressing trolley. It should have a surgical drum, a cut-open tray, a side X tray, a kidney tray, and a bottle with little forceps and other dressing materials depending on the wound. And this is about various things that are put in the cut-open tray. And this is the side X tray, what it contains, the glutaraldehyde solution. And the pulse culture tubes should also be there. And the tropical agents. So tropical agents that are kept for dressings. These are the antiseptic agents, the antibiotic agents, the de-sloughing agents, granulating agents, and the cleansing agents. I'm sure you would not have thought about so many things that are kept on a table. And these are the topical agents that are kept. So among them, the important ones I mentioned here. The antiseptic agents are the spirit, the Savlon, the Dettol, and the tincture benzoin. These are the antiseptic agents. The antibiotic agents are the povidone iodine, silver sulfadiazine, and the rest of them. The desuffling agents are the Usol and others which are not so commonly used. The granulating agents are the oxoferrin and the placentrins, again commonly used. The cleansing agents are the hydrogen peroxide. So this is how the various topical agents are classified. They may ask you about the details of all this and how it is used. If you know at least the names of these solutions and what it is used for, that is more than enough. But in case you need to know more, of course, this is something here about the various composition of the spirit. It's an alcohol for cleaning wounds. It is Savlon, it is chlorhexidine, gluconate, and Dettol, it is chlorhexinol. And tincture benzoin is benzoin in alcohol, and chlorhexidine again chlorhexidine. Coming to the antibiotic agents, the povidone iodine is used as a solution, also as a surgical scrub, and where it is used. Silver sulfadiazine, again silver sulfadiazine. Coming to the de-sloughing agents, these are the agents, and the most important is the Usol. It comprises of boric acid, bleaching powder, and sterile water, and magnesium sulfate. And coming to the topical agent, that is oxoferrin, it's tetrachloroxylin, oxygen anion complex. And placentrex, again it's a combination of nitrogen and fresh human placental extract. And about the cleansing agent, hydrogen peroxide is 20 volume H2O2. So how it acts and where it is used, all these things, I don't mind if you people want to take the PPT from the organizers here. You can have a look at it later on. Coming to post-operative immobilization, these are the axillary crutches which are kept along the sides of the patient, the elbow crutches, and walkers. So where it is used in each of these kind of things, it is used, and you should know about the difference between non-weight bearing and full weight bearing, and when you do that. And these are some of the other things like the air mattress or the water bed that are kept in the wards. It is commonly indicated to prevent bed sores and prolonged immobilization patients, and in bedridden patients, again in spinal cord injuries. Bedside exercises, physiotherapy, there's a separate chapter on physiotherapy. You have to read the various modes of physiotherapy and commonly used types of physiotherapy. You can see a quadriceps board there. You can see CPM and quadriceps exercises. What exercises would you advise a patient? Coming again to summarize, so as I told you, as you enter the wards, you can either see the patients or the materials on the patients and the materials on the ward. So under these headings, if you read up, I think you should be able to do well in your ward rounds. Thank you so much.
Thank you, sir, for the session on ward rounds. I'd like to invite Dr. Prakashappa, sir, to please enlighten us on a presentation on implants. That will be the last session before we conclude for the CME, IOA CME. Sir, please. Thank you, sir. I request Srinivas Reddy sirs to give memento token of appreciation to Dr. Ramesh Reddy. Thank you.
afternoon. I think this is the last topic they told. I'm grateful to Professor Mallikarjuna Swamy and the orthopedic team of Sanjay Gandhi St. John's. And the greetings from Sanjay Gandhi. Both are same almost. Okay. These implants, as you know, in the exams, usually one section will be there in the afternoon. Around the 10 marks will be there. Even in the DNB also. If you answer well, definitely you're going to get the 10 marks. Out of 10, 8 like that only if you answer. And when you come to the implants, nobody will stop there only. They may ask 1 or 2 questions, identify and give 1 or 2 examples, uses. Sometimes they may ask regarding some classifications. If we say about what is that, K-wires, they may ask regarding about tension band principle or tension band like that. If the PFN, you classify some of the fractures of the Gordon's classification or AO classification, like that only they will go. Definitely they may not ask only in the instruments, they may ask and stop there only, but implants, when you come to the implants, where it will use, what are the uses, then they may ask regarding about the subject, definitely. And now I will put some of the implants, all those things you have to identify and tell, each one you can tell 1 or 2 uses, where will this one. As you all know, the implants are the tools to perform the functions such as cutting, dissecting, grasping, holding, retracting or suturing. Whereas the implants, the medical devices used to replace or provide a fixation of the bone or to replace articular surface of the joint. In a simpler words, orthopedic implants are used to either assist or replace damaged or a troubled bone. Most of the surgical instruments and implants are made up of steel, as we all know. And other metals like alloys, including the titanium and vitalium, are also used. These instruments usually made up of, that is a 304 steel, and the implants made up of about 316 L type, that is the steel, that is the type. That is the combination of this one, constituents of that steel, what is containing in the implants and the instruments. So these things you should know, definitely they may ask all these things. When come to the uses, as we all know, there is the uses of different instruments. The first I will go with the instruments. That is the grasping, retracting, clamping, cutting, suctioning, suturing, probing, weaving, any other things also will be there. And grasping like that instruments, that is the tissue pulses, allays, cockers, bone holding, like that only they can ask. The cutting and dissection, blades, scissors, osteotomes and biopsy needles. Then retracting, skin, homens, chanlays and devers, like that only. That's I'll go with a little bit of the simpler ones. Can you tell which is this one and what are its uses? Anyone? If you know the name, you can tell the name. Otherwise, you can tell this one, where it will be used and what are its advantages or what are its uses. What is this one? What is the name? That is the parabox periosteum elevator. So indicators to strip the periosteum. They may ask why it should be stripped, because most of the times the periosteum will be there, while they may slip off the instruments what you are bone holding like that only for a better reduction, all those things we are going to put. And the parts it can have it can have the serrations serration is there for the better holding, this one, and the hand will be there. And what is this one? Anybody? This is the other type of the periosteum also. Most of the times we will use in the smaller bones, that is especially in the forearm, all those things. And it is Hudson's periosteum elevator. This is also the periosteal elevator. Don't confuse those things, because these are the common instruments they will put all those things. What is this one? Past anybody? Sorry? It's a osteotome only. How will you diagnose? Huh? Chisel? This is one side or chisel is one side? It is shown there only. It is beveled at both the ends. Okay, if it is beveled at one end, it is a chisel always. See, that is osteotome. Indications, primary to cut the bone. blunt end will be there. That is the important is. That is uses where you can use to take the bone graft excision of the exostosis, osteotomy like French osteotomy, then sarcorization in a chronic osteomyelitis, like that they can ask all those things when it comes to this one. This is the bevel. It is the one side, it is beveled one side, it is a chisel only. The function is both are same only. All the functions are same only. There is a chisel. What is this one? What is the name? Yeah, it is a steel bone goose. For curating the most of the time sarcorization you can use and curate the cancellous bone when you are taking the bone graft from the iliac crest. Most of the times if you wanted a more of cancellous bone, use these things. Different sizes of the goose will be available. And this is, what is the name? They may ask sometimes the name. If you are very smart to answer it, then they will ask all these things. It is a workman's curate. So bone curate, as you know, all those things. The scraping the walls, cavities after section of the bone tumors like osteomyelitis, all those types is a single-ended and a double-ended. That will be there. These are, what are the names? It's a Homan. So different types, mini and sharp Homan and a blunt Homan, cobra Homan, all those things. They are used in the surgery for the better retraction of the tissues and muscles. Especially the deeper, when you go into the deeper areas, these are the things, and especially in case of replacements, that is very important for the retraction of these things. Okay. What is this one? It's a bone clamp. See this one, leave-in bone clamp. The sharp tip ends, not the, this patella clamp is not the patella clamp, it is a bone clamp only, leave-in bone clamp. And the sharp edges hold the bones while reduction while before putting the plate like that only. Especially the smaller bones. In such cases, you can get in the, if it is a bigger size, definitely to the lower limbs also you can put it. And what is this one? This is a Lohmann's clamp, reduction clamp. Most of the times, when we are doing the PGs, all the tibia fractures will be treated with the plate and screws. This is the one instrument always will be there for a reduction of the tibia fractures, open plating that time, because there was no interlocking nail was not there. So that is the Lohmann bone clamp. What is this one? This is also bone holding forceps, Kern bone holding forceps. That is a Kern bone holding forceps. So it has got a jaws, very strongly you can hold the bone. So it has got the bone. And these things, see this is the Weber bone holding forceps and a Spener bone holding forceps, so commonly used nowadays in all the OT setups for a long bone, these things. And this is, where will you use? In the most of the times you will use in the acetabulum for the temporary reduction of this jung block clamp. Usually we will use in the acetabulum for the fracture reduction, temporary reductions of the forceps. And these are the ranges, different type. There is the big one and the smaller one, and the names are there. That is the steel longe boner and Jufel, the bone, rangers. And name, see we will know all those things. Better try to remember all the Liston bone cutting forceps. Okay, that is the bone cutting. For definitely more, everybody should use all these things only in most of the. This is Chanless retractor. Okay. That is the use of hip arthroplasty mainly when any surgery on the hip joint is definitely 100% is required. Otherwise, it is very difficult to approach into the deeper tissues of the hip. These are name. Yeah, see this one, Wittlinus self-retaining forceps. That's the hammer, okay, to drive out all the osteotomy, whatever K-wire or Steeman pin, whatever may be those things, is used for those things. And this is the plate bender. Name, plate bender files. So this is the It is a plate holding forceps, because this one is there, no, is given for the plate to hold the plate only. The plate holding forceps and giglisa. So giglisa, flexible twisted wise, especially in case of amputations, we're going to use sometimes in a craniotomy. And when you come to these are the usually implants, the most of them will be kept, and they will ask one or you take that one or two questions they will ask, and they come to the implants. As you know, the devices used to replace or provide a fixation of the bone or to replace the articular surface of the joint. In simpler words, orthopedic implants are used to assist or replace the damaged or troubled bone. That is the one thing. What are these things? Sorry? Steam and pin. So it's not the steam and pin, it is a K wires, Krishna's wires. Is given a bigger, magnified, that's all. So what are the types? They may ask. It mainly depend upon the end only. It is a trocar type and a diamond type. So will be there, one is the trocar type and the one is the diamond type. Indications, all will be there. When you get the tension, these things, they will ask where will you use. 100% everybody will going to tell the tension band. That is in a tension band, most of them 100% they will. When you say the tension band, 100% they will ask what is tension band. Anybody, can you define what is tension band? Sorry? That is a tension band principle. I am asking what is tension band. So those two things you should know. They will 100% they will ask. One is a tension band, another one is a tension band principle. Both are ended. The tension band is nothing but is a device which exerts the force, equal in magnitude but in an opposite direction. It is a device exerts the force equal in magnitude but opposite direction. Whereas the tension band principle, everybody know, it is a conversion of tensile forces into compressive forces on a asymmetrically loaded bone. Every word is important in this one. Conversion of tensile forces into compressive forces on a convex surface of asymmetrically loaded bone. That is the definition of tension band principle. They will ask these things. These things, Krishna's voice, these things, Danam and the steam and pin. Okay, both. Everybody knows that is the Danam spin, and these are the indications for a skeletal traction. All those things, trocar tip and will be there, and cylindrical, and that is a blunt opposite, that a quadrangular will be there, these things. Dynams, that is the threaded, especially in osteoporotic bone, to give the traction to prevent the early loosening of those things, in any cases, these things. Nail generation, they may ask, which are the generation we have now. It is we are in the third generation. What is the second generation? Always, this is the only, they are not anatomically, but they will have the first one is only the filling. That is a maximum stability only. No rotation. You should bang into the bone so that get a stability. That is like a K nail, V nail, what we are doing when we are doing PC. Whereas the second generation nail, it is a interlocking is there, but not anatomical. Whereas what we are having is a third generation, it is anatomical nails to the bone. What are these one? Tell me, anybody one recognize what is the first one? Tibia nail. Second one? Sorry? First? PFN. Second one is the PFN. Third one is PFNA. Good. Fourth is a femur nail only. Okay. Fifth one. It is a tibia nail only. It is an expert nail because multiple holes are there. All those things. Okay. See, those are the things. Tibia nail, PFNA nail. Okay. Femoral nail and expert nail. And these are the femoral nail. So this is anatomical one nowadays. What we have, anterolateral curvature will be there, and different length is for the fracture shaft, especially indicated in those things. What is this one? What is that nail? Huh? Recon, why? I will say it is a PFN. Sorry? So in a PFN, the screw sizes will be 6 and 8, these things. Whereas in a recon nail, it will be both are 6 mm only. And a curvature is different. That is a proximal curvature is a 7 degrees only. See this one? Recon nails, 6.5 mm titanium screws and 130 CCD angle. Anatomical anti-version is 14 degrees. That is the one thing. They may ask at this time what are its indications. How will you classify those things when you use these things? See, these are the AO classification. They may ask in the during when you come to the PFN those things. When you is indicated, it is indicated in almost all the types. Whereas you should see why this one. They may ask at that time because the DHS why it is failed, all those things, because depending upon these things you have to know this classification. That is AO classification. A1. This is the A2 classification. Sorry. This is the A2 classification and this is the A3 classification. And A1 and A2 classification, they may ask these things. That is very important. These things, see this one in the A1 classification, that is the further modification of A1. That is very important in the lateral cortex. So in the lateral cortex, these things can be treated in A1 fractures with a DHS also, because they are all stable fractures. Whereas when you come to the A3 fracture, A2 fractures, the lateral wall is less than 20.5 mm. That is the lateral, when the lateral wall, that is the different one. See how to measure that lateral wall means from the most prominent point of the greater tuberosity 3 centimeters below and draw a 135 angle, measure that one from to the fracture site. If it is less than 20.5 millimeters, it is always unstable fracture. These are the fractures, the contraindication for a DHS. It may look simple, but definitely the failure chances is 80%. If you do the A2 fractures, the immediately lateral wall fractures will take place and the failure chances is very high. That is that they may ask at that time, what is this nail? What is this one? What is PFN-A or PFN-A2? A2. What is left side? Huh? Normal PFN. That is then that is A1, A or PFN A2. A2. Then what is this? So this is PFN A, that is PFN A2. So that is PFN A. Okay, helical blade. Then the compression screw is here. I told you, that is the one 8 mm and 6 mm. So that is the things only. That is A, and these are the A2, A fracture and A2. This is for Indian population, Asian populations, because we don't have that much of lateral angulation, so that lateral wall impingement will be avoided by flattening of that is in the A2. Whereas the screw length is also reduced. That is, so these are the things. So proximal diameter in a is 17. A2 is a 16.5 mm. Length of the helical blade is also changed. And CCD angle is very important. It is available for this one 125, 130, 35. Whereas A2 is 125, 130. Angulation, that is the proximal angulation. That is the one thing. 6 and 5. That is A2. Both are same, absolutely remaining. All the functions will be seen. They may ask what are the things you wanted to see when you give these things in the X-ray to assess your post-operative X-ray. You have to see that one. And first and foremost is the reduction you have to see. Reduction is the first thing. Then the next is the entry point. That is entry medial to the greater trochanter, and the screw placement. That is the length of the screws you have to ask. Most of the times it is the compression screws they will ask. It should be about 5 to 7 millimeters from the or less than 1 centimeters from the subchondral area. And how to measure the lateral, that is the derotation screws, you have to draw from the top. That is from the top to the compression area where it cuts that area, that is the derotation screw length. Then very important, see this one, there is a lateral opening is there in the proximal these things. So in Indian populations on the table also, you may feel that one, it is a very good reduction, all those things, but there may be a split of the trochanter will take place. On the table, if you see that one for Indian populations, if you get a more than 100 mm, for the compression screw, please check once again because there may be an opening in the lateral wall. Otherwise, the one thing is you draw the line from the most lateral border of the ileum to this one. This should be in one line only. If it cuts here, there is a lateral opening of the trochanter on the table. You have to recheck that one because once this one lateral blowout will takes place, the failure chances is very high. See, these are the things. If you don't follow all those things, these are the things will takes place. That is, what is that one? First one is a Z effect, whereas the second one is a reverse Z effect. The Z effect is nothing but when you put both the screws are very equal. That is both the screws. That is the derotation screws and the compression screws. If the both are equal, thank you, sir. Both are equal, then this thing will happen. Why it will happen? Because there is no job for the compression screw. Both will take place by the derotation screws. But it is not meant for that one. It is only for the derotation, not for this one. Once it is taken, it goes inside, and the compression screw, there is no job for the compression screw, it will come out. Whereas this one, when you put too much of short derotation screw, both will taken place by the compression screw so that it goes inside. That is a reverse Z effect. That is the indications what I have told, all those things. And the tibia nail, when it comes to that, is the indications, there is not much. That is the PFNA, expert tibial nail and the DHS. Definitely they may ask some of the questions where indicated, I told this is the one thing. In a stable trochanteric fractures, always stable, where the lateral wall is more than 20.5 mm, see that one? The type 1 fractures all are indicated. They may ask what is the length of the barrel, what is the length of the Richard screw, when you will use the longer barrel, when you will use the shorter barrel. 100% they will ask when you get this one. When you will use? Anybody? See, these are the things. That is indicated in all those things. It is available in two lengths. The one is the longer barrel is 38 mm and a shorter barrel is, or a longer barrel or a standard barrel. Whereas the short barrel is available in 25 mm. When the Richard screw, if you require more than 85 millimeters of 85 mm, then use the longer barrel. If the Richard screw requires less than 85, use the short barrel. So those are the things. And when you use that one, that is the standard size is 38 and a short barrel is 25 mm. And when you are using these things, they may ask what is the tip apex distance, what is its importance. Definitely the cutout chances will be 100% for this one. If you don't use this one, and the failure chances is very high in a DHS. And when you come to this one, what is this one? Titanium elastic nails. They may ask who is the father of the this one, elastic nailing, tension band, what is TENS? Elastic nailing. Initially it was not by an elastic nail, it was used by the stainless steel wires. Okay. Huh? So these are the sizes will be available. They may ask what is the prerequisites for your what is that TENS nailing. So it should be the indications what I have told now, that it is either in the shaft fracture or a short oblique fracture should be there, because it is contraindicated in oblique fracture, and most of the times it is the age of the child, it should be 5 to 15. That is around 5 mm or 15 mm. Less than 5 mm, usually the medullary canal is very narrow, so you can't put a 2 wires. And if it is more than 15 years, the forces, the adductor or whatever may be the forces of the muscles cannot control these things. And how they will act? What is the principle? 3-point principle is everybody will tell, even in the interlocking also 3-point. What is that important mechanism? What is the prerequisites? So you should not use the different sizes. You should always use the same sizes only. That is very important, very, very important. And pre-bending is very, very important for these things, pre-bending. So how much you have to pre-bend? Wherever the fracture site is there take the measurement of the medullary canal, bend the 3 times of that medullary canal. If you overlay it, put that one and bend that one about 3 times. 3 times. How it acts? Because this is the very mechanism. Because when you put into this one, it try to straighten. Because you are already bent, it is elastic nail. So it tries to bend means it shifts the fragment to the opposite side. When you put the other nail, that will also shift that fragment to this side. So it is a neutralization of the displacement forces by the nail. That is the one thing, it neutralizes both the nails, neutralizes the forces by the other nail. So that is why it acts, thereby it controls the rotation, translation, bending, everything will be controlled. They may ask all those things when you get these things, these things. So this is the rush nail, everybody knows, and fibula fractures or forearm fractures most of the times. And rush nail, most of the times it is almost is out of the inventory because of the better availability of the locking plate, all those things. We are going to use these things. Square nails. Then they may ask into the screws. What is the parts of the screws when you give those things? You should know the head, neck, shaft, and they may ask regarding this one pitch. What is the lead? So what is the pitch in a cancellous screw? What is the pitch in a cortical screw? Because the cortical screws, because this is the cancellous screws, usually it will have a longer pitch, whereas the very narrow core, whereas the reverse is in a cortical, these things. So that is they may ask the cortical screws, different types, those things, and the different type of the 16 mm, 32 mm, where indicated, all those things. That is the very important things. They may ask all those things. And come to these things. That is the screws. That is the conventional screws and the locking screws. That is the sizes. They may ask all those things. And the locking and conventional screws. See, these are, what are those? These are butt screws for intra-articular fractures, scaphoid fractures, any intra-articular fractures are there, no? Where they will going to use. Then when you come to the plates, these are the plates. That is the types of the plates design, DCP, LCDCP. You ever heard this one, PC fix? It is the first locking plate used for the forearm bones. That is the only the 4-hole locking plate. It is like a LCDCP only. The pointed contact, this one is not this one. Even though it is a PC fix, it is a locking plate only, the first locking plate for the forearm bones. Only the 4-hole plate. They may ask all those things. That is the compression plate. The DCP, dynamic compression plate, they may ask how it will act, how to exert the tension band in this one. Because when you are putting this one on the convex surface, if you use the one side eccentric drill and another one the central guide, so that it compresses, so that on the convex surface it converted into compressive forces on the convex surface. So that is the one thing they may ask. So then next comes is the evolution is the LCDCP. Because of the avascular necrosis, because of the periosteal, all those things, they may modify it into the LCDCP to prevent the complete contact with the periosteum, so that to prevent the delay union or something, those things. That is the limited contact. What is this nail? Sorry, plate. Huh? Anatomical plate. This is not anatomical, okay, anatomical only. This is the first first locking plate done to the distal femur. It is not the locking plate. It is locking plate only, but not the classical what we have. The locking plate is not the locking. It is a list plate only. The difference of this one and that one, it has got only the locking holes. No dynamic hole is not there. So it is only the locking hole will be there, and unicortical cortex. That is the list plate, and unicortical screws will be there. That is the list plate always. So that is usually it will not. This is the locking plate only. Thus it consists of both. That is the list and the dynamic. See, list hole is that is the one locking hole, and the dynamic hole is the compression. This one. That is why they may ask LCP locking. You see, Richard Wagner is the first person, he coined the name of locking plate. It is nothing but the combination of DCP and the LIS. Both are combined and present day locking plate is there. That is the two holes are there. One is that one DCP hole will be there, one is the LIS hole will be there. In that one only we are going to get both the combi hole of locking plate. That is the combi hole we are going to. When you get the locking plate, definitely they will ask all those things. So that is a single beam construct. So what is its biomechanical principles? So this is a single beam construct. That is why it gives a maximum stability. And the fixed angle device, they may ask what is that one biomechanical principles. Each screw will going to lock into the plate, that will become say one beam. So like that only all the beams will give increases the compression in the locking plate. Like that only the load transmit. Why it will fail? Chances because the load transmission is not like in a compression plate. That is going to plate like that only, where here from the screw to the bone again to the screw. That is why the screw is not subjected to the tensile forces, it is subject to the bending forces. That is why the failure chances are very less in a locking plate. And N block fixation. Now each fixed angle gives a maximum stability, that is N block. Even angular stability, because in the direction, different directions, we are going to get all these things. And say N block failure, even with the locking plate, it won't fail as a single screw. If at all it fails as a unit only, complete unit only. That will take a longer time to fail. That is why the advantage of the locking plate. And the locking indications, as you all know, this osteoporosis, short metavascular articular segment for periprosthetic fractures, minimal, very important, is the minimally invasive. This is the rapid round. Diagnose and tell me the fast first. What is this nail? Sorry, plate. Fast. Is a distal femur plate. Distal femur lateral plate. What is this one? Fast. Is a lateral tibia plate. Okay. What are these plates? What is first one, second one, third one, fourth and fifth? Second one clavicle. What of the first? It is a medial tibia plate. Okay. Second clavicle. Third is the locking DCP. Then fourth is proximal humerus plate. And again the distal. What is that plate? It is an anterolateral tibia plate. Okay. This is the distal tibia anterolateral plate. What is this plate? Is a posterior proximal tibia plate. What are these? Is a variable angle distal radius plates. That is the clavicle plate. What is this plate? Distal humerus lateral plate. What is this? Calcaneal plate. What is this? They may ask what are the A, B, C, D, E, F. What is its importance? What is the A? What is B? What is C? And what is D? What is E and F? A is parallel, B is divergent, C is convergent, D is central, then E is calcar. Very important. These are the things, that is why the philos is so important. Thus, what is this plate? Is a medial tibia plate, proximal. What is this one? These are the things will be there on the table. That's why I am telling all these things. What is this one? Proximal trochanteric plate, femur trochanteric plate, the olecranon plate, and lateral clavicle plate. This is also lateral clavicle hook plate. What are these? How will you differentiate? Where it will be? In which processes? Osteomore will be there. So that is the thing. Osteomore plus the fenestrations will be there. Whereas the angulations will be more in that one, in a Thompson's processes. And bipolar processes, usually the THR, that is the components of the THR. Bipolar and the. So thank you.
Thank you, sir. Dear Prakashappa sir, for wonderful explanation of the implants. I think any doubts, read out from the books. Okay. Thank you for coming. Thank you one and all the faculties. From the PG committee member, Sir Gupta sir, and OSS President Srinivas Reddy Garu sir, and Prakashappa sir, and my colleagues, HPR sir, and all my students and residents. Thank you one and all. Have a blessed day. Okay, thank you. We'll meet again. Thank you for Ravi audio visual people. Thank you very much.